పెట్టు గురు. అయితే రెండో హ్యాండ్ మైక్ ఎమ్మరు 2 ఉన్నాయిగా, ఇది పని చేస్తాను. ఇప్పుడు మాట్లాడు. పరమానంద శిష్యుడా, రాజేష్ పడుతుందా నీకు? ఇంకో 2 మైకులు ఉన్నాయి. ఒక మైక్ ఇంకో మైక్ మాట్లాడు. అది కాదు, ఇంకొకటి, ఇంకో మైక్, ఇంకొకటి, ఇంకో మైక్ మాట్లాడు. ఇంకొకటి 2 మైకులు ఉన్నాయి. ఫోన్ చేయాలి. మీ అమ్మాయి ఎవరో రే, ఆ మైక్ ఉంచుకోరు. అది కాదు, ఆ మైక్ పనిచేయట్లేదు స్లాట్. ఇంకో మైక్ తీసుకుని మాట్లాడవేంటి? పిన్ను గురించి కాదు, ముందు దాంతో మాట్లాడు. అదన్నా వస్తుందో రావట్లేదు. నువ్వేం చెప్తావు? అది రావట్లేదు, దాంతో మాట్లాడని చెప్తున్నా. ఆ మైక్ లో మాట్లాడు గురు.
ఇప్పుడు ఇదో మైక్ అదో మైక్
ఆయన తీసుకురామని అడాప్టర్ తీసుకురామని. అడాప్టర్ నువ్వు ఆ మైక్ ఆన్ చేసి హలో హలో నచ్చి తిరుగుతా మాట్లాడు.
ఓకే,
ఇంక జాయిన్ అవ్వాలి. మన ఆడియో అనుకుంటా. సిరీస్ ఎంత అయ్యి
యాంప్లిఫైర్ కావాలా కొంటారు ఎవరన్నా? యాంప్లిఫైర్ కావాలి కొంటారా అడుగుతున్నా.
ఆడియో చెక్ చేసుకున్నారా?
చెక్ చేసుకుంటే ఒకసారి ఓకే
అది ఓకే, ప్రాబ్లం ఏం లేదు.
ఇది ఇచ్చాను
ఇక్కడ నుంచి ఇది మన వాయిస్ ఎంత క్యాప్చర్ చేస్తా ఉంది ఇది?
నేను రెండు ఇచ్చాను, ఇన్ అవుట్.
Hello, hello. Hello, check. My testing 1, 2. Ladies and gentlemen, welcome to Astram Medical College. IMA APCON on 20th and 21st November 2021.
Hello, hello. Hello, testing. 1, 2, 3, mic testing. Right now? Hello, hello. Hello, hello. Hello. Akada. Hello, 1, 2, 3. Hello, 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 hello. Hello, testing. Hello, hello. Hello, hello, hello. Hello.
మదన జూమ్ కాల్ లో ఆడియో చెక్ చేస్తాను కదా రిటర్న్ చెక్ చేయండి.
హలో హలో
సార్ ఫ్లాషెస్ ఎత్తుకొని కాదు
సార్ ఒకసారి మాట్లాడండి సార్.
హలో గుడ్ మార్నింగ్. నీ పేరేం పేరు? సుప్రజ్ రెడ్డి. నేను ఒకసారి దీనికి వచ్చాను, జూమ్ కి టెస్ట్ ట్రయల్ రన్కి వచ్చాను. ఒకసారి మీ వాళ్ళని రమ్మను. అనీషా పచ్చ అని ఉంటుంది, దాన్ని అలౌ చేసి నేను ఒకసారి చూసుకుంటాను నాది. అనీషా పచ్చ. వచ్చింది బాబు? కాదు, నాకు కనపడుతుంది ఇక్కడ ఆశ్రమ్ భక్తవత్సల్ రెడ్డి ఐఎంఏ టెక్ టీమ్ కనెక్ట్ అయింది. నేను ఒకసారి స్లైడ్ షేర్ చేసుకుని చూస్తాను. నేను వీడియో స్టార్ట్ చేసి నా ఇది వినపడుతుందా అక్కడ? చెక్ అండ్ ఐ విల్ స్టార్ట్ మై వీడియో. నేను స్క్రీన్ షేర్ చేస్తాను, ఒక్క నిమిషం ఉండండి. హనీ, 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 ఒకసారి అది ఇది షేర్ చేయాలి సార్. కాదండి, ఇది మిగతా ఎందుకు పెడుతున్నారు షేరింగ్ కి? స్పాటిఫై ఇదిగో నేను డెస్క్టాప్ షేర్ చేయాలి.
No one put that. You only press something.
స్క్రీన్ షేర్ స్క్రీన్ అంటే దీంట్లో ఇది కావాలండి. ఐ వాంట్ టు షేర్.
No, what you want to?
IMA ఏలూరు IMA ఇది
Ask them if they can see it.
హలో, హలో, హలో. అది ఇక్కడ షేర్ చేయాలా?
It's sharing. That means you have to just read it from. You can see it.
అది
Just unmute here and ask them if they can see it.
ఏది అన్మ్యూట్ ఎక్కడ చేయాలి? హలో, గుడ్ మార్నింగ్ IMA. వినపడుతుందా? ఓకే, ఓకే. సో జస్ట్ ఓకే, ఓకే, షూర్, షూర్. అట్లయితే పర్వాలేదు. దెన్ ఫైన్. ఐ విల్ కమ్ 1 hour before the thing. It's on my name only, Rajnikant Pacha. I'll come just before.
Hello. So, good morning, everyone. Good morning, and a warm welcome to you all, the dignitaries, the faculty, the guests, and all the students who are attending this 6th IMA State AP Conference. On behalf of the organizing committee, we extend a very warm welcome and thank you all for attending, and hope we will all succeed in hosting a grand event. So, I'll have the pleasure of introducing the first session. Starting will be, I think we are late by 10-15 minutes, but I think we'll see that things go on schedule. There's a delay because of a slight change in the first talk itself. So it was originally supposed to be given by Dr. Raja Kumar, Prasad Kumar Garu. So he could not, he's indisposed. So another talk in the same topic by neonatology by Dr. Raja Ashok Garu will commence. So now I invite the chairpersons of the first session, Dr. Seshaya Garu, Professor of Medicine, Ashram Medical College, Dr. Tamiraj Garu, Cardiologist, Ashram, and Dr. Ravindranath Garu, Pediatrician from Eluru. Sir, please come on to the dais, sir. Ganesh. So now I invite Dr. Ravindranath Garu, pediatrician, to introduce the speaker, first speaker of this August scientific session, Dr. Raja Ashok Garu. మైక్ అక్కడ ఇవ్వాలి కదా.
Good morning and welcome to this session on neonatology. The topic is recent advances in neonatology. At present, neonatology is a fast-growing branch. We have even 22-week preterm babies surviving, even less than 500 grams of babies are surviving. And there are so many advances coming up in neonatal ventilation. To deal this topic on recent advances in neonatology, we have Raja Ashok Koganti, Dr. Raja Ashok Koganti from Anu My Baby Hospital. To introduce him, he did his graduation from MBBS Osmania, post-graduation from AIMS, PG Postgraduate Institute of Chandigarh, and he is now a consultant of neonatology in Anu My Baby Hospital. To his credit, he has published so many national and international publications, and he's a mentor and a teacher, and he has conducted so many programs on NRP training programs. So with this few introduction, I request Dr. Raja Ashok Garu to start this session and to present his slides.
Thank you, sir, for the kind introduction, and a very good morning to all dignitaries. And I'm very excited to be here, and this being a physical conference after so long, it It's actually very exciting to speak in front of an audience now after the COVID era. So without much delay, I'll begin my topic. So the topic I've chosen to present here is recent advances in neonatology. So even though I see an audience from diverse backgrounds, mostly physicians probably, and super specialists from adult branches, I'll try to keep this as broad as possible and so that everyone is involved. And I would like this session to be interactive. You could stop me anytime and I'll be really happy to take up questions. Okay, I do not have any conflict of interest to disclose. So just to begin with history before we go with advances. So how did actually neonatology begin? So this very thing, made news in the US in 1960s when the then president of United States, Kennedy, he had a baby boy, and that boy was born at 34 weeks with a weight of 2.1 kilo. Unfortunately, the baby died at an age of 2 days. And the baby was in fact 2.1 kilo and 34 weeks. So by today's standards, that was pretty good weight and pretty good gestation. But unfortunately, that baby couldn't make it. So that baby had difficulty in breathing, which was later diagnosed to be hyaline membrane disease, what we call now. And at that time, US did not have neonatal ventilation, nor was surfactant, available commercially. So after this, what happened was that the NIH increased funding, for neonatal care, and that actually sparked off the growth of neonatology. And right now, we are at this place talking about the recent advances. So how did neonatal care evolve? So before 1950s, ironically, the obstetricians were the ones who took care of the newborn babies. Pediatricians were not even in the picture. So after that, in the mid 50s, pediatricians took interest in the care of newborn babies, and they actually started attending deliveries and taking care of babies. But the interventions that were done were actually heroic. They were not evidence-based, they were just on a trial and error basis. So after 70s, the practice had been experience-based. And in the 21st century, now we practice evidence-based medicine. And today we are in the futuristic era where neonatal care is advancing at a very, very rapid pace. So unlike other specialties, neonatology is a specialty which is confined to an age limit. Like a neonatologist deals with babies who are less than 28 days. So basically, a neonatologist is also a neurologist. He's also an ophthalmologist. He's a cardiologist. He takes care of nutrition. He's also a nephrologist. There are metabolic, endocrine, skeletal problems that we deal with newborns. And there are a lot of things happening with perinatology and resuscitation, sepsis, skin. And of course, this social neonatology also involved, like family support and kangaroo care. So that makes neonatology a very diverse branch, and it includes all specialties within it. So that makes this job even tougher. The recent advances that happen, they are happening at each subsystem level. For example, in perinatology, we have the artificial placenta or the womb that is being developed. In resuscitation, we have something called the physiologically based cord clamping. Respiratory system, we have the newer modes of surfactant administration. And as Sir said, we have newer modes of ventilation that are there. We have made huge strides in functional bedside echocardiography. In neurology, we have therapeutic hypothermia, erythropoietin, and AEG bedside monitoring. We have switched to probiotics use for NEC and special type of lipids when we provide parenteral nutrition. And we've also made progresses in renal replacement therapy. We have used newer diagnostic methods to diagnose sepsis in newborns and so on. So because of time constraints, I've selected some topics to discuss today. So I'll be touching upon and I'll be giving you a very brief glimpse about artificial placenta, about physiologically based cord clamping, about the newer techniques of surfactant administration, about hypothermia, EEG, newer diagnostics in sepsis, and about stem cells. So I have structured my talk about all these advances in three headings. I would first be telling about the recent evidence, then why is this even required, and how does it work, and what's the current status of these latest developments. So to begin with, the first thing I'd like to discuss in the perinatology is artificial placenta. And actually this sounds very exciting and almost like a sci-fi movie. Artificial placentas are designed to mimic functions of a native placenta. You know, they work on a principle of extracorporeal life support, and they improve intact survival of periviable births. So if this artificial placenta, if this becomes a reality in the next 10-15 years, you know, the role of neonatologist could even come down. So these are the number of citations that have been quoted in PubMed. So as you can see, over the years, the number of citations on artificial placenta have increased drastically. However, when it comes to newborn, there are many technical limitations when it comes to artificial placenta, because the vascular access to provide an extracorporeal life support in a newborn is extremely difficult. And these babies are at a high chance of sepsis, and they go into progressive circulatory failure. So this is actually a line, it's a model about how an artificial placenta works. So this was an experiment that was conducted about 4 years back in Cincinnati, US, and it has been published in Nature 2017. So as you can see, you find a lamb, it's a preterm lamb equivalent to a human fetus, about 24 weeks, which is being nursed in an amniotic fluid band, and the required oxygen concentration and the nutrition is being provided. So the difficulties that we face when we do this is that because other than, in contrast to the extracorporeal life support that we provide in adults, the one that we provide in newborns, it should use a pumpless circuit. Because if you have a pumped circuit, or if you have a circuit which has high resistance, it increases the afterload and it can cause CCF in the fetus. And the sterility issues, are very, very tough to maintain in newborns. And as I mentioned, the umbilical vascular access to maintain in newborns, that too in a 22 to 25 week fetus is very, very, very difficult. So this is a lamb model, it's in a, which was experimented. So this actually preterm lambs, they have a gestation of 150 days. So this is a lamb of 111 days, which is equivalent to a human fetal gestation of 24 weeks. And this is the lamb after 4 days of cannulation on the artificial placenta. And this is after 28 days of cannulation. So as you have seen, you can definitely make out that the skin maturity has improved. And of course, once these lamb models were sacrificed, then the lung, brain, and somatic growth have been normal, and the liver and kidney function have been normal. So we have miles to go before we implement this in human fetus. And if it comes into picture, we would have fetuses less than 25 weeks surviving very easily, and fetal surgery and interventions would be possible. But a challenge that would remain is that human brain maturation is different, and it cannot be extrapolated to that of a lamb brain. And of course, the ethical issues would remain. So we have miles to go before this advancement actually comes up into picture. So the second topic about the second recent advances that I would like to discuss is about the physiological based cord clamping. So once a baby is born, the first step, if the baby cries, is to cord the clamp and hand over the baby to the pediatrician. So traditionally, what used to happen is the cord used to be clamped immediately. So that practice has changed after the NRP and the ILCOR guidelines have come up. So they recommend delayed cord clamping, that is 30 to 60 seconds. So now the recent advance is that they're recommending physiologically based cord clamping. That is, cord clamping should not be time based, but it should be event based. So what is the event? So clamping after establishing spontaneous breathing or adequate lung inflation is actually the time when you clamp the cord. So why is this helpful? So I would like to briefly touch upon the physiology. So for example, there is a preterm infant and the baby doesn't breathe. So that would cause decreased pulmonary inflow and decreased venous return. So that would lead to decreased left ventricular preload, and that would cause unstable cerebral blood flow. So what if hypoxia-based blood clamping occurs? So it would cause increased LV preload and cardiac output, and basically this would lead to a smoother transition to extrauterine life. So the evidence is that if you do physiologically based cord clamping, the time for respiratory stability is shorter with no major adverse effects. There are a lot of ongoing studies on this topic, and this is actually a hot topic which would come up in the next 4 or 5 years. And we are eagerly waiting for the results. And with the results, you could soon have a change in the guidelines of neonatal resuscitation, where we would probably shift to physiological based cord clamping. So this is the current recommendation, which is given by the International Committee on Resuscitation, NRP 2020 update, where it says that there is insufficient evidence to recommend early cord clamping versus delayed cord clamping for term and preterm babies who require resuscitation at birth. For babies who cry at birth, there is no ambiguity. You have to delay cord clamping for at least 30 seconds. So that takes me to the next system, the respiratory system in neonates. So because I have audience from diverse background, so you all must be aware that newborn babies are surfactant deficient when born preterm, and that leads to a condition of hyaline membrane disease. So surfactant has been traditionally administered to the newborns exogenously. These artificial surfactants have been preferred. So the recent advance is that there is a technique called less invasive surfactant administration. So traditionally, newborns for surfactant administration, traditionally they had to be intubated. Surfactant was given, and the ventilation was continued. So that practice has changed over the last 15-20 years to ensure. So ensure stands for intubate, give surfactant, and then extubate. So the recent advance is that you don't have to actually intubate to give surfactant. So the newer technique is that surfactant can be administered through an aerolized route. You can give the surfactant into the pharynx of the baby. You can give a surfactant through a laryngeal mask airway, or you, instead of intubating, you could just introduce a thin catheter into the trachea and you can give surfactant. So I would be concentrating on the fourth technique, that is introducing a catheter in the trachea, and they have been given a lot of fancy names like the Cologne, Sonosure, Hobart, etc., etc. But I would, to simplify that, I would be talking about two things, that is LISA, which is called less invasive surfactant, and MIST, which is called minimally invasive surfactant. So less invasive surfactant is a technique where you introduce a very thin catheter and you introduce into the glottis of the newborn using a Magil forceps. In MIST, you wouldn't even use a Magil forceps for that. So these are the different options by which you can give a surfactant. To the extreme left, you can see an ET tube with which a surfactant is given, and to the right, you can see specially designed LISA catheters. So this is a LISA catheter with which you give a LISA technique of surfactant. So this was how we gave surfactant for a baby at our hospital recently. So I'll just play the video for you. So in this, my colleague, he's visualizing the glottis using a laryngoscope, and the baby is on CPAP. The CPAP hasn't been discontinued. And this is a syringe that you find here, and it has been loaded with surfactant. And he's introducing, a 6 French feeding tube into the baby's glottis under vision. And he's trying to manipulate it using a Magil's forceps. And once it is in the glottis, so So he has introduced into the glottis. So once into the glottis, he actually removes the laryngoscope where you find here. So he has closed the mouth and he's injecting the surfactant using a syringe. So this technique actually saves intubation and leads to better outcomes. So what is the evidence? So this is a a meta-analysis that was published, and so as you can see, this is a forest plot in which you have the diamond which favors Lisa with a risk ratio of 0.75. So with Lisa, you have a 25% reduction in death and bronchopulmonary dysplasia. So what interventions decrease bronchopulmonary dysplasia in a newborn? To address this question, a network meta-analysis was conducted, and you can see this network plot. I would not like to go into the details, but a lot of interventions were compared, like CPAP, Lisa, Insure, mechanical ventilation, etc., etc. And they came up with a ranking and a SUCRA that is probably reported in a network meta-analysis. And as you can see, Lisa is ranked #1. So probably it is the best bet where you can avoid bronchopulmonary dysplasia in preterm newborns. Next thing is the newer mode of ventilation that has come up. And as Sir was mentioning, these days, volume target ventilation is the norm in newborn ventilation. Many of the anesthesia colleagues sitting here might wonder, like volume control ventilation, we have been practicing since ages. So what is so new about this? But volume target ventilation is different from volume control ventilation, wherein volume target ventilation is a hybrid mode where the ventilation is basically a pressure control and a volume target. And this actually runs like an autopilot, and it decreases the volume trauma to the newborn lungs. So the evidence is that volume target ventilation led to a 27% reduction in death or BPD in preterm newborns. Next, we have neurally adjusted ventilator assist called the NAVA, where the electrical signals from the diaphragm are picked up and that transmits to the ventilator. So this results in perfect synchronization of the initiation size of breath. So I'll just skip this to maintain time. Next is the cardiovascular system, where I'll be discussing about the shock management in newborns, the recent advances that have happened. So this is the traditional algorithmic approach of shock management that has been practiced in newborns. And if you ask an updated neonatologist, he would say that this is no longer practiced, because the shock management in newborn has to be tailor-made. And right now we are so much dependent upon invasive BP monitoring and point of care bedside echocardiography, to titrate boluses, fluid, and the choice of inotrope as well. So this is a brief modification of the algorithmic shock management which has happened. And the way we proceed forward these days in modern NICUs is with bedside echocardiography monitoring. And we actually see if the systolic BP is affected or the diastolic is affected. So based on that, we have a choice of inotropes that we have to make. So we are basically shifting away from the algorithmic approach of shock. So next, coming to sepsis and infectious diseases. So when it comes to sepsis, we were traditionally taught that blood culture is the gold standard for diagnosis of sepsis. But unfortunately, in newborn, culture negative sepsis account to 57% of the total newborn sepsis episodes that happen. So I'm quoting data from the Dennis study, which is a landmark trial conducted by the AIMS group in New Delhi. So as I said, culture negative sepsis in 60 to 80%. So what is the gold standard of sepsis and how do we diagnose? So molecular markers in sepsis is the hot topic these days. So we are slowly shifting towards an omics approach in diagnosis of sepsis. That is, we are relying on nucleic acid amplification techniques, about genomics, about proteomics, and the latest advances. So these are the emerging molecular techniques that we are following for sepsis diagnosis in a newborn. So they have a pretty good sensitivity and specificity, although the quality of evidence is low to moderate. But I would say the sensitivity and specificity is reasonable. And for now, we could use them as an add-on approach, provided we have the facilities. So just to speed up things, amplitude EEG for seizure detection. This is also a latest technique. And this is a baby which is undergoing amplitude EEG in our NICU for neuromonitoring. So this was a baby that we recently had with encephalopathy. So we connected an EEG monitor for seizure diagnosis and prognostication. So a recent advance in seizure definition in newborn is that ILA, that is the International League Against Epilepsy. It has recognized that the diagnosis of neonatal seizures is difficult. Even with experienced neonatologists, the inter-observer agreement for the diagnosis of seizure is very, very, poor. 50 to 80% of neonatal seizures are only electrographic. There are no clinical manifestations as such. So the ILA came up with an algorithm which gives a lot of weightage to EEG, bedside EEG monitoring. So as you can see in this flow chart, seizures with EEG correlate, and they have been classified as electrographic only and electroclinical, with clinical sign. And the clinical sign in newborn are very, very, very subtle. Like you just have boxing kind of movements. You have lip smacking or eye twitching movements. The classic tonic-clonic movements are very less. I'll just take 3 minutes before I end. So we also use AEG for prognostication. For example, this is a baby where we were using AEG to prognosticate, and we see the burst suppression pattern on AEG. And this baby on MRI had extensive infarcts, and we could prognosticate the baby that the baby would have very poor long-term neurological outcome. So next, coming to therapeutic hypothermia. Therapeutic hypothermia is an intervention which is used to decrease the morbidity because of birth asphyxia. We artificially cool the baby to a temperature of 33.5 degrees. This is recognized as a standard of care in high-income countries, and there is a Cochrane review which says that decreased neurodevelopment. However, in an LMIC context, after the recent Helix trial, there is a confusion if it would work in our setting, because the etiology of asphyxia in our setting is a bit different. Next is stem cells. I'm sure stem cells is a recent advancement in all other branches as well. But in neonatology, stem cells are very promising for bronchopulmonary dysplasia and hypoxic ischemic encephalopathy. So there is work in progress and a lot to continue. Thank you very much for your kind attention. And I acknowledge my team members, Dr. Anusha, Dr. Guru Prasad, for helping me to support and make these slides. I'll be happy to take up questions. Thank you, sir.
Thank you, sir. Thank you for your wonderful presentation, sir. You have nicely touched upon the recent advances, starting from the importance of the delayed cord clamping based on the baby's condition, and then how to the neuro implementation of ELISA and MISA do surfactant therapy, and amplitude AEG in case of seizures, because most of them are echocardiogram, and the importance of the changing treatment modalities in during shock, and most of the topics, recent topics you have covered. With these few words, I invite the audience, if there are any questions, please ask the speaker. Sir, in one question in sepsis, the recent molecular studies, with molecular studies, the antibiotic susceptibility will not be there, no? So that is the drawback of the molecular.
Yes, sir. Still, that's a drawback. I agree with you, sir.
If there are no questions, we'll wind up this session.
Yeah. Thank you very much.
Thank you, sir.
Thank you, sir. Dr. Ashok Garu, for your wonderful presentation on neonatal advances. Please accept a memento on behalf of the organizing committee. I request Dr. Seshaya, sir, to hand over a memento to the speaker. And for the benefit of the audience, this is a conference first time being conducted on a virtual mode and also a physical mode, a hybrid conference. So there are about nearly 1,500 delegates have already joined onto the. So already 1,500 delegates are already virtually logged into the conference. They are going after this thing. So we are bound by time. So let us stick to the time. The speaker's small request is, sir, kindly be on time and see that the talk does not exceed your limit. Thank you.
Okay.
So the next talk would be a topic on cardiology, heart palpitations. I request Dr. Tamaraj Garu to introduce the speaker, and he'll be joining virtually.
Hello.
Good morning, one and all. So I'm very happy to introduce Dr. C. Bhaktavatsal Reddy, sir. He did his MD Pediatrics from Kasturba Medical College, Manipal, and DM Cardiology from NIMS. He's actually senior in NIMS for me. And presently he's working as consultant interventional cardiologist at Apollo Hospitals, Nelluru. And his topic is actually regarding palpitations. So palpitations is generally a very vague complaint. It's like a fever. Just palpitations could be due to anything. So, and most of the times it could be non-organic also. So the most but there are some causes which regarding palpitations, which can be detrimental in some situations if you are not given proper care. So with this short introduction, I hand over the topic to Dr. Bhaktavatsal Reddy.
Hello. Good morning. Am I audible to you, sir? Hello. Am I audible to you?
Yes, sir. Audible.
Yeah. Thank you. Thank you for the IMA and organizers at my Apollo Hospital for giving me this opportunity to have an interaction with you all. After that very nice lecture by my previous colleague about recent advances, I want to touch upon the more basics, because after the COVID started, our OPDs, 20 to 30% of OPD complaints are palpitations. As our colleague cardiologist has said, it's a vague complaint. So usually we don't bother about what is palpitations, and it's a part of the disease and all the things. But the COVID era, we almost 30 to 40% of my OPD patients are coming up with palpitations who are recovered from COVID. That made me to choose this topic to give an enlightenment about and to share my knowledge and to get knowledge from all of you about the basic concepts of palpitations. And the recent past, all of you has heard that the Kannada actor, icon actor, the Punit Rajkumar has died within the young age. So many of young people have started coming to the cardiologist OPDs with the complaints of palpitations, most likely anxieties. But our being a clinicians, our worry is, are we missing something? Are we missing something? That question always evades the brain. So with this, I just want to start my topic. What is palpitation? It is an uncomfortable awareness of heartbeat or undue awareness of heart actions. Two things are really made a man suffer is, one, if you are aware of your breathing, it is very difficult for the people to tolerate that complaint. At the same way, even though not that much, if you are aware of the heartbeat, of your own heartbeat, it means that you are having some either anxiety or some issue or physiological or pathological disturbance, which can be defined as there are so many ways of description of this complaint by the patients, like thumping of the heart, pounding of the heart, or fluttering sensation in the chest. This sensation can be either intermittent or sustained, and either regular or irregular. So the commonly palpitations is due to alteration in the heart rate. Every one of us would have experienced the palpitations after running or after anxiety, after whatever, maybe some hearing some news or whatever. That can be alteration in the heart rate because of the sinus tachycardias or bradycardias, which can also feel that they can feel their own heart beating, especially in the nights. And more commonly, alteration in the heart rhythms, we will go in detail in the succeeding slides, are augmentation of myocardial contraction, which can be because of the anxiety states or drugs. So most commonly, the cardiac causes are the next is psychiatric causes, other is the miscellaneous, and most of the times we may not be able to find out the cause, that is unknown causes. So there are, if you come to the differential diagnosis of palpitations, there are so many causes that we have to think as a clinician, especially arrhythmias which are life-threatening, from starting from atrial fibrillation to bradycardias to multifocal atrial tachycardia, sinus tachycardias, commonly supraventricular tachycardias, or in sick patients ventricular tachycardias, or the psychiatric causes like anxiety disorders or panic attacks, and who are on medications like bronchodilators and the digitalis, or the common coffee can cause, or the smoking habit, and then that is tobacco, or the commonly who had binge of alcohol, and the other also who are suddenly withdrawn from the beta blockers. These are so many drugs and medications which can cause the palpitations. The other non-arrhythmic causes of cardiac disease, if they have some structural heart problem, which can lead to the increase in the heart rate and sympathetic overdrive, which is the cause of the palpitations. The common causes that physicians will come across is the anemia. This is the first and foremost thing is, if somebody's heart rate is high, always check the hemoglobin first. And the other thing is electrolyte imbalances, fever, other common causes, fever, hyperthyroidism, and in commonly diabetic people who are complaining of palpitations, first we should think about the hypoglycemic episodes, or the rare causes of pheochromocytoma, or some episodes of vasovagal symptoms after the extreme vagal response. The exaggerated, after the vagal, exaggerated sympathetic drive will lead to the increase in the palpitations, increase in the heart rate, which can be felt as the palpitations. So how do you predict the cardiac etiology? Usually common in male sex are the description of irregular heartbeat, or the history of heart disease, and the event duration more than 5 minutes. If anything, any 1 or 2 or 3 indicates more predictors of cardiac problem for the palpitations. The other psychiatric problem are panic attacks, anxiety states, somatization, or depression. Usually they report a longer duration of sensation, more than 15 minutes, and the young and disabled, and multiple non-specific complaints. In my practice, commonly I have seen thin-built females or the heavy overweight males have the common problem of these palpitations, especially because of the anxiety states. Other miscellaneous causes are hyperkinetic circulatory states like anemia, fever, thyrotoxicosis, hypoglycemia, are the common drugs of aminophylline, or high doses of thyroid for the hypothyroidism. If they don't check the thyroid levels, proper TSH levels, or the T3 and T4, and if they take high doses, which can lead to the palpitations. And the other is drugs like I discussed, caffeine, tobacco, and alcohol are the more other causes. So other things are like physiological exertion, excitement, and the pregnancy, or other vasovagal attacks. And sometimes the skeletal muscle contractions can be felt as the palpitations in the patients. So when we look at the patient with the palpitations, first thing we need to see is how serious it is. If they are associated with giddiness or the near syncope, we always need to evaluate them for the suggestion of any arrhythmia, associated life-threatening arrhythmias. So why do we need to evaluate these sort of patients? Because to eliminate the symptoms, for it is very easy for us as a clinician or the doctor to sit and then say, it is nothing, just it's an anxiety, but that complaint is still there for the patient. It has to be reduced. So first is to eliminate the symptoms, or the prevent imminent death or hemodynamic collapse due to life-threatening arrhythmias, or the reduce the possible risks other than the arrhythmias. That is, if it is irregular, always try to give an anticoagulation to reduce the thromboembolic phenomena. So if whenever you see a patient with the palpitation for the first time, first thing is we need to, is the arrhythmia causing symptoms? Does the arrhythmia pose a risk to the life of the patient? Which type of arrhythmia is present? Does the arrhythmia require emergent cardioversion? Does the patient require urgent hospitalization? Is specialist consultation is required and referred to a higher center? These sort of things should come into the mind. So what is the diagnostic evaluation? Mostly we need to put our effort in the history to diagnose the thing. So in the history, age of onset and the description, whether it is rapid and regular, which suggests supraventricular tachyarrhythmias or the ventricular tachycardias, rapid and irregular, which goes more in favor of atrial fibrillation or flutter with variable blocks, or flip-flopping like atrial and ventricular premature beats, and rapid fluttering, pounding in the neck, which can be seen as in the AV dissociations or the complete heart blocks. And also the main thing that we need to ask this, which is with the onset and offset, whether it is sudden in onset, or the gradual increase in the palpitations or the tachycardia and the gradual decline. This gives an immense clue, because abrupt onset and offsets gives the clue of VTs and SVTs. Gradual onset is more in favor of sinus tachycardias. What is the mode of termination? Like in Valsalva maneuver or other vagal maneuvers, if it terminates, it is most likely because of the PSVTs. And the positional palpitations, like the palpitation upon standing up or straight or bending over and even lying down, AVNRTs, are some rare cases of myxomas which can cause positional complaints, and the intermittent pounding sensations, more of atrial or ventricular premature beats. And the other associated with other symptoms will come in the next slide. And the palpitations of psychiatric causes, younger and disabled patients, more somatization, and palpitation duration more than 15 minutes, accompanied by other complaints and more visits to the ER. And of course, we need to go through the medications list. All palpitations are not arrhythmias, but many arrhythmias may not have the complaints of palpitations. So first is the key questions are onset and offset, whether it is sudden or gradual, duration, momentary or sustained, frequency, what is the frequency of palpitations are they getting, triggers, which is triggering the event, that we need to analyze, and then associated symptoms like pre-syncope or syncope, breathlessness, chest pain, and other associated cardiac history, which is the previous cardiac structural cardiac problem is there or not. So first thing is, as the palpitations continuous or intermittent, that gives more of the clue, because if there is an ventricular premature beat, post-ventricular premature beat, they will have an increased ventricular end diastolic dimension following the pause, and then increased sense of contraction, which patient can feel as a palpitation. So, and the regular and irregular, and what is the heart rates? Usually the sinus tachycardias, usually 100 to 120, and the PSVTs can go up to 150s, 160. For physiological purposes, for theoretically to say, AV node to conduct, it cannot conduct more than 195 beats in a minute. So it should be less than 100, but even then that much rate is very, very rare, even if it is AF or PSVTs. So were there any associated symptoms that we need to analyze? That is, if there is an associated chest pain, dyspnea, syncope, and there is a polyuria, sweating, and the diarrhea, which can give a clue that there is some associated abnormality which is causing the symptoms of, which is causing disturbance to the patient to feel the palpitations. Then are there any precipitating factors like exercise, stress, and intake and drugs, and the positionals, and are there any history of structural heart diseases? All these things you need to spend detailed time to analyze the history. So sometimes if the educated people can explain the tachycardia, like when we were students, our professor used to take the rhythmic, the way of describing the palpitations. Most of the patients will describe the palpitations by a tapping method. So in brief, what are the things that we need to see, the clinical findings? Single skip beats or benign ectopy, unable to catch one's breath is ventricular premature contractions, and also sounding sensations, Rapid regular pounding of neck gives clues to the supraventricular arrhythmias. Palpitations that are worse in the night, benign ectopy or atrial fibrillation. Palpitations associated with emotional distress, that is the psychiatric etiology. Associated with activity gives a clue to the coronary artery disease. Generalized anxiety, we can easily see the panic attacks, we can diagnose with experience. And the rapid palpitations with exercise, that is supraventricular arrhythmias, are increased rate because in the atrial fibrillation. Positional palpitations and the height intolerance, tremor or thyromegaly gives the clue to the hyperthyroidism. Palpitations since childhood gives the clue to the supraventricular tachycardias. Irregular rhythm gives to the clue atrial fibrillation or atrial flutter with variable blocks, which are terminated by vagal maneuvers, give a clue to the supraventricular tachycardias, and other associated murmurs or click or friction rubs can give clue to the diagnosis. Because the first thing that we need to diagnose in the patient with palpitation is the diagnosis. Once we get the diagnosis, it is very easy to treat. So simple approach is the heartbeat regular? No, then it is atrial fibrillation, then it is ectopic beats or atrial fibrillation or atrial flutter with variable blocks. If it is regular heartbeat, taking heart rate more than 120, less than 120, most of the times if it is more than 120, it is SVT or VT, or if it is less than 120 because of high stroke volumes or sinus tachycardia. This is the simple algorithm. So the physical examination is important. Measure the vital signs, see the jugular venous pulse and auscultation of the chest and the precardium. And coming to the investigations, baseline ECG, even though the ECG is invented in 1896, this is almost 125 years after the ECG, still now there is no replacement. Even it is still, ECG is still an enigma for so many of us, because it can diagnose so many things and it will give such an immense information about especially the cardiac status, and there are so many other conditions can be diagnosed from the ECG. If there is palpitations, so the most of the times we need to get the ECG while the patient is having the symptoms of palpitations. If you get that, 99% of your diagnosis is over. So, but getting an ECG during the palpitations is the really tough challenge. So what we usually advise is, we advise the patients to come when they have the palpitations, and if they are staying away or far away from the place, we always tell them, wherever an ECG available to your nearby location, identify the place, and then if you have the complaints, immediately go there and get an ECG done. But in the latest techniques I will discuss, these things have come up. But in our Indian settings, this may take some time to diagnose, because getting an ECG during the palpitation is really, most of the times it is really tough if the patient is having intermittent palpitations. So these are some of the examples. I don't want to go in detail into the ECG descriptions of the different types of arrhythmias and all those things, because I thought this is more mainly, I just want to focus on the how to approach to the patient with palpitations. But once you get an ECG, you will easily know whether it is an ectopic beat or atrial fibrillation or sinus tachycardia, or there is a WPW syndrome or VT or whatever it is. If there is an associated arrhythmic abnormality, we can easily and 100% diagnose with the ECG. So what are the clues that we get are, if there is a delta waves, it is there, that is WPW syndrome, or if there is a left atrial enlargement, it more goes to the atrial fibrillation. If there is a left ventricular hypertrophy, it may cause the atrial fibrillation or ventricular tachycardia. Frequent VPCs going into runs like ventricular tachycardias. Q waves suggest ischemic heart disease. Widespread T inversions cause HOCMs. And the long QT interval, Brugada patterns and early repolarization patterns, and of course the other causes of rare causes like ARVDs and all those things. And the next simple common investigation is 2D echocardiogram, just to know the structure of the heart, whether how is the heart, how is the pericardium, how is the myocardium, how is the endocardium, how are the valves. If you have to assess the valves and then ejection fraction, myocardial structure, thinned out, scarred, or there is a concentric left ventricular hypertrophy or HCM, or are there any masses Are there any tumors? Everything can be diagnosed, and then of course associated regional valve motion abnormalities, and basically if especially in children, if there are an associated congenital abnormalities. And the exercise testing is appropriate in patients who have palpitations with physical exertion and patients with suspected coronary artery disease or myocardial ischemia, because I personally prefer in a setting to do treadmill test for the patients who are fit to do exercise, because even if it is psychiatric problem or anxiety, if they can walk very well on the treadmill, it gives a lot of personal confidence that we have walked so much and we don't have a problem. Or if they really have the problem, we can induce the palpitations and then so that we can diagnose it. But mind you, it's always to be done in the setup where you have the facilities for oxygenation or to treat if there are any associated arrhythmias, because every cardiologist would have faced at least once in their lifetime having problems in the treadmill rooms. So if the arrhythmia is sufficiently infrequent, then if it is very rarely occurring once in a week, once in a month, or once in a year, it is really tough for us to diagnose what it is, what is what. Then in those scenarios, you need to have an ECG monitoring, that is Holter monitoring, or trans-telephonic monitoring, or implantable loop recorders, or event recorders, or mobile cardiac outpatient telemetry. These are very well practiced in the West, because I'll go through this. So the 12-lead ECG and then the Holter monitor, which is available easily even in every setup, but it can only record for 1 to 2 days. If they have the complaints during that period, always tell the patient to record the time and the date of that, and then put the time. And when you put in the for analysis, you can easily diagnose the diagnosis. But if they are occurring very less frequently, then you may end up in putting loop recorders or the event recorders. Even now the event recorders are really coming at a cheaper price. Almost for 4,000 or 5,000, removable and reusable event recorders are available, which can record up to 4 to 5 days or even up to 1 week. So that if they have symptoms during that period, it is very easy for us to diagnose. And mind you, always instruct the patient to do their own routine activities during that period, so that they have to get the symptoms first, and don't try not to give any medications during that period. And of course, the other handheld ECG machines are available. It is like a mobile phone which is available now. Just put your 2 thumbs on one side of the corner and put it on your ankle. It will automatically record an ECG with an app in your mobile. So these things are available now. So if the patient is educated man and he can buy that handheld ECG machine, just it's like a mobile, keep in the pocket. Whenever they feel palpitations, put 2 fingers on each side of that and put on the ankle. It will automatically record an ECG in your mobile with an app. So these things are available nowadays. So when do we further refer for diagnostic settings? Because if it is suggests an arrhythmic cause, or if the patient is at high risk for an arrhythmias like a significant valvular regurgitation or the hypertrophic cardiomyopathy or dilated cardiomyopathy, then we need to refer. Or if the patient is suffering with syncope, because syncope is a really tough situation, because patient cannot go alone somewhere or the attendants cannot leave them alone, because we never know when they are going to have the complaints. The other thing is, if the patients are very anxious about their condition and they demand a specific explanation like evidence-based medicine, we sometimes refer for the electrophysiological studies. So the American College of Cardiology recommends for the assessment of unexplained syncope, near syncope or episodic giddiness, or the assessment of unexplained recurrent palpitations, we do the ambulatory arrhythmias on the further evaluation. So how do you manage this? That is, if there is no evidence on the ambulatory or other findings, then they are tolerated and unsustained, then you reassure them or do other ambulatory monitorings. Or evidence of heart disease are unsustained, then do the ambulatory monitoring. If they are sustained or not poorly tolerated, refer them for electrophysiological studies. These are the Holter monitors. This is the loop recorders that can be implanted. And of course, these are the wireless monitors. It will have 24/7. If there is any disturbance in that, it will give a beep in the center so that they can get a phone call. So referral, when to refer to the cardiologist is any patient with an arrhythmias which is uncomfortable with either diagnosis or management, candidates for permanent pacing, those with uncertain diagnosis, prognosis and management strategies, those with benefit from impact ICDs, or those might benefit from catheter ablation procedures and do benefit from anti-arrhythmic drug therapies. And mostly we try to keep them in the hospital if they need intravenous drugs, because for the observation, or if there is any life-threatening situations or persistent hypotension, we need to keep them in the hospital and then observe them at least for 24 to 48 hours or till we get the diagnosis. So this is the simple way of evaluating the patients with palpitations. So first take an ECG, and it depends upon the structural heart disease, without structural heart disease, and the symptoms of daily symptoms are less likely symptoms. And always rule out other causes, that is like anemia, hyperthyroidism, drugs and other things. So mainly reassurance, lifestyle modifications, correction of comorbid diseases, anxiolytics, mainstay of treatment is beta blockers, and if required anti-arrhythmic drugs if we are able to diagnose, and of course anticoagulations, and recurrent life-threatening arrhythmias can be treated with other ways. So what about in children? So for children old enough to articulate the sensation or the racing or heart stopping or pausing and skipped beats, they can describe like in a common way, but always look for the family history if they have the complaints in the children, and also the social history, the habits of smoking or other drug abuses in the family. Infants, they may not articulate, so they may present with irritability, poor feeding. Some cases may progress to heart failure and prior to identification of normal rhythms. And the last, without any topic will not be ended without COVID-19 nowadays. So actually, for us as a cardiologist to get involved in the COVID-19, most of the patients in our hospital who had more than 60 years, who are diabetics, who are lung involvement prominently, predominant lung involvement, who took time to recover, most of them, 50 to 70% of the patients in the follow-up complaining of palpitations. So, in what way the COVID-19 has caused the damage to the heart is overwhelming inflammatory storm, and then direct damage by the cardiac myocytes. And then, of course, the other causes like hypoxia and oxidative stress, which increases the myocardial oxygen demand. On the long run, they are ending up in heart failures, and then they are presenting with tachycardias. So during the high fever or anxiety and the sympathetic drive or having myocarditis, or especially in the second wave, I don't know how the other parts, but in Nellore we had so many young people between 30 and 40 landed up with the myocardial infarctions. So many with COVID positives. And then they are, I don't know what is the probably delay in the presentation or increase in the coagulation, procoagulant state. They have had, so many had infarctions, and the establishment of lung damage, which further leads into carpulmonal kind of situations, are leading into LV dysfunction and going into heart failure. And of course, the other arrhythmias because of the establishment of the heart enlargement. So in my experience, I don't have any scientific study. I'm just doing the analytical studies. Probably in another 2 months, I will complete it. So most of the patients had palpitations even without lung involvement for 8 to 12 weeks. 8 weeks is for about the younger the age, and 12 weeks is for about the older age and the diabetics and the lung involvement. But 90 to 95% of the patients are recovering by 12 weeks. Probably it is because of the sympathetic drive still persisting. And most in clinical practice, it are the palpitations in COVID-19 without any structural cardiac or lung damage, managed very well with beta blockers, are evaporating. Thank you so much for your kind attention.
Thank you. Narrating a simplest and algorithmic way of understanding arrhythmias and the clues for identification the possible causes. Thank you so much, sir. Nowadays, the cause of palpitations, non-cardiac cause is also becoming highly prevalent as those of cardiac origin. Because in the last few years, psychiatric causes are on rise by 30%. Alcohol consumption, drug abuse also are on rise by 30% in the last decade. So non-cardiac causes also becoming highly prevalent as those of cardiac origin. So anyhow, palpitations causes apprehension. Apprehension leads to increased palpitations. So all cases of palpitations, especially recurrent and associated with some red flag signs, should be investigated for cardiac source. And sir, I request Dr. Tamiraj to take over any few questions from audience.
Yes, please.
So as such, there are no questions from audience and also in chat box. So actually, it's a very lucid presentation, and as you clearly point out, and even my professors used to say, so any palpation, if the patient in your OPD is having palpation, just finger on pulse and stat on chest, 50% of the times you can make the diagnosis, and rest of the things can be taken care of ECG. And most important thing is the company with which it keeps, what are the associated symptoms, and that gives at least 62% of the times of the diagnosis. And one more thing is that it's not always tachycardia that causes palpitations. Even bradycardia can also cause palpitations, because the strong beat, the pause after strong beat will be blood-like thing, and that patient can feel that as palpitations also. And because there are so many recent things sir have spoken, and recently I have a personal experience. Like I was attending a function, there I have seen a patient, I mean, and another person having palpitations, and palpation wise hardly heart beating is on 100 110. So there is a app in the watch. With that app I have seen the ECG itself, and ECG showing the normal sinus tachycardia. So just is almost a psychiatric disturbance, and patient was settled after giving an Alprex 0.25 and so beta blocker like propranolol 10 mg. So there are so many recent advances coming up. So thank you, sir, for this recent presentation. And there are no further questions. We'll close the session.
Thank you so much. Thank you.
We thank Dr. Bhaktavatsal Reddy, who happens to be maybe a classmate. So thank you, Dr. Bhaktavatsal Garu, for your nice presentation.
Thank
And,
you. Thank you.
we are all happy to see you, and please accept our thanks on behalf of the organizing committee.
Yeah. Thank you so much.
So the first session is completed for now. We have 2 talks. Though we started the schedule a little bit late, I think we should be on time. So thank you for the chairman, moderator, and the co-chairpersons. Sir, kindly accept a memento on behalf of our organizing committee. Sir, Dr. Sudhakar, sir, I invite you, sir, to hand over a memento to Dr. Sesha Garu, chairperson. Next. Dr. Ravindra sir, pediatrician. Yes. He is a senior pediatrician from Yellore town, sir. Thank you, sir. Dr. Tamiraj Garu, consultant cardiologist, Ashram Hospital. He is an alumnus of this college. Sir, thank you, sir. So I invite Dr. Raghuram Garu, Assistant Professor of Medicine, Ashram, and Sir, Dr. Seshe sir also would be requested to please kindly stay on the stage for moderating next session also. The next session moderator has unable to come due to some unavoidable circumstances. So I would like you to continue for the next session also, sir. Since it is on diabetes and medical related topics. So the next talk would be, there's a slight change in schedule, just on a small exchange. Dr. Ramachandran sir will be delivering the next talk in the symposium on diabetes. He is coming virtually. He is right now in Mumbai. So he has some work. So he requested a small exchange. So he'll be delivering the first talk in the symposium and later to be followed by the next talk by Dr. Narayan Rao Garu. So I hand over the mic and the next to conduct the next symposium to Dr. Raghuram.
Good morning to all of you. Dr. Ramchandran Garu is at present a president for Indian Diabetes Research Foundation, Chennai, India, and he is a chairman for Ramchandran's Diabetic Hospitals, Chennai, India, and he has published more than 400 research papers till date. And awards achieved by Ramchandran Garu are Best Investigator Award by World Indian Diabetes Foundation based in US, and Thomson Reuters Research Excellence Indian Citation Award in Medicine, receipt of prestigious Organization of Pharmaceutical Producers of India Healthcare SS Award for highest level of contribution in field of diabetes care, and Marinari Award for World Community for Prevention of Diabetes in Edinburgh, UK. Now I ask Dr. Ramchandra Garu to proceed for his presentation.
Thank you. Thank you very much for that invitation. And I'm very happy to be a part of this important meeting by the IMA in Andhra Pradesh. And let me first share the slides. I'm going to talk, I'm being sponsored by Novo Nordisk, but I do not have any conflict of interest, as you know. And I'm going to talk on a formulation called the co-formulation of insulin called Risudex. So the title of my talk is Breaking Barriers of Insulin Initiation in Tune with the Indian Patient's Needs. So as you know that in India, when you start insulin, 75% of the prescriptions are actually a pre-mixed insulins, unlike in the Western countries where you start actually basal insulins. So the agenda for my talk would be first the core realities of type 2 management, especially in Indian patients, and then bringing barriers to insulin inertia, the reasons and practical solutions. And then we'll talk about individualizing insulin therapy to Indian realities. As you know that challenges of managing diabetes in India is very
members kindly attend the meeting at Charka Hall.
Very different. First, Indian realities include high carbohydrate diet. As you know, 60 to 75% of the total calories derive from carbohydrates, and therefore there is a high postprandial plasma glucose, and patients are, most of the time when for the first time you see them, they're uncontrolled on multiple oral hypoglycemic agents. So there is need for simplicity and convenience if you want to start injectables. Now, it has also been shown that 61 to 70% of energy intake in Indians through carbohydrates, as I just now told you, and there is no big difference in the geographical regions of India as far as east, west, north, south, or central are concerned. The other important specific feature of the Asian patients is that in the Western countries, the contribution from fasting plasma glucose is lower for lower HbA1c, and the contribution from postprandial is much higher. That is understandably correct, because in the beginning of hyperglycemia, your fasting will be almost normal or even slightly elevated, but there will be a postprandial rise, a typical of an impaired glucose tolerance. So the contribution from the postprandial plasma glucose to HbA1c is highest. And as the blood glucose increases and the HbA1c increases, what happens in the Western countries is that usually the contribution is almost equal from both. But in India, what we find that actually the contribution for postprandial is still pretty high, very different from that you see. In fact, what you see in the Western countries is that when you go for higher HbA1c, the contribution from hepatic glucose production due to the fasting hyperglycemia is high because the blood glucose remains very high throughout the night. So therefore, the contribution from fasting plasma glucose is much higher in higher HbA1c levels in the Western countries. On the other hand, in the Indian patients, the contributions from postprandial and fasting is almost pretty similar. In other words, postprandial hyperglycemia seems to be contributing pretty high, both in the lower fasting HbA1c levels, as well as in the higher fasting HbA1c levels. That is because of the high carbohydrate load of the Indian diet. And as you know, in subjects who eat 3 times a day, 50% of the day is spent in postprandial phase. An Indian scenario is worse owing to high carbohydrate diet, and treatment strategies should address both meal-related and fasting hyperglycemia for optimum HbA1c control. So does initiating with basal insulin serve the purpose of total control? And the answer to that question is there's a big difference between the non-Asian and the Asian. As you know, the patients achieving HbA1c below 7% is much, much lower in the Asian patients with actually basal insulin. So can one single dose of basal insulin be suitable in case of high carbohydrate diet? Can it offer direct control of postprandial blood glucose? Be suitable in cases of delayed insulin therapy? Offer convenience at insulin initiation with total postprandial and fasting plasma glucose. One of the reasons why in India we use mostly premixed insulin to start with is because usually the insulin initiation is delayed, and only after 3 or 4 or a number of oral hypoglycemic agents are tried with the maximum dose, we start using insulin because of the inertia both on the part of the patients as well as doctors to start insulin. So prandial component cannot be neglected, and therefore you have to bridge the gap, the step towards achieving better control of diabetes. So as this is a very old and not a slide which you have probably seen a number of times, this is actually from Del Prato from Italy, who's a good friend of mine, who is achieving glycemic goals by timely treatment optimization. The earlier you intensify treatment, you probably achieve better control throughout 15 to 20 years of diabetes. On the other hand, we wait for hyperglycemia in order to intensify treatment, then you lose time. And most of the years, the patient is spending with high blood glucose levels and high HbA1c levels. Why is timely insulin initiation particularly important in Indians? Even with normoglycemia, it has been found that Indians had lower fasting insulin. In fact, as the diagnosis of diabetes is made, we have found that the beta cell defect in the Indian patients are much, much more than actually the white or the Western patients. Here is a comparison between Asian Indians and the PMI Indians to just show that Asian Indians exhibited significantly lower insulin values compared to the PMI Indian population. In fact, this is not a very good comparison. I think the best comparison would be to say that our patients, by the time they are getting diagnosed with onset of diabetes, they have almost severe beta cell deficiency. Therefore, starting insulin as early as possible in the natural history of type 2 diabetes is probably very logical or rational. There are many barriers, physicians' factors leading to therapeutic inertia of insulin. There are perceptions and inaccuracies in the hands of doctors' assessment of the patient's preferences, concerns, and self-management. We sometimes underestimate the understanding and the acceptance of the patients. Perceived patient-resistant insulin, we always find that, okay, there is always a resistance on the part of the patient to start insulin. And probably when you tell the patient about insulin, they are concerned about adherence, perceiving many patients are unable to or unwilling to adapt for more complex treatments. We are also lack that whether there is self-management skills, and we are underestimate that. There are perceptions regarding patients' prior non-adherence to oral agents as inefficient. We always feel that patients probably are not taking the oral drugs properly, so therefore, why not I intensify the oral hypoglycemic agents before starting insulin? So the underestimation on the part of the doctors regarding the patient's ability to accept the new insulin therapy or insulin therapy is one of the reasons why doctors do not want to initiate insulin for patients at a timely manner. Now, on the patient side, there are many misconceptions. I know that all of you know that when you want to start insulin from your side, there are many misconceptions from the patient side. Lack of self-confidence, and there are opposing views. Patients often have a goal of eliminating medications, and they think that it is a failure of my treatment. It is a failure of the management of diabetes, or I have come to the end of my diabetes treatment, and that is why I have to start insulin. People do not understand that insulin is a very good treatment. Even early in the part of type 2 diabetes, you can start insulin for good health, to prevent complications, and also to have a better quality of life. Of course, another concern about injections is that it is also, most of the insulins are a little more expensive than the conventional oral hypoglycemic agents. People also have misconceptions about when you start insulin, it can have side effects and it can lead to complications. Unfortunately, they find that patients who are taking insulin are people who have long-term diabetes with complications. And therefore, they connect insulin injections with complications, with myocardial infarctions, with stroke, with amputations. And that is because of the misconception that insulin is causing the complications. It is because patients who are having complications like chronic kidney disease or acute infarctions or ischemic heart disease, or even frail patients or patients who have liver disease or patients who have infections, they need insulin at those times, and they continue to be on insulin for better control of diabetes. So the patients, the relatives of the patients and the patients who have seen these patients have a misconception that insulin can cause the complications. Now, you can overcome these social and psychological assistance of insulin therapy in many ways. There are some possible solutions to insulin therapy inertia. Begin discussions in a collaborative communication style, knowing that some care and effort, long and healthy life with diabetes is possible. Discuss the health benefits of treatment projects and explain that treatment changes are a normal part of living with diabetes and not a sign of their personal failure. Explain benefits of insulin therapy. Address injection concerns by demonstrating the actual injection process, which is absolutely painless. Assess and address patients' concerns and beliefs or misconceptions about insulin. Learn early about how to type 2 diabetes changes over time. Address concerns about diabetes and insulin therapy, and then tell them that insulin therapy is a natural treatment for diabetes. So I think there are many ways. I'm sure all you experienced physicians are pretty familiar with the misconceptions and the fears and the barriers to starting insulin. Now, individualizing therapy and meeting the glycemic control requirements of insulin. As I told you, premixed insulins are the first type of insulin started in 75% of patients who need insulin therapy in India for the simple reason, two simple reasons. First, we always start on them very late, and their postprandial blood glucoses or oral fasting portion both are pretty high. Secondly, they already have a high carbohydrate diet when their postprandial blood glucose are pretty high compared to the Western countries. Now, one of the co-formulations which is now available today is a combination of iraCASP and insulin degludec. As you know, insulin degludec is a long-acting insulin which is available and work for about 30 to 40 hours. And we have a combination of the rapid acting, short acting insulin, as well as the ultra long acting insulin, which is called Rhizodec. And this actually is a diffusion which is occurring very, very significant. For example, the rapid insulin diffuses very rapidly from the subcutaneous tissue after you inject and will start acting within 15 minutes. The slow acting insulin will go only very slowly and will be absorbed within about 36 to 40 hours. So therefore, when you begin insulin for the first time, this combination of a long-acting basal analog and a short-acting insulin analog is a very good combination. And secondly, you should know this is not a pre-mixed one mixed together. This is actually a co-formulation where the molecules of both these insulins remain separately in the formulation that you are buying in the cartridge. There are many studies to show that whether a combination of this short-acting insulin as well as a long-acting insulin, is it better than starting a basal analog? The basal analogs like insulin glargine became very popular, especially in the Western countries, because you start insulin very early in the natural history of type 2 diabetes, where their HbA1c is only 8+. In India, insulin is started only when the HbA1c is above 9.5 or 10, and therefore we always require a pre-mixed short-acting plus long-acting insulin together. Now, this is a comparison of basal insulin glargine 100 compared with IDEC as combination as a co. In other words, it is a comparison between Rhizodec and Lantus. And what you can see here is that Rhizodec reduced the HbA1c 1.4% better than glargine, and with a similar fasting plasma glucose control with 70% of patients. Now, we also find that the significantly better postprandial control after a major meal when you use Rhizodec compared to only basal insulin. Most importantly, there is a lower risk of hypoglycemia, almost 27%. It has been shown that, well, we know, of course, that glargine insulin should not be underestimated. Glargine or Lantus were the first insulin basal analog which came into the market to be used for all over the world. And it was actually launched in 2002, which made a revolutionary change of starting basal insulin for uncontrolled diabetes with minimal risk of hypoglycemia. However, today we have insulins like Tresiba or Rhizodec, where this degludec has got 40 hours of acting with still further reduction in the risk of hypoglycemia compared to glargine. In patients uncontrolled with oral hypoglycemic agents, we have shown that insulin initiation comparing basal insulin with a co-formulation like IDEC. The blue one shows IDEC, which is Rhizodec, which is a combination of IDEC as with degludec, and this gray one is those patients who are started on glargine. And the proportion of patients at week 26 with less than HbA1c 7% is without any hypoglycemia is 43% with Rhizodec compared to 25% with glargine. And that is important because you have to achieve low blood glucose or lower and target HbA1c without the risk of hypoglycemia. And that is the most important characteristic or property that you want an insulin to have, especially when you start insulin for the first time in a patient who has not taken an insulin before that. Because hypoglycemia is a dreadful experience, and you do not want your patient to experience that and get a disrepute for the insulin as well as for the doctor. Of course, I have discussed this already. Now, the RSSDI ESI clinical practice recommendations have actually recommended avoid using insulin as a threat, alleviate patients' anxiety about insulins, and once daily Rhizodec, which is an IDEC combination, is recommended as a choice for insulin initiation. insulin therapy should be considered in all patients failing to achieve glycemic targets on 3 oral agents, 2 or more actually. And this is the recommendation from the Research Society for Study of Diabetes in India. So to summarize, Indian reality is that people with diabetes have high carbohydrate diet, just like the general population, and that results in a high postprandial plasma glucose. And high carbohydrate intake and high postprandial plasma glucose level are independent risk factors for cardiovascular disease and mortality. It has also been shown that postprandial blood glucose has a stronger correlation with HbA1c than fasting plasma glucose, especially in the higher levels of HbA1c, thereby necessitating requirement for total control. The treatment effectiveness can be increased through usage of insulins, which offers total control with convenience at initiation. So we need to actually not overwhelm the patient when you start insulin. The treatment should be simple, probably a single dose a day to start with, and you should also convince that it is almost painless injection. And one important aspect is that the risk of hypoglycemia is very low, and that is very important from the doctor's point of view. One of the reasons, I think that one of the major reasons we do not start injections for insulin for patients with type 2 diabetes is because the fear of hypoglycemia. And secondly, you do not get an immediate reward from bringing down the blood sugar from a postprandial of 200 milligrams to 160 milligrams immediately. So there is no immediate reward from the patient's side because he's almost asymptomatic patient sitting in front of you. But in the long run, starting insulin will improve his health, improve his quality of life, and try to prevent complications. So in the interest of the health of the patient and continued good control, starting early insulin with a co-formulation like Rizodat, which is a formulation of IDEC or degludec insulin plus an aspart, that is a short-acting insulin, is a very good option for you to start for patients with type 2 diabetes who are uncontrolled with more than 3 oral hypoglycemic agents. Thank you.
Thank you, sir, Ramachandran sir, for having a very good explanation. Vividly explained about the importance of prandial glucose control and its impact on HbA1c and Indian realities of insulin, low insulin secretion and insulin resistance, and very nicely explained about therapeutic inertia. Inertia not only from the patient side, there are therapeutic inertia from physician's side. You are very nicely explained and have shown solutions also for that, sir, and also explained very nicely about management of diabetes in the Indian patients. Now I request the audience if any questions. We are very fortunate to have your lecture session, sir. And if no questions from audience, I would like to have a clarification from you, sir. When we expect chemical mimics or oral insulins or weekly insulins?
I think it's a long time off. You know that there are 2 types of injectables you can start in patients with diabetes. One is, of course, insulin. And the other one is what is called GLP-1 receptor agonist. You know that you have dulaglutide, which is a single dose once a week injection by Eli Lilly and company. And then Novo Nordisk has got Victoza, which is liraglutide, once a day. Now, those are also injectables. They are pretty good because they also have cardiovascular benefits and safety and also have no hypoglycemia. Today, Novo Nordisk has now brought in the new innovation, and that is called polypeptide in a pill, peptide in a pill, it's actually. So they have brought out for the first time a protein in a pills model, and patients can take it orally. Now, This has been already launched in certain parts of the world. We will be getting this in January. So one of the injections, which is a peptide to be injected for diabetic patients, type 2 diabetic patients, have been now converted into an oral peptide in a pill, which is a great innovation. I think it is soon that we will also be able to put this particular insulin molecule into a pill. So far, we have not been successful because the absorption from the gut has been very, very negligible. But I'm sure soon it will come. Nobody will be able to tell you when it is going to come. We have been talking about for the last 20 years, whether we can put the peptide in a pill and that insulin molecule can be put in a pill. But they have done that with a GLP-1 receptor agonist, which is a new molecule for injection for diabetic. We have been injecting that for the last 5 to 10 years, almost 5 years now. So thank you for that question. So we'll have to wait for the time when insulin will come in a pill form.
Thank you. Thank you, sir.
Thanks a lot. Thank you very much. I'm leaving. I'm in Bombay. I got one more function to attend. Thank you very much. I wish you all the best for the rest of the meeting.
Thank you. Thank you so much, sir, on behalf of IMA.
Dr. TV Narayan Rao Garu, consultant physician in Andhra hospitals. He's a retired as a special grade civil assistant surgeon at ESA Hospital Vijayawada in November 2017. He did his MBBS from Kakatiya Medical College, Warangal in 1981 and diploma in ophthalmology from Kakatiya Medical College, Warangal in 1987. And he passed his MD General Medicine from the same college with distinction from NTR University of Health Sciences, Vijayawada in the year 1996. And he worked as a Joint Secretary 1997-98 and a General Secretary 98 to 99 for Indian Medical Association and Vijayawada branch, and worked as a General Secretary API Krishna District Chapter, was Organizing Secretary for 41st AP State Medical Conference IMA 1999 Vijayawada, and is a convener Scientific Committee AP APCON 2006, which was held in Vijayawada. He is also a co-chairman Organizing Committee AP APCON 2016 Vijayawada. He delivered lectures at various state conferences. Now I asked Narayan Rao Garu to continue and deliver his lecture. Thank you. Thank you.
Respected chairpersons and dear friends, at the very outset, I would like to profusely thank the organizing committee of AP APCON Eluru for inviting me for this morning's lecture. And I also would like to thank Mrs. Novo Nordisk for facilitating my talk today. So if you want to talk about anything about insulin, I think this single slide is enough to explain everything about insulin. Way back in 2002, in the New England Journal of Medicine, Professor David Nathan, who is the chief of internal medicine and endocrinology at Harvard School of Medicine, he very succinctly put it, saying that insulin is the oldest of the hypoglycemic agents. It's also the only one that occurs naturally in humans and has no upper dose limit. Then why are we afraid of starting our patients on insulin is the next question to be answered. So my talk for today will have three areas. So first, we'll see the history of insulin discovery, and then how we have progressed relentlessly towards the solutions of a relentless disease, and what future holds us in the arena of insulin in the next decade or so. We'll see. So if you look into the history of diabetes, as all of us are aware, we are celebrating the centenary of insulin innovation or insulin discovery this year. So before insulin, diabetes was mostly considered to be a fatal disease. So most people used to die, particularly those who were diagnosed with type 1 diabetes, used to die within the next 1.5 years. So the most effective treatment during those days was to put these patients on diabetes with very strict low-calorie diets. sometimes the patients used to die of the starvation itself rather than the diabetes itself. In the middle of this slide, you can see a typical diet chart, which used to be the order of the day during the pre-insulin era, which used to prescribe about 150 kilocalories for 24 hours for a patient with diabetes. I don't think anybody can survive with a diet which is supplying just 150 kilocalories per day. And on the extreme, on the left extreme, you can see a typical child suffering from type 1 diabetes before the discovery of insulin. So this is a plaque which was erected in the year 1970 in front of a house in which Frederick Banting used to reside during the days of insulin discovery. And in that particular house, he had the brilliant idea of how to extract insulin from a dog. So again, on the left side of the slide, you can clearly see an original notes which was written on the fateful or eventful night of October 30, 1922 by Dr. Frederick Banting. So if you look into the actual evolution, how we came to know and how we came to prescribe today the insulin, the whole story started way back in the July month of 1920. Banting, after participating in the World War as an orthopedic or trauma surgeon, he started his orthopedic practice in London, Ontario, Canada. Please remember, this is not London of UK, but this is London of Canada. So, but for some reason or the other, he could not get much of a patients as for his practice. And then he was very depressed and he was going through various journals and he was also delivering lectures in physiology to a local medical school. On the fateful night of this October 31st, 1920, he was browsing through a journal in which how to ligate the pancreatic duct of a dog was described. And he had suddenly a flash of thought that if you ligate the exocrine duct of the pancreas, you can probably see that the exocrine function of the pancreas can be taken care of, and then subsequently you can extract the principle of insulin from the pancreas. So he met Dr. MacLeod, who is the professor of physiology at the local medical school, on the November 8th, 1920, and subsequently has convinced him to allot him a laboratory space to do the experiments on pancreatectomized dogs and extraction of insulin. On May 17th, 1921, he was given an assistant in the form of Mr. Best, who was a medical student at that time. And then in the month of July, that is on 30th of July, 1921, activity of crude extracts were successfully demonstrated in a pancreatectomized dog, which was prone to develop diabetes mellitus. On January 23rd, 1922, the activity of the purified extract in a human with diabetes for the first time was demonstrated, and the patient's name was Leonard Thompson. You can see him on the extreme left side of the chest. And in the month of June 1922, the patent application was submitted by Collip and Best, and then subsequently Eli Lilly as well as Novo Nordisk started manufacturing insulin. You can see the time there in the slide. Dr. Banting has appeared on the cover of Time magazine on the day of August 27th, 1923. And in the after 2 months, on the October 25th of 1923, Nobel Prize was awarded to the Banting and MacLeod, which of course subsequently they have shared with others like Best and Collip. So what is very much interesting and what is really cool about this particular award of Nobel Prize is nowadays we see the award of Nobel Prize in physiology and medicine after 15 years or 20 years of the original discovery taking place. I think in the history of Nobel Prize, the entire Nobel Prize, I think this is the shortest period between the discovery of a molecule and then the award of Nobel Prize for the same. It took less than a year. So these are the guys, these are the heroes behind the discovery of insulin. Banting to start with, and Best his student and his assistant during the discovery, and the Collip who has really helped in purifying the the pancreatic extract from the dogs into the pure form of insulin, and then the MacLeod who was the head of physiology department at that time, who has facilitated the experiments and discovery of insulin. So subsequently, we had a lot of molecules which have come up in the groups, 10 different groups and 10 different categories of molecules have been successfully identified. But please remember, insulin was the first molecule to be invented as a modality of treatment for diabetes mellitus. Today, these medicines are used in various combinations to form individual treatment plans for people with diabetes. But please remember again that insulin plays the most important role in type 2 diabetes mellitus management with the highest glycemic, because there is no end as far as the hemoglobin A1C reduction potential of insulin is concerned. If you look into the life expectancy of a patient, if you are talking about the 1900 early 30s or 40s, before the discovery of insulin, patient's life expectancy, any patient was diagnosed to be type 1 diabetes mellitus, at the age of 10 years, they hardly used to live for about 1.5 years. So the life expectancy after diagnosis with the dreaded type 1 diabetes mellitus was only 1.5 years in the early years of before insulin discovery. By the time 1945, you can clearly see that life expectancy has progressed from 1.3 to 1.4 years to a 35 plus years. And today, if you have a patient who has been diagnosed with type 1 diabetes mellitus, the life expectancy is 59 plus, that is beyond nearly 60 years. So that was the amount of tremendous progress we have achieved as far as life expectancy increase is concerned in the lives of type 1 diabetes mellitus patients. So these are various innovations which have been brought out after the discovery of insulin. In the 1926, the first crystallized insulin was synthesized by Dr. Abel, and then subsequently we had various formulations in the form of protamine insulin, zinc insulin, NPH insulin, lenti insulin, and all those things. And the most important discovery is in the year 1946, when Kranboal and Rosenberg manufactured the isophane insulin. Isophane insulin is just a balanced insulin where the zinc and insulin was in equal proportions. So there was neither excess of insulin nor excess of zinc in the combined preparation. So due to the relentless innovation towards a relentless disease, we have seen a lot of molecules coming up. In the 1974, I think the first synthetic human insulin was achieved because of the RNA and rDNA technology, recombinant DNA technology. And subsequently, in the year 1975 to 81, first production of recombinant human insulin has taken place. Eli Lilly was the first to come up with supply of human insulins, that is human analog insulins. And then subsequently, we had the short-acting human insulin analogs in the form of insulin Lispro in 1996 and human insulin Aspart in 1999. Glargine, as was explained by Dr. Ramchandran, my previous speaker, came up with insulin Glargine in the year 2000, and subsequently Eli Lilly, the Novo Nordisk people have come up with the Detimer in the year 2005, which is a long-acting basal insulin analog. And in the year 2015, we had the Glargine U300, again, another innovation as far as basal insulin is concerned. And in the year 2013, we had insulin degludec, and now the latest kids on the block of insulin analogs are the ultra rapid acting Lispro and as well as insulin faster Aspart. So you can argue about what is the necessity of having so many innovations, because they come with their own advantages. So if you're looking at the Tresiba, which was launched in 2013, that is a degludec, which is a basal analog. The advantages are once a day dosing, better fasting blood plasma glucose control, lower glycemic variability within the patient as well as in between patients, and flexibility. The half-life is nearly 8 to 40 hours, so you can have a lot of flexibility as far as dosing of this particular insulin is concerned. And it has shown its safety as far as cardiovascular outcomes are concerned. And then subsequently, the Rhizodec was launched in 2014, comes with similar advantages. And then in 2015, Tuzio, that is Glargine U300 has been launched. It has got its own advantages in the form of it being a once a day injection and better fasting plasma glucose control. And it has also demonstrated lower glycemic variability. And then, of course, in the year 2017, one more innovative molecule came into the picture in the form of fast Aspart, which goes by the name of FIAS. So it is twice as fast as far as the onset of appearance in the bloodstream and action is concerned, 74% greater glucose lowering within the first 30 minutes, and superior 1 hour and 2 hour postprandial glucose control following a mealtime. The beauty of this particular molecule is that, suppose if you have got a young kid with type 1 diabetes mellitus, you are never sure how much he's going to eat, whether he's going to eat at all, or is he going to refuse, or is he going to vomit immediately after taking food. In such patients, the advantage of using FIASP is that it can be given after the boy or child consumes his meal, and then of course it reduces the postprandial plasma glucose to the same extent. And then of course we had a lot of basal insulins in the form of analogs in the past decade and a half. We had NPH in the beginning. Of course, even now, so many people use NPH as a basal insulin. The advantages are it controls beautifully the fasting plasma glucose of any given patient, but there are limitations, like, you need to give it twice a day. And then, of course, early morning hours, very early in the day, around about 3 a.m. or 4 a.m., these patients are likely to have a small hypoglycemic event sometimes. Subsequently, Glargine U100, which has really revolutionized the treatment of basal insulin. Again, advantages being once a day dosing, lower risk of hypoglycemia when you compare this particular molecule with the previously existing molecules like NPH. And of course, it does have some limitations as far as flexibility. It doesn't offer you much flexibility. If you're going to give this particular land test in the morning, you need to give it in the morning, more or less at the same time every day. And there is, of course, some room as far as improvement in the intraday variations are concerned, which was overcome to a certain extent by Detimer and then Glagen U300 and then subsequently insulin degludec. And then, of course, we had some rapid acting insulins, which I have already explained. Initially, we had the human analog insulin in the form of regular human insulin. We also call that as human actrapid. And then we had the first generation rapid acting analogs in the form of Aspart, Lispro, and Glulysin. And then now we have fast acting insulin Lispro as well as insulin Aspart. And the most important thing, I think Dr. Ramchandran sir has already addressed this issue, because as Indians, we come with a lot of postprandial hyperglycemia, and we are much delayed in the starting of insulin in our patients. So I think rather than basal insulin, it is the premix insulins which are going to help us in a long way as far as taking care of our own patients are concerned. In that area, of course, we have three things going with us today. We have the conventional human mixed start, and then we have the no mix in the form of biphasic analog insulin. And now we have the latest one, which I think Dr. Ramchandran has explained in detail. That is the Rhizodec or insulin degludec aspart. I don't think there is any point in repeating the same things which he has covered, so I'll skip this. And this also, I think, is beautifully covered as far as the pharmacokinetics and pharmacodynamics of Rhizodec is concerned. So that is as far as today. So what is it that we are going to look at in the future? I think we should have a vision to look at certain things which we need to achieve in the future. Then only I think we can strive to reach those goals. So as the chairperson has asked to the previous speaker, once weekly insulin, probably I think we are going to see in the next 4 or 5 years. And the most important thing I think all of us never give much thought is physiologically distributed insulin. That is one area I think is very tough to replicate, because if you look into the normal physiology of insulin secretion and utilization, the distribution between the portal circulation and systemic circulation is 4:1. That is, if you take a normal human being without diabetes, and if it is inert insulin that you are talking about, the concentration of insulin in the portal circulation is 4 times higher than what you see in the rest of the circulation other than the portal circulation. To mimic that with artificial insulin, which you are going to administer through the form of a subcutaneous insulin, that is going to take a Herculean effort. But I think we must be optimistic and see that in the future, probably I think we will overcome this physiological distribution barrier which is there. And of course, we are looking for oral insulins. Probably I think next 5 years or 10 years, maybe we'll be able to achieve that. And then glucose sensitive, that is an insulin formulation which is sensitive to the blood glucose level. And it acts as if only when the patient passes a certain threshold which has been pre-decided blood glucose level, then only it acts. That is one thing which we need to look for. And in the future, I think the ultimate thing to look at is the beta cell replacement, wherein there is no need to give any oral insulin or oral tablets or then injectables. So I think that is the future, the ultimate in the future. Probably I think we may not be able to see in our lifetimes, but probably our kids will see in their lifetime such a thing being achieved in the treatment of type 2 diabetes mellitus. So summarizing my presentation, in our quest for better insulin, we have come a long way, and still there is a long way to go. Though we have advanced with newer analog insulins available with better safety, efficacy, and patient convenience, the adoption is yet very low. We still see patients coming with 4 oral hypoglycemic agents, 5 oral hypoglycemic agents with a fasting blood sugar of 250 and a postprandial blood sugar nearing 400 and hemoglobin A1C, which is beyond 10. I think as was stressed by my previous speaker, there are problems in 2 areas. One is the physician resistance and then the patient's resistance. I think we must strive to overcome that and start our patients on insulin very early in their failure of achieving good glycemic control in their diabetes journey. And it is time to bridge insulin inertia. That's what this last statement says. So top, we heard the Leonard Thompson, the first person to receive insulin. And the first insulin vial which was used, now we have come a long way. We have the modern insulin devices, pens and cartridges. But then, as I said, we have still a lot of distance to cover in the future. And ultimately, I think one day we will end up with beta cell replacement. Thank you, ladies and gentlemen, for your patience.
Thank you, sir. Thank you, Narayan Rao, sir. As usual, I need not explain about your lecture. Always will be very good. And you are well versed, most senior person experience, having experience of and well versed with diabetes lectures especially. insulin was discovered 100 years back, by Banting. Okay, when he discovered insulin, Banting sold his patent rights to university for $1 only, without having any profit. So he himself told at that time, insulin doesn't belong to me. Insulin belongs to the world. It belongs to the world. So with the motto that it should reach everybody who needs it. But with the development of new molecules, cost of production is increasing. Naturally, new products will have high prices. So the theme of diabetes, World Diabetes Day, is access to insulin by everybody who needs it. So it is the policy of national health systems to be modified, adjusted in such a way that patients who need insulin, they should have it, access. So in the last 100 years, so much development, as Sir described, we have seen in the molecules, devices, diagnostic methods, everything. So we are also we have to not only to look back what happened in the 100 years, we have to look into the future also, sir. As you explained, new molecules having physiological actions, mimicking physiological insulins, artificial pancreas, and etc. And I request audience to have any questions. Please ask Dr. Narayan Rao, sir. Sir, if no questions from audience side, because you are very much experienced, I have a small practical question. The issue has become viral because recently we have seen in the last 1 or 2 years. How do you feel? What is your opinion about ketogenic diets, sir?
Sir, if somebody is interested to read about the various diets which are available, I suggest you to read Science Magazine latest issue, which is available on the net. And the conclusion is there is no diet which is beyond the normal diet which you are taking. It could be Atkins diet, it could be keto diet, or it could be intermittent fasting, or whatever it is. So far, the evidence has been anecdotal, not sustained for a long time, and the outcomes are not at all proved. Having said that, these are fly-by-night operators, sir. Today we have keto diet, and then tomorrow we have somebody else's diet, and any diet which is not sustainable over a period of time, which you are unable to eat for months together and years together, is not a diet which is sustainable. So I think for short-term weight loss, like about 3 months or 4 months, you can go with keto diet. And for some indications like pediatric epilepsy, which is very difficult to control, those are the areas where keto diet has been proven to be of some benefit. But for long-time diabetes control, I don't think it is really a sustainable modality of treatments.
Okay, sir. Well, thank you, sir. Thank you so much.
Please take the moment. Sir, thank you, sir, for delivering an excellent lecture on diabetes, past and present, the future, how it, the insulin and all these things. So kindly accept a memento on behalf of the organizing committee, sir. I request Dr. Seshaya, sir, to hand over memento to Dr. Raghu. So the next session would be the one before the inaugural. So I request all the audience to stay back for the inaugural function. The inaugural of the scientific session would be held shortly in about 20 minutes. So the next session would be on the updates in COVID management by Dr. Subbarao Garu. So after the session, we will be having the inaugural of the scientific session, and all the dignitaries are coming, already have come. The Vice Chancellor of the University, NTR UNHS, and others have come. So kindly stay back for the inaugural. Sir is there. The next speaker is ready. He will be joining us virtually.
Good morning, sir. Subbarao sir. Dr. Subbarao sir is MD Pulmonary Medicine, working as an associate professor in SVRRGG Hospital, Tirupati. And he did his MBBS from SV Medical College, Tirupati, and MD from Kannur Medical College. And he worked as a nodal officer for COVID-19 and is also working as a nodal officer for TB unit. TB unit. He has won Dr. Sunita Subramaniam Oration Award for IMA Tirupati 2020, and is a Vice President Association of Pulmonologists of Simandra, Andhra Pradesh. Now I ask Subbarao sir to deliver his lecture on COVID updates. Sir.
Dr. Subbarao sir, kindly unmute yourself, please. Unmute, sir. I think you are on mute. And increase the volume to maximum. Announcement. Sir, Subbarao sir, you can start your lecture. Still you are on mute, sir.
Sir, please unmute, sir. Please unmute and increase the volume, sir. Please unmute your audio. Please increase the volume.
We are not able to hear you, sir.
Sir, please unplug your headset and please try to speak again, sir, please.
Okay.
Hello.
Hello.
Sir, yes, sir. You can just share your PPT and start presenting, sir. We can hear you, sir.
You are hearing now?
Yes, yes.
I'm audible now?
Yes, yes, sir.
Okay.
Please share your PPT, sir.
Okay. Is it okay?
Yes, sir. Please make it into slides.
Okay. Okay.
Yes, sir. It's clear, sir.
Is it okay? Okay. Good morning, everybody. Thanks for chairpersons for introduction and all the audience and organizers. So now today we are going to discuss about updates on COVID therapeutics. So I will be briefly covering on the status report, briefly introduction and various clinical phases of COVID-19 and available therapies and evidence for the COVID-19 treatment. So these are the graphs which are showing status of
COVID-19 in India. So there is a first wave followed by second wave, rapid peak. So now we are sustained fall in cases and deaths. Am I audible, sir?
Yes, yes.
Okay. Sustained fall in cases and deaths. There is a gradual increase in increase in vaccination status of India. So with this, before we go to discuss about the various treatment strategies, we have to know the stages of COVID-19 disease. As all of you are aware, viral phase and the host inflammatory phase. So we divide them into 3 stages. In the initial viral phase, followed by pulmonary phase. Pulmonary phase 2A, B, 2A, which contains no hypoxemia, 2B presenting with hypoxemia, and then hyperinflammatory stage where you get more severe respiratory support, ARDS, shock, cardiac, and other systemic symptoms, depending on the severity of inflammatory response of the person. So here in the viral phase, we will be having mild fevers, fever and constitutional symptoms like any other viral fever, and the only finding we can identify is lymphopenia. So we have to take a CBC test for every person positive, and lymphopenia indicates a severe viral infection. And then in the second phase, we'll have X-ray and CT findings in the lung involvement. In the early phase, hypoxemia will not be there. At this stage, we have to say take a 6-minute walk test to identify early identification of hypoxemia, so that a patient, this is viral phase usually starts and ends by 10 days, usually declines from 8th day onwards. So you have to take clear-cut history, and in the inflammatory phase, you have rise in the markers. So the treatments also different, and the response also different in various phases of treatment. So in the early stage, you have to give antivirals and supportive treatment, no steroids, because here is our natural immune system which works, and 85% of persons are naturally cured of COVID-19. So we should not control. Suppress the natural immune response of the person, so that we have to avoid immunosuppressive treatments in the early phase. And from the late phase, second phase onward, we have to start anti-inflammatories and anti-cytokine treatment from till the end of the. These inflammatory drugs and anti-cytokines will be more beneficial in the moderate to severe disease. This is in brief about pathogenesis and how this is the slide showing how the pathology will start. In the early stage, there is a IL-1 and IL-6 will produce from inflammatory cells to the local site of infection. Type of interference will be involved. So the natural containment of the disease occurs. There is no much damage to the organ. Once this stage is crossed and the natural immunity mechanism not able to contain the inflammation, infection, or the abnormal inflammatory response starts in the person prone for cytokine production, abnormal cytokine production, then the more amount of cytokines are released, and more amount of regional lymph nodes are involved to produce T helper cells and T cytotoxic cells towards the organism, and they will be infiltrated in the local site, and in the circulation they will produce more amount of mature T lymphocytes, and attract the inflammatory cell to the site of infection, and that leads to overproduction of cytokines and chemokines at that site of infection. So that leads to cytokinemia, and further these cytokines and chemokines through the bloodstream reaches the various organs and produce multi-organ dysfunction, multi-organ damage. So this is in fibrosis in the late stage of the disease. This is in brief about pathogenesis, how the goes on. So this is a hyperinflammatory stage. Why this happens is there is a failure of to resolve the inflammation of the person, or inappropriate response towards the trigger, whether in the amplitude and the quantity or quality of infection, response of immune response, that leads to persistence of cytokine release and local inflammation, and failure of negative regulatory mechanisms like T helper cells, mesenchymal stem cells, and IL-1 receptor antagonist, antagonist and pro-inflammatory leukotriene 10. So all these things will lead to persistence of inflammation and stimulation of the prolonged signal receptors like JAK receptors, mTOR receptors, NFK beta, and these are secondary receptor sites which will further promote the production of more cytokines by the inflammatory cells by stimulating inflammatory cells, and persistence of the inflammation leads to organ damage and further. So this is how the JAK receptors and STAT receptors incorporate into the nucleus of the inflammatory cell and produce abnormal cytokine level of cytokines in the inflammatory site. These are the brief how the various organs are involved, particularly lung and the vascular system and the heart are major things involved. Every body, kidney and every part of the body is involved. So this WHO classification of severity disease, this also we have know the pathological stage of the disease and correlating the clinical stage of the disease, then only we can assess which treatment will be working. So in non-severe, severe and critical, WHO classified as non-severe, severe and critical. Non-severe means no severe and critical signs or symptoms of critical disease. Severe and critical disease. Severe disease is SpO2 less than 90, respiratory rate more than 30, and critical is requiring sustained sustaining treatments like NIV, mechanical ventilation, ECMO like that, and acute respiratory distress syndrome, sepsis and septic shock. So these are way to classify the severity of disease, and this Indian government classification of our classification, mild disease, if the saturation and respiratory rate is normal and that is 90 more than 94 and less than 24 respiratory rate, and so moderate 90 to 93 SpO2 and 24 to 30 respiratory rate, and presence of more than 30 respiratory rate and more than less than 90% of saturation. So this is a critical thing. Respiratory rate more than 30 and 90 below saturation is a severe disease. And then other if the any organ will be ARDS and sepsis and multi-organ is considered critical disease. So with this introduction of classification, with the severity of disease and the high risk group, as all of you are aware by this time. So high body mass index more than 35 and having chronic disease like kidney, CKD, diabetes and hypertension, age more than 65 and more than 55 with chronic disease, cardiovascular hypertension, and all these chronic diseases with and any immunosuppressive therapy, cancer like that, any comorbid condition is there, they will lead to high risk group into. So this high risk also we have to assess. So assess the severity, assess the high risk group, and then the available treatments. The available treatments, as we are going through nearly complete the 2 years of pandemic. So continuous cases in the Western world and USA, there is recorded hospitalizations and deaths are more in unvaccinated populations. The vaccination is still the good weapon on our hand, and therapeutic needs are required for the COVID-19 disease, progressive disease in the COVID-19, and then many treatments have been explored, but few are approved. Few are got good response in the treatment, and few are approved. In these few approved, there are a handful of drugs are available for treatment. These drugs also, particularly during surgery, there is a need for availability of the drugs. So accessibility and availability will be difficult at the time of surgery, where we get more number of cases at a shorter time of period. So in this context, we have to know which drug has to be given at which point of time. And the new concepts in the COVID management is one is the combination of treatments. So adding previously we follow the one drug is failing, not responding, adding other drug. Now it is both drugs will be given at the same time, will have good response and good outcome. And another thing, biomarker new developments, the biomarker guided treatment of cytokine storm. So with this brief, these are the available drugs: antivirals, monoclonal antibodies, remdesivir, melphalan not approved, but recently showing good result, and therapeutic modalities to immune dysregulation are corticosteroids, IL-6 blockers and IL-1 blockers. It is also not approved, and Janus kinase inhibitors, and anticoagulants and other treatments. So these are for outpatient. Now we have monoclonal antibodies. For inpatient, we have remdesivir, dexamethasone, tocilizumab, and baricitinib for approved by US FDA, and tocilizumab, dexamethasone, remdesivir. So their role may be discussed in further discussion. So these are the monoclonal antibodies. What are the indications for monoclonal antibodies? Sir, these are particularly useful in used for the outpatient basis and non-hospitalized patients. So non-hospitalized patients with confirmed COVID-19 positive with mild to moderate disease, not severe disease, who have high risk to progress to severe disease or hospitalization. So these risk group we have already discussed, and post-exposure prophylaxis of these groups who are close contacts or who are high risk group of exposure. So these are post-exposure prophylaxis also indicated. Another who are high risk progression I already discussed, and vaccine status. Another thing is vaccination status. Not fully vaccinated, that is either not taken two doses of vaccination or vaccinated within less than 2 weeks. Also prone, and vaccinated but not expected to mount the adequate immune response. These are the vaccinated people still are susceptible, and these groups also we have to give. So one is non-hospitalized mild to moderate disease, another is post-exposure prophylaxis. Another indication for severe disease and critically ill patient is with seronegative status. So these patients can be given monoclonal antibodies along with standard care of treatment, that is corticosteroids and IL-6 receptor blockers. So along with that, we can give in the severely ill patient with seronegative status only. So these are the drugs available for treatment: Bamlanab, etesevimab, and casirivimab and imidivimab combinations. So these are 3 groups of drugs available, monoclonal antibodies. This is a graph showing there is 70% improvement in the hospital prevention of hospitalization and cause of all-cause death when you give monoclonal antibodies. This is the seropositive status. So the more benefit you will be seen in the patients who are given monoclonal antibodies when there is seronegative status rather than their seropositive status. So this is the importance of giving seropositive or negatives monoclonal antibodies. And these are the available drug for us is casirivimab. So it is has effect on all variants of the available variants. So then, so how to infuse in? So we have to infuse during infusion. We have to observe any anaphylactic reactions. We have to prepare for treating the anaphylaxis, and any bronchospasm, angioedema we have to observe. So we have to flow at least 1 hour. After infusion, we have to wait for 1 hour. Observe the patient for 1 hour for transfusion reactions or any anaphylaxis. After that, patient can be discharged, and he can be followed in the next one day, and then next day after 24 hours we have to follow the patient for any development of new onset of reactions. And vaccination after immunoglobulins, you have to wait for 90 days to give vaccination. These are the brief things we have to follow while giving monoclonal antibodies. And other drug is remdesivir. Now the WHO is not recommending, conditional recommending against the use of remdesivir. There is so much controversy in the use of remdesivir. So is COVID adaptive COVID treatment trial 1 demonstrated improvement in the clinical recovery in the group of patients with low oxygen. So, but not in the patients who are receiving mechanical ventilation or NIV. So in the next study, multi-level study, solidarity, WHO solidarity trial demonstrated there is no mortality benefit. Yes.
Sir, I think you have exceeded your time and we are all are waiting for the inaugural function. So kindly conclude in 1 or 2 minutes, sir.
Okay, okay, sir. Okay. So these trials, there is, these are the finally the insufficient evidence either to recommend or against for the use of. We require further evidence and further RCTs to recommend the remdesivir. So that is the status, and it is given to physician choice. If you have, we cannot give remdesivir to all patients, but we have to judiciously use by the physician's opinion at the time of point of care. So, and another thing is steroids, which are very effectively proven in the randomized controlled trials, and very mortality benefit was seen with the patients. The steroids are contraindicated, particularly when the patient is not on oxygen treatment. When they are on invasive ventilation, on oxygen treatment and invasive ventilation, the benefit is more with steroids. So the maximum benefit will be seen in the moderate to severe disease, and when these steroids are combined with mild to moderate disease with remdesivir, shows very good response when giving a single steroid or a single remdesivir. So the combination treatments are working better than single treatment, and immunotherapy targeted therapy pathways are. So IL-6 blockers are very effective in management. Tocilizumab and sarilizumab are antagonists of IL-6 receptors. So this is another JAK receptor. These two are recommended for the use in the severe and critical disease. So WHO recommends IL-6 receptor blockers for patients with severe and critical infections. So along with steroids. IL-6 inhibitors, the high certainty of evidence and the low certainty evidence that they may also reduce the duration of mechanical ventilation hospitalization. That is the status of IL-6 receptors present. So they can be added to more severe disease with steroids. Need not wait for late stage of the disease. And these are the studies which prove mortality benefit to the tocilizumab. So Stop COVID study and Impact study both have shown there is a much improvement in mortality, 10% mortality benefit in Stop COVID study and 2% mortality benefit in severe cases of in the Impact study. These both evidences. Yes, sir. Yes, sir. Yes, sir. 2 minutes, sir. So this. Baricitinib, another Janus kinase inhibitor. This also very much useful in the critical and severe and critical disease. So, when combining with steroids and remdesivir, the mortality benefit is all-cause mortality benefit is 17% in baricitinib is used. So now, when it is not used, it is 29%. So there is a very much improvement with baricitinib. So this is the IL-1 receptor antagonist under trial. So my conclusion is these are the biomarker response. Then the patient is having low CRP and low neutrophil lymphocyte ratio, and these patients will respond better with sarilumab. And when there is another biomarker in the IL-1 response is plasma SOPRA levels more than 6, it will have a good response. So these are the final conclusion is, so the guidelines, a limited number of therapeutics available for outpatient. Multiple trials demonstrate significant reduction in hospitalization combination of monoclonal antibodies. So for inpatients, combination therapy has become standard. So early stage we can add Dexa with remdesivir. In the moderate stage we can add steroids with IL-6 inhibitors. and the addition of anti-inflammatory agents like baricitinib will produce good result in the outcome and mortality benefit and prevent the respiratory failure. So this in brief combination treatments and appropriate level of care of at the time of treatment is more useful rather than blindly giving all drugs at a time or single drug and waiting for adding another drug. So depending on the severity of stage of the disease, we have to add the drugs appropriate level so that we will get more benefit. Thank you very much. Thank you very much.
Thank you, sir. Dr. Subbaragar, sir.
Thank you, sir.
For,
Thank you so much for nicely explaining this COVID updates regarding pathophysiology and therapeutics, sir. Thank you. Thank you so much on behalf of IMA, sir.
Thank you, sir.
Concluding the session, sir. So the next will be the inauguration of the scientific session. So I request the organizers to present a memento to the chairperson and the moderator. So the next we'll proceed with the opening of the in our scientific session. So now I invite so the organizing committee is honored to invite the dignitaries onto the dais. Today's chief guest, Dr. Shiva Reddy Garu, Chairman, AP Medical Council. Sir, kindly come on to the dais. Sir. And today's presiding officer will be Dr. Subramanian Garu, President, IMA State. Then we invite Dr. Shyam Prasad Garu, Vice Chancellor, NTR UHS, onto the dais. Director Ashram, Dr. Rati, Madam Rati Garu, could not make to the this thing. So we are inviting Dr. Anji Reddy Garu, Medical Director Ashram. Dr. Anji Reddy Garu. Dr. Krishnamurthy Garu, Principal, Ashram Medical College. Dr. Srihar Garu, Chairman, IMA AMS Headquarters. Dr. Nandakishore Garu. And the incumbent President, Dr. Srinivas Raj Garu. President-elect. Now he is going to take over the presidency of the AP State IMA. Dr. Srinivas Raj Garu. State. Next, Dr. Hanumantra garu. Hanumantra garu, CA Ashram, sir. Next, Dr. Vijay Mohan garu, Administrator Ashram garu. Dr. Varaprasad garu, Member APMC. And Dr. Srinivas Kumar garu, Superintendent Ashram. So now hand over the mic to Dr. Subramanian garu to conduct the proceedings.
Friends, good morning to you all. First of all, let's have the IMA prayer. I request all of you to please stand up for a while. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you. The flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. Distinguished dignitaries on the dais, my neurosurgical colleague, Dr. Sambasiva Reddy, the chairman of the AP Medical Council and a very important functionary in the government of Andhra Pradesh. My another friend, good friend at Andhra Medical College, Dr. Shyam Prasad, Vice Chancellor of NTR University of Health Sciences. And Mrs. Rati Devi Garu, Director Ashram, Dr. another good friend and then a colleague of mine in RMC, Dr. Anjireddy Garu, Medical Director Ashram, a good friend, Dr. Krishnamurthy, Principal Ashram Medical College, Dr. KCGS Srinivas Kumar, Superintendent Ashram, and my good friend and my classmate, Dr. S. Vijay Mohan Rao, Administrator of the Ashram, Tirsala Dr. Varaprasad Garu, Member APMC, and our own colleague and good friend of IMA, Chairman AMS, Dr. Srihar Rogaru, my friends, members of the Indian Medical Association, ladies and gentlemen. It is indeed a great privilege for me to inaugurate this, to preside over today's function of the CME program of this AP State IMA conference. IMA, ever since we took over IMA AP State, we have been giving a lot of importance and activating the academic atmosphere of our members. And we have got two academic wings, Academy of Medical Specialties and College of General Practitioners, for Academy of Medical Specialties for postgraduate degree holders and diploma holders, College of General Practitioner for all the basic medical graduates. Both the wings we have activated and who have been conducting a series of continuing medical education in the last 1 year. Unfortunately, with the COVID, we could not do many of the physical activities, but at the same time, we learned good lessons from the COVID, conducting various meetings and conferences through the virtual means, which itself is great boon, because even with the physical means, we can't meet all the people, but with the virtual means, we could meet all the people, all the members of IMA AP state, not only this, throughout the nation and even the worldwide, the speakers are participating in our CME programs and other activities. So in this process, I am extremely thankful to our chairman of AP Medical Council, Dr. Samsiva Reddy Garu, who is kind enough to give credit awards to many of our CME programs organized by IMA AP state. Thank you, sir. Thank you very much. And this is very important, as you know, for the re-registration of our medical degrees. We are also thankful to the Health University Professor, Health University Vice Chancellor, Dr. Sam Prasad, who is also very cooperative and is helping us in our Indian Medical Association activities. I am once again thankful to you all, especially to the organizers of Ashram Medical College, the administrators of the Ashram Medical College, who are kind enough to give us this beautiful atmosphere in the academic feast of our IMA, the galleries and the audiovisual equipment. We are also thankful to the organizers of this conference, the Dr. Srinivas Raju, and all the organizing team of IMA at Eluru State. Thank you all. Thank you all. I now request Dr. Srinivas Raju Garu to come and address the gathering.
Welcome to all of you. Dear friends, thank you and every one of you for being here with us today. Today marks our 6th annual state conference, and we are proud to be able to host it today here at this wonderful place with all of you. I would like to thank and acknowledge all the delegates, and on behalf of organizing committee and Eluru branch, I welcome all the delegates here and our virtual platform also. I request all the delegates and participants to take part in all the activities that we have come up with for the next 2 days. Wishing your senses enjoy the wonderful gastronomic and academic feast. Dear friends, after the long gap of 15 years, our Eluru IMA branch is conducting state IMA conference the second time. First time we have done in the year 2005. That also has been organized in this auditorium and in this campus only. For all this, we must acknowledge, and also on behalf of IMA AP State and Eluru branch, we must congratulate and also extend our thanks to the dynamic and academic management of the Ashram Medical College, one and all. And so I said last, but it is most important, sir, the dynamic young chairman of the AP Medical Council, Dr. Samsiva Reddy Garu. He is a chairman of the, not a simple body, it is a quasi-judicial body. This is a AP Medical Council. It has a lot of weightage, has to do in our society, definitely against the quackery and also crosspathy and mixopathy. So I present Dr. Samsiva Reddy Garu, chairman of the APMC, to all of you. And the most dynamic and sincere person who is managing the NTR Health University as a vice chancellor. He is coming all the way to greet us and to bless us today. Thank you, sir. And I must acknowledge my friend, Dr. Srihar Rao, who is the chairman of the Academy of the Medical Specialties of the IMA headquarters. Friends, you all know, IMA has 2 wings, educational wings, that is the College of General Practitioners and also Academy of Medical Specialties. At this juncture, let me take this opportunity to request once again the Vice Chancellor of the NTR Health University. Sir, we will come with the 2 syllabuses for the 2 courses. Please approve those courses, which will give a long mileage to the CGP and AMS, because definitely in the future, IMA AP State, along with the other states, is going to create a IMA Academy of the Medical Sciences. And I must acknowledge Dr. Anjareddy Garu, the octogenarian academician of the Ashram Medical College. Not only Ashram Medical College, he is well versed with the almost all academic institutions in your country. Sir, thank you very much, sir. And the most dynamic and most cooperative and coordinative CEO Hanumantarao Garu, and Superintendent Vijay Mohan Garu, and Administrator and Superintendent Srinivas Kumar Garu, and the most sincere, punctual principal of the college, Dr. Krishnamurthy Garu, and our dynamic secretary, State Honorary Secretary, Dr. Nandakishore Garu. I acknowledge the presence of our Financial Secretary, Dr. Subhash Chandra Bose Garu. Please come. Subhash Chandra Bose Garu. Please. Please come, sir. Please come. I recognize the presence of the great luminaries, starting with Dr. G. Samaram Garu, Dean of the AMC, Dr. Sudhakar Garu, and Indian Resuscitation Council Chairman Dr. Chakrao Garu, and the one and only sincere academician of the all time, Dr. Ashwini Kumar Garu, and my colleague friends and seniors, my past presidents and past secretaries, my young leaders. Thank you one and all. Enjoy.
Now we'll have the lighting of the lamp and also the prayer song.
And the member of the APMC, Dr. Dirisal Varaprasad Rao Garu. We recognize presence, sir. Thank you very much.
सन्ततमहं कुञ्जरमुखं शङ्करसुतं तमिह श्रीविघ्नराजं भजे सन्ततमहं दन्तिसुन्दरमुखम् अन्तकान्तकसुतं तमिह श्रीविघ्नराजं भजे सेवित सुरेन्द्र महनीय गुणशीलं जपतप समाधि सुखवरदानुकूलं भावित सुरमणिगण भक्त परिपालं भयङ्कर विशङ्गमातङ्क कुलकालं श्रीविघ्नराजं भजे कनककेयूरहारावळी कलित गम्भीर गौरगिरिशोभं सुशोभं कनककेयूरहारावळी कलित गम्भीर गौरगिरिशोभं सुशोभं कामादिभयभरित मूढमद कलिकलुषकङ्कितमखण्ड प्रतापं कामादिभयभरित मूढमद कलिकलुषकङ्कितमखण्ड प्रतापं सनकसुख नारद पतञ्जलि पराशर मातङ्ग मुनि संघ सलापं सत्य परमार्जनयन प्रदुत मुक्तिकर त्वमसि नित्यमिघमाति स्वरूपं श्री कुञ्जरमुखं शङ्करसुतं तमिह श्रीविघ्नराजं भजे श्रीविघ्नराजं भजेऽहं 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 भजे तमिह श्रीविघ्नराजं भजे श्रीविघ्नराजं भजे श्रीविघ्नराजं भजे
So next, I invite the chief guest, Dr. Samsivara Reddy garu, to give his address, sir.
This has the okay, right. Let it be. These has కింద పెట్టు. First of all, let me thank Srinivas Garu for the kind invitation to attend this, the offline first of its, I think in 2 years' time, to be as a guest for this occasion. And I also thank Dr. Subramanian Garu for kind words. So first, let me congratulate the IMA for conducting this wonderful conference with very good academic content. And I congratulate all the members who have attended over here and the dignitaries on the dais. Dr. Shyam Prasad Garu, Vice Chancellor Garu, Dr. Anjireddy Garu, Srihari Garu, Tarvata na classmate and Nandakishore Garu, and the other dignitaries on and off dais. So first, we had a great interaction once I became the Medical Council Chairman. The IMA was more or less part of my interaction with the medical fraternity since I think 2.5 years. So as the pandemic came over, I think a lot of interaction we had with the IMA, state IMA, and we were in between the government and the IMA. So we had quite a few meetings in terms of, how to manage this COVID pandemic, and a lot of discussions while preparing the guidelines, how to treat, and then the problems faced by the doctors as well as the hospitals. So all these we were kept on interacting with the past president, starting with Prasad Reddy Garu, and then Subramaniam Garu, and then now I think the president-elect, so Srinivas Garu, were always part of the medical council, as well as he was part of most of the committees as well. He is still heading CME committee of the medical council. So let me say this, I think the doctor fraternity, including the Indian Medical Association doctors, did a tremendous job, selfless, dedicated work during the pandemic, without which I think our state would not have been in this position. See, we did better than many other advanced states where they have much bigger facilities, healthcare facilities. Recently, I visited Kerala, wherein when we compared how we looked after the poor patients in the COVID pandemic, I felt we did far better than even Kerala, wherein the private sector was involved, but not to the extent what has happened in our state. See, one glaring point which I'd like to point out with the COVID management in our state is more than 75 to 80% of COVID admissions were taken care by the government, either in the form of admissions into government hospitals or in the form of admissions under Arogyashri in private hospitals. So in majority of the other states, what happened was the patients had to incur so much money that they had to sell their valuables. So that did not happen in our state, thanks to the doctors who treated more than 50% of admissions in private hospitals also under Arogyashri. So that was commendable with the prices, whatever we have devised. I think Dr. Subramaniam Garu were also involved in fixation of the prices for the hospitals, along with myself and other colleagues. So that is one thing. We could save so many families going into a poverty in our state because of this pandemic. So that's a commendable job, either by the government or by the doctor fraternity in the state of Andhra Pradesh. So that credit goes to even IMA because they have guided the doctors to get involved, starting from the telemedicine services, which they have provided during the pandemic to start with, and later on treating the patients in their hospitals for the prices fixed. So overall, I think IMA was very, very active during the last 2 years, and even government also has given a lot of importance to IMA so that the smooth functioning of the, from the top to bottom happens. So overall, I think there was a synergistic effect happened from the government to the beneficiary. Similar way, I think in the future also, whenever we have some trouble, we are there to convey that to the government, or if there is anything from the government, we will pass on that to the doctor fraternity. So coming to the medical profession itself, see, since the independence, this medical profession has progressed in a the seniors like Dr. Samaram Garu here, I think he is practicing since 40, 50 years, and he knows how it has transcended over last few decades. In 1940s, I think most of the doctors were like, single doctor clinics in the urban areas. There were no doctors in the rural areas. And by 70s and 80s, there were nursing homes managed by wife and doctor or 2 or 3 doctors. Later on, from 80s, the small hospital setups have come up. And then from 90s on, the bigger hospitals, the so-called corporate hospitals have come in. At the same time, the government started, reducing the healthcare budgets. That's when I think private sector took over the healthcare. And with that, the technological advancements have come up, but which has pushed the cost of healthcare very high. By 2004 to 6, as you know, around 4 to 6 crore population are being pushed into poverty every year. So that was the scenario we are facing. So because of all these developments, earlier in 1940s and 50s, when we were curing very few people, but we were relieving pain to some, but we were comforting many of them. But now the scenario has changed. We are diagnosing accurately. We are curing many more patients, and we are relieving almost all the pain. But that comfort aspect is, I think, going off. That's where I think we need to concentrate on. And as the healthcare costs have gone up, and with the technological advancements, even the public, not very much educated in health. They don't know, what are the outcomes of different diseases and all that. It's a doctor's duty to explain them, what is this disease and what are the outcomes. That information, I think we should be giving. And one is lack of information and the escalating costs of healthcare. They have pushed the doctor and the patient apart. That trust has slowly going off. So it is the responsibility of the doctor to build that trust back. How we do it, it's not by fighting. It's not by fighting for rights. It's with the compassion showing towards the aggressor also. That's how you build our trust back. So what we should be doing is to take the confidence and the money aspect. Yes, that also we have to take care. In India, we have sort of a greatest opportunity where no other clinician elsewhere in the world will have. Like the clinician can titrate a treatment plan depending on their education, depending on their financial ability. This cannot be done in any other country because they strictly follow a protocol-based treatments. Wherein in India, as a clinician, you have that leverage wherein you can titrate a poor patient with a limited educational background, limited finances. When you try with some new treatment, which costs them huge, wherein they had to sell their, sort of all the family belongings, that's not required. That should not be advised. Whereas those patients who can afford, who are educated, who can understand, you can try newer things, which can cost huge amounts, which doesn't pain them. So that leverage you should be using as a clinician. That way, I think you should involve the patient with compassionately. Then I think this trust will get back the trust. See, whatever the atrocities against hospitals or whatever stone pelting or beatings of the doctors are happening because the trust is gone. I think we need to build back the trust. So how we do it, I think IMA also should introspect into this. Their association meetings and all that, they should concentrate this aspect also. How to build back the trust. That also should be one of the areas I think these associations should focus upon. So coming back to the IMA association, I can see, a lot of people into 50s and 60s. Rarely I see a guy, except for the medical students in their 30s and 40s. So I think IMA should focus on this younger generation so that who can take forward the legacy of the IMA and then the strengthening of these professional bodies, which is a very essential part of our medical profession. So try to encourage these youngsters to be part of the medical professional bodies. And hopefully, I think in the future, under Srinivas Rasgari's guidance, probably the number of registrations should go up. As you see, we have around 60,000 doctors in the state, and state IMA has about, say, I don't know, around 15 to 18,000 people registered. So hopefully you can drive this younger generation into the IMA fold so that they can take forward this legacy. And a few things about the medical council. What are all the things which we have done in the past 2-3 years? We have started an online portal. Already the provisional registrations for the house surgeons is happening online. I think Principal Garu should be happy about it. So next is even the renewals will be done online, I think in next few weeks time. Only a doctor should come to the council for a permanent registration at the first time. So rest of the certificates and renewals will happen online. They don't need to visit the medical council. Like good standing certificates, NOC certificates and all can be obtained online. And the financial assistance we are giving for CMEs, for non-clinical professional bodies for conducting their CMEs. Probably we can increase that amount also, whatever we are giving now, 25,000 rupees we are giving from the medical council. Probably we can increase that maybe in the next, once we have a discussion, probably we can increase that as well. And journal IMA CMEs, I think because of the pandemic, we could not conduct these in the last 2-3 years. Probably we can start them back and medical council will sponsor those events. So And CME credit hours, there is a discussion going on for the professionals above 75 years, whether we should exempt them from obtaining the CME credit hours or not. Personally, what I feel is the doctor, whoever is practicing, should be learning all the time. It's not that, COVID is a typical example wherein if you don't learn what is COVID and how you treat and what is the drug to be used and all that, how can you treat, see, there is some objectivity to what you learn. The credit hour is some sort of an objectivity so that we know that, this gentleman is learning. So maybe we can reduce the credit hours, and now online CMEs have come up, and online CME credit hours we are issuing, and those guidelines prepared by Srinivas Raj Garu only. So hopefully we can discuss, probably instead of 30 credit hours, we can reduce the credit hours, maybe say 15 or so for doctors who are more than 70 or 75 years. That also probably we will discuss in the next few months, and then we can come to a reasonable agreement upon that. And the other aspect came up in the last general body meeting in medical council was to provide study material to the postgraduates and medical students in the medical colleges. Even medical council can do that. I've asked the director of medical education to send the proposals. Probably we can support in that aspect as well. So medical council is prepared to support, to go to any extent to support the continuous medical education, either for the students or for the physicians. So, and the other aspect, as I was discussing with Nandakishore, which came up is, the fire safety for the buildings and all that. Being a executive vice chairman for Arogyashri Healthcare Trust, at the moment, we are not objecting to a great extent to enroll into the Arogyashri scheme for these hospitals. But what we should understand is, nowadays the practice has become, the medical practice or practice of a doctor has become such a difficult proposition, as the acceptance of a minor error is not there. So as we move forward for the quality healthcare, and again we are stuck at, my building doesn't have a 3 feet staircase, I don't have a fire safety measures, or my building is built 50 beds in say 300-400 square yards. These things may not last very long. So what we should understand is, as we move forward, it is the quality healthcare which matters rather than, quantity. Now, we are able to provide healthcare to most of the individuals now. Okay, earlier 70s and 80s, not all the people were getting the healthcare. They were not even reaching out to the healthcare. But now, everyone can reach out to a healthcare facility, but now the concentration will be on the quality and the outcome-based payment system also might come out in the very near future. So what we should be concentrating on is creating a facility which is suitable for providing healthcare, as well as in a standard which is prescribed, and with a quality outcome. So, but even then, whatever facilities which have got some fire norms difficulties, probably definitely I will also take that up with the government, and we'll see what best we can do. So finally, what I conclude is, all activities of a man should lead to happiness. Happiness only comes with righteousness. So it is the bounden duty of a man to be righteous in every action. So then only you will be happier. If you are not righteous, whatever you achieve, wealth, fame, name, you won't be happy. So try to be righteous. So you will be happy. Thank you. Thank you all.
Thank you, Dr. Samsivreddy garu, for your excellent message and your advice. You have rightly pointed out that the membership of the Indian Medical Association has to be increased. A large number of medical graduates are not the members of this thing. In this connection, we request your good officers to help us in improving our membership strength. As you know, many other countries, the membership in an association is important for becoming a council member. So I request when these graduates, young graduates are coming to you for registration in the medical council, to please you instruct them, may not be official order, but instruct them, or maybe an official order, to become the members of the association before registering that thing. And whatever way or ways you suggest, we are there to follow. And if you want some of us to come and help there or use your good offices in any way, please do in improving the membership of this strength. Thank you. Thank you very much.
Next, I invite Dr. Shyam Prasad Garu, Vice Chancellor, NTR UHS, to give his message.
Thank you, friend. Om Sai Ram. Harihi Om. Namaste. Very good morning. Vedika Nalankarichinna Peddalu. Fellow, one of my classmates is also here, Dr. Mahesh, Guruvulu, Samaram Garu, teachers. Maku cheppalante Anjireddy gaరి దగ్గర నుంచి అందరూ టీచర్సే, ప్రొఫెషనల్ ఫ్రెండ్స్, ఆల్ ఆర్ హియర్. ఒక స్టేట్ కాన్ఫరెన్స్ మొట్టమొదటిసారిగా వర్చువల్ కాకుండా ఆ వర్చువల్తో పాటు నిర్ణయించడం అన్నది చాలా బాగుంది. ఈరోజు అందరినీ పర్సనల్గా కలుసుకున్నాం. 1.5 yearగా లేని చిన్న అంటే మాస్క్ వేసుకోవాలా వద్దా, శానిటైజర్ తీయాలా వద్దా, ఒక్కోసారి ఫోటో కొరకు మొహం చూపించాలా వద్దా, ఇట్లాంటి బిడియంతో కొత్త పెళ్లి కూతురులాగా లోపలికి వచ్చాం. దాన్ని అలా అనొచ్చో లేదో కానీ సరే, ఇది మొదలు. ఫస్ట్ లెట్ మీ కంగ్రాచులేట్ IMA. లాస్ట్ 2 years బ్యాక్ శ్రీనివాసరాజు గారు నన్ను కలిశారు. వాళ్ళ IMA వాళ్ళందరూ కలుద్దామండి. ఎందుకంటే ద గ్రేట్ వర్క్ ఇన్ ఫస్ట్ వేవ్ ఆఫ్ కోవిడ్ వాజ్ గివెన్ బై మీ. నాకు ఎందుకు ఇచ్చారంటే ప్రైవేట్ మెడికల్ కాలేజీలంతా ఒక లైన్లో పట్టుకోరండి అన్నారు. ఆ రోజుకి తెలుసు మన ప్రిన్సిపాల్ గారు వీళ్ళందరితో మాట్లాడాం, మిగతా వాళ్ళకి చెప్పాం. మొట్టమొదటిగా వచ్చింది వీళ్ళే. ఆ రోజుకి ఒక్క ల్యాబ్ కూడా లేదు, RT-PCR ల్యాబే లేదు స్టేట్లో. 10th of I think in March they started. గవర్నమెంటే ఈ కాలేజీలో మొదలు పెట్టింది. విజయనగరంలో గవర్నమెంటే మొదలు పెట్టింది. సో 2 పెట్టారు, తిరుపతిలో పెట్టారు మొదలు, తర్వాత విశాఖపట్నంలో పెట్టారు. అలా వరుసగా అయిపోతూ ఉన్నాయి. అన్ని కాలేజీల వాళ్ళు ఏమి ఆశించకుండా, they never, we promised so many things like a politicians, but they agreed, they come back with the government. Government cannot alone do it. Lot of people are involved. And see, so many warriors in a dental colleges are 16 in number. All of them come. 20,000 warriors are registered for this purpose. Srinivasaraju gariki telusu. అక్కడ ఏంటి, వీళ్ళని ఎక్కడ వాడాలో మాకు అర్థం కాలేదు. What we say is, go back to your district collectors. They are given full powers to utilize ourselves. వాళ్ళు దేనికి పనికొచ్చారంటే లైన్ నిలబెట్టడానికి, టైప్ చేయడానికి. సర్జరీ పేజెస్ ఆర్ ఇన్ ది వార్ రూమ్, టైపింగ్ ది థింగ్స్ ప్రాపర్లీ. రోజు ఏమో జరుగుతుందని, రోజు ఉదయాన్నే నేను సాంబశివరెడ్డి గారు, చంద్రశేఖర్ రెడ్డి గారు, తర్వాత వీళ్ళందరూ కలిసి మన జవహర్ రెడ్డి గారితో కూర్చొని, ఏమయ్యా ఈ కొంతకాలం ఇక్కడ పని చేస్తా ఉన్నాను. చేస్తాను సార్ అంటే పనే ఉందండి, ఎక్కడ పని ఉంటే అక్కడ చేయడమే కదా. మార్నింగ్ నుంచి నైట్ వరకు 8 వరకు చేసేవాళ్ళం. 8 తర్వాత నా యూనివర్సిటీకి వెళ్ళి నా సంతకాలు అయి పెట్టుకోవడం, డెసిషన్లు చెప్పుకోవడం చేసాం. ఆ రోజు అలా జరుగుతుందని అనుకోలే. ఫస్ట్ వేవ్ ఎంత చక్కగా జరిగిపోయిందండి. మన జోబులో డబ్బులు లేవు, ఎక్కడొచ్చి డబ్బులు తెచ్చుకున్నాం, పని చేసాం. కొంతమంది దగ్గర మాస్కులు లేవు, పీపీఈలు లేవు. అందరికీ తెలుసు, ఏం చేయాలో ఎవరికీ తెలియదు. ఒక తెలియని భూతం మన ఎత్తున కూర్చుంటే దాన్ని ఎలా ట్రీట్మెంట్ చేయాలో కూడా మనకు తెలియదు. సరే, హైడ్రాక్సీ క్లోరోక్విన్ అందరం వేసుకున్నాం. ఒక 3 నెలలు అయిన తర్వాత ఇది పనికిరాదు తీసేయండి అని తీసేశారు. కొన్ని చోట్ల రెమ్డెసివిర్ మొదలుపెట్టాం. అలాగ మందులు వచ్చాయి, ఒక్కొక్కటి వచ్చాయి. అందువలన దీంట్లో గొప్పగా పనిచేస్తున్నాడు అన్నిటికన్నా అంటే ఇది కోవిడ్ మ్యాట్రియర్ మెమోరియల్ హాల్ పేరు పెట్టిన రతీదేవి గారికి ముందు మనం శిరస్సు వంచి పాదాభినందన చేయాలి. ఎందుకంటే మన దగ్గర తెలుసు 2000 మంది డాక్టర్లు చచ్చిపోయారని. వాళ్ళకి మనం ఏం చేయగలిగాం? ఐఎంఏ చాలా చేసింది, చిన్న చిన్న వాళ్ళు చాలామంది చేశారు. వాళ్ళలో మన స్నేహితులు ఉన్నారు, రోజు చూసే మొహాలు ఉన్నారు. వాడు లేడు అనే భావం మనకు ఉంది ఎప్పుడు. దానికి మనం ఏం చేసావో చెప్పలేని పరిస్థితుల్లో ఈ హాల్కి పేరు పెట్టడం చాలా గొప్ప విషయం మేడం. అండ్ వీ విల్ కన్సిడర్ మై సెల్ఫ్ యాజ్ వీఆర్ రియల్లీ apt for conducting this one second time in the same hall with that name. తర్వాత అండి, ఇందులో ఒక్కొక్కరు నేను 3 డికేట్స్గా ఐఎంఏలో చూస్తూ ఉన్నాను. 1990 నుంచి యాక్టివ్గా ఉన్నాను. ఎన్నప్పారావు గారు నాకు చాలా క్లోజ్. ఆయన చెప్పేటప్పుడు, ఏమయ్యా నువ్వు వచ్చి నువ్వు ప్రెసిడెంట్షిప్ చేస్తా సార్, నేను 1000 గుళ్ళ పూజారిని, నాకు చాలా గుళ్ళు ఉన్నాయండి. ఆమె సోషల్ సైంటిస్ట్, వాలంటీర్ ఆర్గనైజేషన్ మేనేజ్మెంట్ కానీ మా నాన్నగారు చెప్పిన పద్ధతులు బట్టి నేను చాలా తెలియకుండా తెలిసి ప్రింట్ మీడియంలో రాకుండా సహాయాలు చేస్తున్నాను. వైజాగ్లో ఎవరిని అడిగినా చెప్తారు. అది నేను 30 ఏళ్ళుగా చేస్తున్నానండి. ఐఎంఏకి వస్తే అక్కడ బాగా చేయాలి, ఎందుకంటే ఐఎంఏ అందరు చూస్తారు ఏంటి వీడు ఏం చేస్తున్నాడని. నన్ను వైస్ ప్రెసిడెంట్గా పెట్టారు. దయచేసి అక్కడ వాళ్ళు ఎంత చక్కగా పనిచేస్తారు, నేను ఉన్నా లేకపోయినా అన్ని పనులు చేశారు. సుబ్రహ్మణ్యం గారు తెలుసు నాకు. ఇప్పుడు రవిరాజు గారు పనిచేసినప్పటి నుంచి నేను పీజీగా ఉన్నప్పుడు చూశాను ఆయన చేయడం. మిగతా పనులకు అన్నిటికీ వస్తాం. ఒక కరెక్ట్ టైంకి రాలేని వ్యక్తి దాంట్లో పనిచేయడం న్యాయం కాదు. ఐఎంఏ అంటే మీరందరూ సోల్జర్స్, ముఖ్యమైన వాళ్ళే వచ్చారు ఈరోజు, మిగతా అందరూ ఆన్లైన్లో ఉన్నారు. వాళ్ళందరూ కూడా తెలుసు. మీరు స్థితి చేయాలంటే ఒకసారి రమణి ఎంత పనిచేసిందండి అమ్మాయి. వి స్టిల్ రిమెంబర్ ద గ్రేట్ వర్క్. షీ ఈజ్ అన్ అసోసియేట్ వన్స్ అపాన్ అ టైమ్, షీ ఈజ్ అ ప్రొఫెసర్ నౌ. వీ సీ స్మాల్ పాలిటిక్స్ ఆర్ దేర్. పాలిటిక్స్ ఆర్ ఇన్ఎవిటబుల్ ఇన్ ద లైఫ్. చిన్న దెబ్బలాడుకున్నాం, చిన్నపిల్లలాగా అందరూ కలిసిపోయాం. ఒక అవసరం ఉంటే కోవిడ్ తర్వాత అంత మంచి పని చేశారు మీరందరూ. తర్వాత ఈ 3 decades ఐ సీయింగ్ సో మెనీ. ఐ హావ్ డెలివర్డ్ 2 lectures ఫర్ ఐఎంఏ. అశోక్ నేను బాగా నచ్చాను. వాళ్ళ ఫాదరు మా ఫాదర్ క్లోజ్ ఫ్రెండ్స్. మా ఊరికి ఇవ్వాలని ఇచ్చాడో ఏమో మరి, 2 నేనే డెలివర్ చేశాను. కోడి గురించి మాట్లాడాను, డయాబెటిక్ ఫుడ్ ఇన్ఫెక్షన్స్ మాట్లాడాను. ఇక్కడ చేయాల్సిన పని నేను అదే, మాటలు చెప్పడం, ప్రజల్ని ఉత్తేజపరచడం, ఏదన్నా అలాంటివి. అపార్ట్ ఫ్రమ్ అవర్ అకాడమిక్ అండ్ అదర్ థింగ్స్. మీరు అకాడమీ గురించి అడిగారు సార్, అది తప్పక చేద్దాం. మీరు రండి. మేము అన్ని మెడికల్ కాలేజీలకి చెప్పాం ఏమంటే కొత్త ఫెలోషిప్లు చెప్పండి. ఎందుకంటే ఇక్కడ ఎక్కువ మంది ఎంబీబీఎస్ డాక్టర్లు ఉన్నారు. ఈ దేశంలో 580 మెడికల్ కాలేజీలు ఉన్నప్పుడు 80,000 మెడికల్ పర్సనల్ ఎంబీబీఎస్ వాళ్ళు బయటకు వస్తున్నారు. ఒక 7,000 మంది ఫారిన్ గ్రాడ్యుయేట్స్ వస్తున్నారు. అంటే దగ్గరగా 1,00,000 మందికి ఉన్నారు. అప్పుడు మీరు భయపడ్డారు, గుర్తున్నారా? బీడిఎస్ నుంచి ఒక బ్రిడ్జ్ కోర్స్ పెడుతున్నారని. అది టోటల్గా నేషనల్ మెడికల్ కౌన్సిల్ మెంబర్ నేను. వాళ్ళు ఇది చేయడానికి కుదరదని చెప్పారు. కారణం ఏమంటే 1,10,000 మంది డాక్టర్లు వస్తున్నారు. వాళ్ళకే మనం దారి చూపించడంలా. వాళ్ళు చెప్పిన రేషియో 1 in 1000 వీఆర్ రీచింగ్ సూన్, విత్ ఇన్ ప్రాబబ్లీ 1 or 2 years. అందులో ఈ దేశంలో తయారవుతున్న 6 నుంచి 7 కోట్ల వ్యాక్సిన్స్ ఎగుమతి చేశారు సెంట్రల్ గవర్నమెంట్. గొప్ప విషయం. అది మనందరికీ వచ్చాయి. 2 డోసులు వచ్చాయి, 3వ డోసు కూడా వేసుకున్న మహానుభావులు ఉన్నారు ఇందులో. ఎందుకంటే ఎవరి ఏజ్ వాళ్ళది, ఎవరి కష్టాలు వాళ్ళవి. ఇది కోవిడ్ గురించి. రెండోది వీళ్ళు అకాడమిక్గా వాళ్ళు, నేను సుజాతమ్మ అన్న మా కజిన్ ఒక అమ్మాయి ఉంది నెల్లూరులో, వాళ్ళు రెగ్యులర్గా మీకు ప్రతిదానికి ఏమేమి జరిగింది విషయాలు నాకు చెప్తూ ఉండేవారు. ఏం జరుగుతున్న టాపిక్స్ కూడా. ఏమంటే ఈరోజు డయాబెటీస్ గురించి చెప్పారు, ఎంత చక్కగా చెప్పాడు ఆయన. ఈజ్ అ గుడ్ ఫ్రెండ్ ఆఫ్ మైండ్. అంత చక్కగా ఎవల్యూషన్ ఆఫ్ ఏ న్యూ ఇన్సులిన్, ఒక డయాబెటిక్ ఇందులో నిలబడేది చూస్తే, ఓహో ఇన్ని 100 ఏళ్ళ తర్వాత ఈ గ్లార్గ్యాన్ వచ్చింది. గ్లార్గ్యాన్ తర్వాత ఈ రోజు ఇది కొత్తది వచ్చింది, సబ్కుటేనియస్గా పెన్ను మాదిరి జోబులో పెట్టుకొని వెళ్ళిపోవచ్చు అని. రీసెర్చర్స్ కూడా చెప్పాడు, ప్యాంక్రియాటిక్ ఇంప్లాంటేషన్ ఫ్రమ్ ఏఏజే హాస్పిటల్ హైదరాబాద్. సో మచ్ ఇన్ఫర్మేషన్ ఫర్ ఎ కామన్ మ్యాన్. చిన్నగా ఎంబీబీఎస్లో ఒక 70-80 ఏళ్ళ ప్రకారం ఇక్కడే ప్రాక్టీస్ చేస్తున్న వాళ్ళకి యు ఆర్ గివింగ్ ద రీసెంట్ అడ్వాన్సెస్ ఇన్ ది టాపిక్. వాట్ మోర్ యూ నీడ్? ఇది కాకపోతే ఇంకెక్కడికి? మీ దగ్గర కాదు డాక్టర్ గారు, నేను వెళ్తాను, నా దగ్గర డబ్బులు ఉన్నాయి చూపించండి. ఎక్కడికి వెళ్తారు? మెడ్రాస్కి వెళ్ళాలా, విజయవాడకి వెళ్ళాలా? ఇక్కడి నుంచి ఏది దగ్గర ముందు విజయవాడ చెప్తారు, అక్కడ కుదరకపోతే మిగతా చోటుకి పంపుతారు. దీనికి చాలా కృషి చేశారు ఐఎంఏ వాళ్ళు. We will all members, administrators, I've seen from Vijayanagaram, Visakhapatnam, Srikakulam, and these are the people who have done it. Next, a great man from Kakinada, he made an entry here as an anesthetist. Chakkar Rao garu. ఆయన ఇంటర్నేషనల్ ఫిగర్ అయ్యాడు. కారణం ఏంటంటే అందరితో కలిసిపోతాడు చిన్నపిల్లల్లాగా. ఆయన మాకు 3-4 సంవత్సరాలు సీనియరు. అయినా కూడా చిన్న పిల్లోళ్ళు మా దగ్గరకు వచ్చి మేము నేర్పుతామండి ఇది అన్నారు. దారిలో పోతున్నప్పుడు ఒక సడన్గా కార్డియాక్ అరెస్టో రెస్పిరేటరీ అరెస్టో వచ్చినప్పుడు ఏం చేయాలన్నది కామన్ మ్యాన్కి నేర్పడానికి 5 లక్షల మందికి మొదలెట్టాడు. అదే ప్రోగ్రామ్ మేము కండక్ట్ చేసాం. అలాంటివి చాలా చేసాం యూనివర్సిటీ తరఫున. కాబట్టి అట్లాంటి వ్యక్తి దీంట్లో ప్రతి అందరికీ నేర్పాలా. ప్రతి విలేజ్కి వెళ్ళి, ప్రతి కాలేజీకి వెళ్ళి, స్కూల్కి వెళ్ళి, మీ ఎప్పుడైనా చనిపోయే ముందు నీ చుట్టుపక్కల డాక్టర్ ఉంటాడు, నమ్మకం లేని రోజులు ఇవి. అలాంటప్పుడు మీరు ఏం చేయాలో స్టెప్ 1, 2, 3, 4 అని చెప్పాడు. అంత గొప్ప ఆయన. కాల్స్ అని, COLS, కంప్రెషన్ ఓన్లీ టెక్నిక్ ఫర్ దెమ్. సిపిఆర్ రాని వాళ్ళు కూడా నేర్చుకోవడానికి నేర్పాడు. ఇదంతా ఐఎంఏ ఘనత. అది ఇచ్చిన గౌరవం ఆయనకి, విశిష్ట పథకాలు ఇచ్చే ఆయనకి, అందరికీ చాలా గ్రేట్ థింగ్స్. అందులో మా గురువు గారు అయిన అశ్విని కుమార్ గారికి, సత్సాయి డివోటీగా నేను ఆయన 4 డికేడ్ల నుంచి చూస్తున్నాను. ఎంత చక్కగా చెప్తారు. పుట్టపర్తికి అందరూ కలిసి వెళ్తే సాయంకాలం ఆయన కూర్చోబెట్టి కొంచెం మంచి విషయాలు చెప్పాడు. ఆయనతో మాట్లాడితే ప్రపంచం ఇంత గొప్పదా అనిపిస్తుంది. ఈ రోజుకి మచిలీపట్నంకి వెళ్ళి ఒక డయాబెటిక్ క్లినిక్ ఆయన నడుపుతున్నాడు. ఈ రోజుకి వీళ్ళు ఆనరల్ ప్రొఫెసర్గా పనిచేస్తున్నాడు. ఆయనకి శిరస్సు వచ్చి నమస్కారం ఇస్తున్నాం. వీళ్ళందరూ సమరం గారు చేసిన పనులైతే మనం ఏం చెప్పలేము. ఆయన చేసే వర్క్ కానీ ఎప్పుడు ఆయన అడుగుతూనే ఉంటాడు. ఎప్పుడైనా ఖాళీ వస్తే మాతో మాట్లాడండి అంటారు. మాట్లాడడానికి రెడీయే. చాలామంది మాట్లాడే వాళ్ళు ఉన్నారు, నాకన్నా గొప్ప వాళ్ళు ఉన్నారు. ఇక్కడి వరకు నడుచుకొచ్చాం, తప్పక మాట్లాడతాం సార్. కొత్త విషయాలు మా మిషన్ అంటే మా కొరకు ఏంటంటే ప్రతి సంవత్సరం 70,000 మంది కార్సినోమా బ్రెస్ట్ చనిపోతున్నారు. వాళ్ళందరికీ స్టేజ్ 1 డిసీజ్ రమ్మని మేము కోరుకుంటున్నాం. బ్రెస్ట్ సెల్ఫ్ ఎగ్జామినేషన్ ఆల్మోస్ట్ నేను ఒక 15 కాలేజీల్లో చెప్పానండి. ఏదో ఒక ప్రోగ్రాం పెట్టి ఇది చెప్తున్నాం. ఆడవాళ్ళు వాళ్ళు బ్రెస్ట్ టెస్ట్ చేసుకొని ఏమైనా తేడా అవుతే ఇమీడియట్గా వస్తాయి. మేము 1970 ప్రాంతంలో స్టేజ్ 4 డిసీజ్ చూసేవాళ్ళం. ఈ రోజు కూడా స్టేజ్ 4 డిసీజ్ చూస్తున్నాం. ఇది అమాయకత్వం తెలియదు, మనం వాళ్ళకి హెల్త్ ఎడ్యుకేషన్ ఇవ్వాలో తెలియదు. నేను ఐఎంఏ వాళ్ళు అర్థించేది ఏంటంటే క్యాన్సర్ ఇప్పుడు నాన్ కమ్యూనికబుల్ డిసీజ్ అన్నది ప్రపంచంలో పెరిగిపోయాయి. ఇంతకుముందులాగా ఇన్ఫెక్షన్ డిసీజెస్ లేవు, డయేరియా, డిసెంట్రీ లేవు. మనకున్నదే ఒకటి, డయాబెటీస్, హైపర్ టెన్షన్. ఇంకా నెక్స్ట్ ఇంపార్టెంట్ థింగ్ ఈజ్ మనం చూసే దాంట్లో ట్రామా. నెక్స్ట్ ఇంపార్టెంట్ ఈజ్ క్యాన్సర్. క్యాన్సరే ఆక్యుపై చేస్తుంది 70-80%. దాంట్లో కార్సినోమా బ్రెస్ట్, కార్సినోమా సర్విక్స్ గురించి విపరీతంగా పల్లెల్లో చెప్పాలి. మనం చిన్న చిన్న వర్కర్లోకి చెప్పాలి. ఆడవాళ్ళకి పని చేసుకునే వాళ్ళకి తెలియదు పాపం. వాళ్ళు స్టేజ్ 1లో వస్తే క్యాన్సర్ ఇస్ క్యూరబుల్. క్యాన్సర్ ఇస్ క్యూరబుల్ ఇఫ్ యు కమ్ ఇన్ స్టేజ్ 1 డిసీజ్. మనకి 98% 5 year సర్వైవల్ రేట్స్ ఉన్నాయి. నా చిన్న ఈ అవకాశం ఇచ్చినందుకు అందరికీ సభాముఖంగా రాజు గారికి, ఐఎంఏ వాళ్ళకి, మా కృష్ణమూర్తి గారికి అండ్ రతిదేవి గారి మొత్తం టీవీకి చాలా అందంగా ఉంది మేడం. ఇది చాలా చక్కగా తయారు చేశారు. ఇట్లాంటి పనులు మీరు ఎన్నో చేయాలని కోరుకుంటూ థ్యాంక్ యూ వెరీ మచ్.
So we conclude the inauguration and we are proceeding with the memento presentation. I invite Dr. Krishnamurthy Garu, Principal, sir, for the vote of thanks, sir.
Dignitaries on the dais, off the dais, the delegates, a very good morning and a warm welcome to the scientific program. Now it's my privilege that our institute has been chosen as the venue for the 6th APCON, and for this I thank the organizers, exclusively Dr. Srinivas Raju, for giving us this opportunity, and it's a privilege for all of us. I thank Dr. Srinivas Reddy, the chief guest, for taking his valuable time and coming over here and giving a very elaborate address as to indicating our responsibilities and how professionalism should be introduced in the practice of medicine. The practice of medicine about 25 to 30 years back was different from what is now, and now what is the need of the hour is professionalism. I thank you, sir, for your valuable suggestions. So also I thank the president of IMA, Dr. Subramanian Garu, the Vice Chancellor of Dr. NTR University of Health Sciences, Dr. Shyam Prasad Garu, then the leadership of the IMA and the President-elect, Dr. Srinivas Raj Garu, Dr. Nandakishore, Dr. Bhaskar Reddy Garu, Dr. Varaprasad Rao Garu, AP Medical Council member, and Dr. Srihar Rao Garu for taking their valuable time and inaugurating this scientific session. I also thank the Chief Executive Officer of Ashram Hospital and Medical College, Dr. Hanumantarao Garu, the Medical Director, Dr. Anjareddy Garu, and the Medical Superintendent, Dr. Kumar, and also the Hospital Administrator, Dr. Vijay Mohan Rao Garu, and for all of you to come over here and making this function a very grand success. Thank you very much. And I'm sure you are going to have a very interesting scientific session ahead. Thank you all.
Sir, first Dr. Samsaya Reddy Garu. Dr. Anjareddy Garu. ఇచ్చారు ఎవరో డాక్టర్ శ్యామ్ ప్రసాద్ సార్. డాక్టర్ అంజిరెడ్డి గారు. నెక్స్ట్ డాక్టర్ శ్రీహరి గారు. శ్రీహరి గారు. నెక్స్ట్ డాక్టర్ వరప్రసాద్ గారు, మెంబర్ APMC. డాక్టర్ కృష్ణమూర్తి గారు, ప్రిన్సిపల్ ఆశ్రమ్. డాక్టర్ కృష్ణమూర్తి గారు. విజయమోహన్ గారు, డాక్టర్ విజయమోహన్ గారు. హనుమంతరావు గారు, CEO ఆన్ బిహాఫ్ ఆఫ్ డైరెక్టర్ రతీదేవ్ గారు. డాక్టర్ నందకిషోర్ గారు. డాక్టర్ సుభాష్ చంద్రబోస్. డాక్టర్ సుభాష్ చంద్రబోస్ సార్.
I request working committee members to assemble in Gangadhara Memorial.
So with this, we have concluded the inauguration of the scientific sessions. So చేంజ్ ఏం లేదు. చేంజ్ ఏం లేదండి లేదు డేట్ ఏం చేంజ్ లేదు ఎక్కడ చేంజ్ చెప్పండి మీకు ఇది కాదు మీరు చేంజ్ అది కాదు ఇది మార్చేసారు మీరు సెకండ్ డే విజయశేఖర్ గారు అది
I request all the members of the state working committee to kindly come to the working committee hall, please, as early as possible. We are already late for the working committee meeting.
కంటిన్యూ చేసేయండి Sir, all the working committee members are requested to proceed to the hall, Charaka Hall at the ground floor. The academic program will continue, sir. So we are proceeding with the next session. The next session would be chaired and moderated by Dr. Satyanarayan Garu. Dr. Satyanarayan Garu, gastroenterologist, Eluru. And Dr. Tamiraj Garu, cardiologist, Ashram. Okay, sir. Okay, sir. Okay, sir. Sir, virtual chapter. Sir. Okay. So I invite Dr. Vijay Prasanna Garu, rheumatologist from Vijayawada, to kindly continue with her lecture. And I request the moderator and co-chairman to take over the session.
So initially, I thank Dr. Vijay Prasanna Kumari for accepting our invitation and coming as a guest lecture. And I'm very pleased to give introduction about her. She did her MD General Medicine and then DM Rheumatology from NIMS Hyderabad. And she's a member of Indian Rheumatological Association and IRA Hyderabad chapters. Her special interest is in rheumatoid and spondyloarthritis, SLE, autoimmune disorders in children, and teaching undergraduates and postgraduates. Her special skills are she's one of the very few qualified rheumatologists in twin Telugu states. She does basic musculoskeletal ultrasound guided procedures. She has good technical skills in performing many of the rheumatological procedures like skin biopsy, ulcerated biopsy, minor salivary gland biopsy, kidney biopsy, and intra-articular injections. Now, I request Dr. Vijay Prasanna Garu to deliver her lecture.
Thank you, sir. Thank you for your kind a very good morning to all. At the outset, I thank the organizers for considering me capable of talking on this important topic. And also, I feel privilegedly honored to stand before my teachers, seniors, and my juniors. Can I have all the delegates in their places? I request all the delegates to have your seats, please. So in the next couple of minutes, I'll be dealing about the commonly performed serological test pertaining to rheumatological evaluation of a patient. So many of the patients with autoimmune diseases, they present with a varied clinical manifestations. These manifestations at times pose a challenge to the physician and also creates a lot of confusion in any part of their clinical evaluation, be it a diagnosis, be it at management. So however, like in all specialties of medicine, a detailed clinical history and a physical examination contribute to majority of the diagnosis at the bedside. So whatever the lab investigations we are doing, they only add 5% to our diagnosis, and they either confirm our diagnosis or refute our diagnosis. Especially in rheumatology, this laboratory medicine, apart from helping us to establish our clinical diagnosis, they also help us in categorizing the end organ involvement to assess the disease activity and also to assess the prognosis of the patient. Thereby, they form an important role in the management of these patients. However, in this current era of demand for high value of care and also a widely being used most of these investigations, like a rapid ordering of these investigations, there have been a global concern regarding their inappropriate use. So inappropriate ordering of these clinical investigations, they are very harmful lethally, because especially the patients who are suffering with rheumatic diseases, and to differentiate them from those who doesn't have an autoimmune disease, but they have some musculoskeletal manifestations, which bring into the suspicion that they might be having some rheumatological illness. So in such patients, if a test comes positive and if we think that it is a true positive and subject them to an unnecessary immunosuppression, definitely the patient lands in the drug adverse side effects, thereby increasing the increasing the stay in the hospital, leading to an increased financial burden both to the patient and to the family. Apart from that, they are also associated with medical legal issues, and also they promote unnecessary auxiliary investigations. Having said that, an appropriate use of these investigations is very important. But if we underutilize them, there is also a lethal consequence of underdiagnosing these patients, thereby leading to increased morbidity and mortality associated with these illnesses. So this is the crux of the last two slides. What I have said is these are used for diagnosis, to assess the disease activity, to assess the end organ involvement, to assess the prognosis and response to the treatment. However, the misuse leads to misdiagnosis with inappropriate therapy with high dose steroids or any of the steroid sparing immunosuppressive agents, unnecessary healthcare burden, and an emotional trauma. So before ordering any of the rheumatological investigations, we should have a thorough clinical history and detailed patient examination. And before ordering it, we should know the characteristic performance of the test. So what is the likelihood ratio of these tests to be positive or negative in that particular patient? So before ordering that, we should have the clinical context in our mind. So every investigation which we order should be in the clinical context and not like a fishing tour, especially when dealing with a patient in suspicion of autoimmune diseases. So because of this global concern of increasing this utilization of these investigations, there has been many international campaigns which facilitates many of the treating physicians or practicing physicians, which guide them regarding the evidence-based recommendations for appropriate care of these patients, like Choosing Wisely campaign in US and Do Not Do in UK, wherein they have specially mentioned regarding testing ANA, which I'll be dealing in the next slide. So with this short background, the objectives of my today's talk will be, I'll be discussing the commonly doing serological test, which we do very routinely in our clinical practice to establish a diagnosis of autoimmune disease. And what are the false positivities? What are the other conditions which mimic rheumatological illness and wherein the tests are positive? And what are the diagnostic utilities and the limitations of these tests? So this, like a black hole which we have in our universe, there is also a black hole in our medical knowledge. Especially when we are doing our UGs, we are not aware, neither the Harrison nor the Davidson has described clearly about any of this rheumatological illness, especially the test which we used to do. So when we came directly to our house agency to treat a patient, we are clearly like in a blank mind whether we have to take this positivity without any clinical manifestations or clinical evidence of rheumatoid arthritis. Or if we have a strong clinical suspicion and the test is negative, how to interpret these tests is a basic dilemma. And even now, I think that the same dilemma exists to most of our UGs because rheumatology is not being considered a specialized subject in UGs. So this is a self-explanatory diagram wherein you can see unless and until you know what test you are ordering in a current patient, and if you order a battery of tests and if all of them or a few of them comes positive and you fail to link the exact symptom with the exact test. So in this current era of this ordering battery of tests, many labs are performing panels, especially rheumatological panel, wherein they test all the available serological investigations pertaining to rheumatology. And most of the times these patients come to our OPD with a positive test, at least one or more than one positive test. And at times we find that these test positivity is not at all related to their clinical situation. So that is the reason why before ordering a test, we should know how we have to order, why we should order, what is the ultimate test result. We should be able to predict basing on the clinical scenario. So to minimize this confusion, we should understand the basic principles of a particular test in relation to that particular patient clinical scenario. So what is that patient clinical diagnosis? What test should be ordered as per the diagnosis? And if we order a specific test, what method should be ordered to do a particular test, whether the rheumatoid factor should be done by latex agglutination or an ELISA or nephrometry, so on and so forth. So once the test comes positive, how to interpret these tests in relation to the patient clinical scenario? And importantly, the pre-test probability of the test should be well versed with all of the clinicians who are ordering these tests. So before we order any serological test, the initial musculoskeletal evaluation at the bedside is you have to decide whether the clinical condition is of inflammatory or non-inflammatory. And if you are concerning it is an inflammatory, then you should delineate whether it is an articular cause or a non-articular, that is a systemic cause. Because unless and until you make a clear-cut differentiation of these basic preliminary steps, you cannot assure the patient about the test you do. You cannot interpret the test if it turns positive or negative in relation to that particular candidate. So these are the commonly done tests. Of late, because of this increased availability, many of the labs, including the labs which are there in remote areas, they started doing ANAs and ANCAs. So we have been seeing many patients with the positive reports in the tertiary care centers. So among all the listed things, I'll be dealing with only a first four investigations now. So starting with ANA, which is nothing but an anti-nuclear antibody, which means that it targets the antigens which are there on the nuclear membrane or in the nucleus. But with an increasing our knowledge, we could identify the antigens which are present in the cytoplasm that are also being targeted by ANA. So this is one of the most common tests which we are doing now, irrespective whether the patient is having fever of more than 5 days duration. Also, we are doing ANAs now. And any patient with a vague body pains or arthralgias, we are doing ANA now. So this is not the scenario which I insist not to do ANAs in such patients unless you have a strong clinical suspicion of some autoimmune diseases. So why we need to do an ANA? So ANA, most of the times, if we have a clinical suspicion of autoimmune disease, particularly a connective tissue disease, definitely you need to order an ANA. And once ANA is positive, it also helps us to delineate the subgroups of that connective tissue diseases. Depending upon the titer and depending upon the pattern, you have to interpret this ANA report. A mere positivity of ANA is not at all equivalent to lupus, because ANA is more sensitive to diagnose or to establish a diagnosis of lupus, but it is not specific for lupus. Okay, so if ANA is positive, it says that the patient may be having lupus, but it is not equivalent to lupus diagnosis. If ANA is negative, you can confidently say that 95% the patient is not having lupus. Okay, so for establishing a diagnosis of lupus, definitely ANA plays a role. And very importantly, ANA negativity also helps very much or more or less equal to ANA positivity in the clinical situation. So depending upon the pattern, you can further categorize this autoimmune diseases, particularly connective tissue diseases, depending upon the pattern. If it is homogeneous pattern, more likely lupus, or if it is Peckel pattern, it is more likely to be a scleroderma or a Sjogren's syndrome. Or ANA negativity, definitely we need to consider a negative ANA with patient of similar lupus-like clinical manifestations is also important. In such cases, you should think of other causes like myositis. Inflammatory myositis may have an ANA negativity. So the most commonly used methods are ELISA, indirect immunofluorescence, and immunoblot, among which ELISA is more sensitive in picking up these autoimmune diseases. Once ELISA is positive, you can go for an indirect immunofluorescence. ELISA is very easy, cheap, and easily available across the towns. But indirect immunofluorescence, it is cumbersome and it requires a high skill both in performing the test and also in reporting. So this is very important when not to order an ANA, as I have been insisting from the first slide that unless and until you have a clinical evidence of connective tissue diseases, please do not order an ANA. So if at all you have a clinical suspicion, order an ANA. If it turns positive, then only you have to go for an immunoblot, because depending upon the titer, it is positive in a normal healthy population also. And the second most important thing is, if a patient of rheumatoid arthritis or a lupus who has been with us since a couple of years, and if we test ANAs of relatives of that patient, they also may test positive for ANA. So that is the reason why ANA positivity is not at all equivalent to diagnosis of any connective tissue disease, especially lupus. And this is not at all reflective of disease activity and is not indicated to follow serially, because day in and day out, we see there will be a repetition of ANA, both by ELISA and by immunoblot techniques, say after 3 months after initiating treatment, 6 months and 1 year. But we need not serially test it to assess the disease activity. If ANA is positive initially and after 1 year it is negative, it doesn't mean the disease has gone out from the body, because all the autoimmune diseases are genetically predisposed diseases. So as I have said, once you have a tentative diagnosis, test an ANA. If it is positive, and if you want further explore a specific antigen, then only you go for an ANA blot. So without a positive ANA by immunofluorescence, do not test ANA subserologies by immunoblot. This is also very important point, because these times we have been seeing directly patient coming with ANA immunoblot rather than an ELISA or an indirect immunofluorescence reports. So as I have said that international campaigns, particularly the Choosing Wisely campaign, has clearly made specifications that we should not order ANA unless there is an evidence of autoimmune disease, and ANA subserologies should not be tested if you have an ANA negative by immunofluorescence. So as I have said that apart from nuclear antigens, cytoplasmic antigens do test positivity for this ANA. These cytoplasmic antigens, they are the antigens which are present in the cytoplasm, they being a self-targets for these antibodies, particularly in idiopathic inflammatory myositis, to mention tRNA synthetase, which test positive for anti-synthetase antibody syndrome. So you have a positive ANA, and you have to think of non-rheumatological diseases also when you are not fully confident enough to say on a clinical basis that the patient may be lupus or some other CTD. Because a positive ANA can be seen with other systemic autoimmune diseases and also non-autoimmune diseases, like many of these autoimmune hepatitis, Graves, or infections like hepatitis, tuberculosis, or leprosy. These also test positive for ANA. So on a clinical ground, we should differentiate. That is the reason why the basic step, whether it is an inflammatory or a non-inflammatory disease pattern, should be evaluated. That is a basic step for us to follow further evaluation. Rheumatoid factor, it is the deadliest lab investigations, which have been at least out of 10 patients who walk into the OP, 9 will walk with a rheumatoid factor report. Okay, but as the name suggests, rheumatoid factor is not at all specific for rheumatoid arthritis, because only 70% of rheumatoid arthritis test positive for this rheumatoid factor. And when compared to the anti-CCP, this rheumatoid factor have a lower specificity, and as like ANA, it is also positive in normal population, and the appearance of rheumatoid factor, it depends upon the timely events of this rheumatoid arthritis progression. It may be negative or it may be positive a decade before a clinical diagnosis of rheumatoid arthritis. And as I have said that it is not specific, so a negative rheumatoid factor does not exclude rheumatoid arthritis like ANA excluding lupus. Okay, a seronegative rheumatoid arthritis do exist. At the same time, a positive test do not guarantee a diagnosis of rheumatoid arthritis. Because the rheumatoid factor can be positive in other autoimmune diseases like Sjogren's, systemic sclerosis, cryoglobulinemia, etc. And apart from all the chronic infections, cancer patients do test positive for rheumatoid factor. So that is the reason why any of the serological tests pertaining to rheumatology should be interpreted only in clinical scenario. And coming to rheumatoid factor with rheumatoid arthritis, definitely it carries a prognostic significance. High titer rheumatoid factor positivity at the diagnosis is a poor prognostic indication. At the same time, the positivity of the test also increases during the follow-up of these patients. And particularly this rheumatoid factor and anti-CCP, they are more useful if you are dealing with a patient of undifferentiated arthritis. So if you have a positive rheumatoid factor, the odds of developing a rheumatoid arthritis is very less compared to a positive rheumatoid factor and an anti-CCP. So during follow-up, these patients may turn to rheumatoid arthritis if they test positive for both rheumatoid factor and anti-CCP as compared to only rheumatoid factor. Coming to the most specific and most sensitive antibody we test for rheumatoid arthritis patient, that is anti-CCP. This anti-CCP is highly sensitive and specific compared to rheumatoid factor and rheumatoid arthritis. And this also carries a prognostic significance, and presence of anti-CCP in any titer is associated with erosive form of the rheumatoid arthritis, poor prognostic factor, and more commonly associated with the systemic complications like cardiovascular risk and ILDs in rheumatoid patients. Anchor, thank God this is not had reached the peak stage of ordering still, because many of us are not aware of this anchor vasculitis still. So like ANE, these are also the antibodies, but these are targeted against the antigens present in the neutrophil. So depending upon the pattern, you can say C anchor or a P anchor. Again, it is tested both by ELISA and indirect immunofluorescence. And particularly when to order anchor, when a patient comes with a multi-system disease, all the major organ involvement like brain, lungs, heart, and intestines, or if the patient have a vasculitic skin disorder with a multi-organ involvement, definitely you need to test for anchor. So unless and until you have a multi-organ involvement, we generally don't do test, though isolated forms of small vessel vasculitis do exist, but they are rare compared to a systemic form of systemic vasculitis. So similarly, it also have a false positivity, particularly in non-vasculitic conditions, particularly in lupus. A lupus patient can have a P anchor positivity. So whenever you have an ANA positivity and a P anchor positivity, you can't see the patient is having lupus and also small vessel or anchor vasculitis. So having one autoimmune disease itself is a curse. And in addition, if we label 2, 3, or 4 autoimmune diseases basing merely on a positivity, definitely he or she will be put on to a very bad immunosuppression and ultimately land in the adverse events of this immunosuppression. Even chronic infections, particularly this mononucleosis, also has an anchor test positivity. Drugs like cocaine also cause anchor positivity. So acute phase reactants, as a physicians, you are more aware of this ESR and CRP. But what I want to conclude in this slide is they both are definitely sensitive for inflammation, but they are not specific for inflammation. So if you see a patient with high ESR and CRP, it is not that the patient is having autoimmune disease. There are many other non-rheumatological illness which can cause high ESR and CRP. So mere values of ESR and CRP in a high titers, they also doesn't signify, but it only supports our clinical suspicion. Basing on this ESR and CRP, we cannot label patient with a rheumatological illness. They are only useful for establishing the disease diagnosis, and particularly once the diagnosis is established, they are very useful for assessing the disease activity, because this ESR and CRP are used for various bedside severity scorings in rheumatoid arthritis and ankylosing spondylitis. So I think I have 10 more minutes. So in the next next couple of slides, I will be dealing the 2 clinical scenarios where I want the postgraduates to interact with me. So this is a 32-year-old female presented with a 3-month history of joint pains, which are small and large, symmetrical, associated with swelling and early morning stiffness of more than 30 minutes. There is also a history of low-grade fever, night times, and weight loss, with a past history of blood transfusion for anemia. So clinically, she is normotensive, active arthritis is there, pallor with a purpuric rash over the extremities. Her CBP is showing thrombocytopenia, and also she had an evidence of transaminitis with a normal routine urine examination. So with this, we can say the patient is having some musculoskeletal symptoms, that is arthritis, associated with some systemic features like constitutional symptoms and a lab evidence of thrombocytopenia and transaminitis. and clinically anemia can be suspected in her. So in this female, what lab test do you order further? Do you go for a rheumatoid factor? Do you go for ANA? Do you go for anti-CCP or any other test you want to order before we label her as lupus or rheumatoid arthritis? Anyone? Among these, which one you want to order? And if you have any other blood test in the mind, which you want to order at this scenario? No postgraduates? Yes, sir. Definitely viral markers need to be tested in these patients. So if she turns RF and CCP positive, do we really call her as seropositive RA? If CCP is positive and RF is negative, still we can call her as seropositive RA. If both are negative, do we really label her as seronegative RA? And if RF CCP positive, ANA is also positive, do we really label her as lupus or lupus with rheumatoid overlap? So in all these four conditions, we have to take into credence that CCP positivity is more important. So especially in a patient who have a positive CCP, it favors a diagnosis of rheumatoid arthritis mostly. However, 5% of these patients, normal population, can also have a positive CCP. So in this patient, she had a history of transfusions in the blood transfusions in the past, and also a symptomatic thrombocytopenia, that is a purpuric rash over the limbs. So definitely we need to consider a hepatitis in this patient also. This is not that I'm saying that the patient is of hepatitis, but how we have to approach depending upon the clinical symptom. So this is a second case. He's a young male who has presented with a CVA, ischemic stroke right hemiparesis, with a past history of DVT, CSVT, and he is hypertensive. Probably he is giving a history of some lung abscess. The history was not clear. So in this patient, do we go for an ANA, APLA, RA factor? So the treating physician has tested all these three, and he was positive for ACL and RA factor, and he was being repeatedly screened with ANA every 6 months, which has been persistently negative. The total duration of his symptoms is 6 years. And in between, he has tested positive for ACL also, borderline positivity, with only one time the positive ACL was documented, and rheumatoid factor is positive. The method with which this rheumatoid factor was tested was not known. So with a young male with an ischemic event, CSVT, with an ACL borderline positive, definitely most of us will think of primary APS. But for us to consider a primary APS, this patient is not meeting any criteria. And moreover, on deep poking, he is also giving a history of genital ulcers with a history of GSV thrombophlebitis. Actually, this GSV thrombophlebitis was given by his brother, who is a physician. So with a history of genital ulcers, with a thrombophlebitis and ischemic stroke, past CSVT and a hypertensive, despite having an ACL borderline positivity, Behçet's is a more common rather than APLA. So we have tested for Behçet's, and he has turned positive for Behçet's. At the same time, we also had that nodular swelling biopsy, which was showing an evidence of inflammation rather than vasculopathy, which is more common in Behçet's. So though the glaring investigations, though the positive glaring investigations are seeing with us with a clinical scenario that we can suspect a particular disease in these patients, but still history plays a role. So many of these patients doesn't open up in the first 2 or 3 sittings, particularly the patients which we see in a rheumatology practice, because they take a lot of time to open up, because this will be like some decades before also they may be having some minor manifestations, very difficult for them to recollect at that point of time. But as we poke on deeply, they come out of this with either some probably or a definitive answer that I had suffered with this type of symptoms in the past. So in such scenarios, definitely the clinical history and the detailed examination definitely helpful. So the last slide of mine, ladies and gentlemen, to conclude that. So again and again, for the postgraduates and undergraduates, a history and clinical examination is very useful, particularly when you're dealing a patient suffering with an autoimmune disease, And lab test, a positive lab test, if you see that, do not jump into the diagnosis of autoimmune disease, be it whatever the titers it may be, the positivity, unless and until you have a pre-test possibility. That if you think that the pre-test possibility is very high, and if the test comes positive in a patient in whom you have a clinical evidence of rheumatoid arthritis, then the positivity of the test is very helpful in establishing a diagnosis of rheumatoid arthritis. Similarly, with ANA and anti-CCP or any other investigations related to rheumatology. And apart from diagnosis, these investigations are also helpful for assessing the disease activity, like anti-dsDNA complements in lupus, and ESR-CRP or rheumatoid factor in rheumatoid arthritis. And they're also helpful for prognostication, because a positivity of anti-dsDNA, we can see that the patient may have an nephritis in his future follow-up. And it is very important for us to choose these investigations very wisely, and we should be very careful in interpretation of these positive or negative result. A positive result, how it is helpful to us in establishing a diagnosis, we as a rheumatologist will also give the same credence to the negative report also. And ultimately, and most importantly, the last line of my talk is, most of these autoantibody tests need not be repeated serially, except a few tests which we assess for disease activity, like anti-dsDNA and complements. Please do not repeat ANAs or rheumatoid factors or anti-CCPs. Thank you so much for your patient hearing, and I am glad to answer if you have any questions.
Thank you very much, madam, for the really very nice talk, clinically oriented laboratory tests. And I am sure that if one hears your lecture clearly, it definitely gives overall orientation. And if anybody has some questions, please.
No, sir, autoimmune disease is the broader terms, may not be a rheumatological illness always. You can have an autoimmune hepatitis, primary biliary cholangitis, all these things. It is like an umbrella term where connective tissue diseases were also included. But connective tissue diseases, the term is more often restricted for lupus, scleroderma, Sjogren's, or myositis, rheumatoid.
As far as the treatment is concerned, is the biologicals has to be started on the day one of the diagnosis of the rheumatoid arthritis, or you have to treat with the DMRDs, and then if the response is not there, then you can add the biologicals.
The anchor drugs for treatment, example in rheumatoid, is methotrexate always. Even if you have to start a biologic, it should be with a DMARD only. So there are again a prognostication markers where we have to decide whether the patient should receive only a conventional DMARD or a biologic DMARD. If the patient doesn't satisfy a poor prognostic factors, and if he doesn't have any risk factors to say that the disease may be like severe in follow-up, we can definitely go with the conventional DMARDs, out of which methotrexate is an ideal thing to start. Yeah, you can start biologics at the initial also, but those are reserved for a very severe disease activity, or a patient with poor prognosis, or if a patient have a life-threatening, organ-threatening manifestations.
So those are the indications for the early biologicals.
It's not early, sir. Biologics are always a choice, but you have to depend on the clinical prognostication markers. So to which patient you have to, and which patient you need not to.
If the patient is affordable, what are the indications of starting the biologicals?
So affordability, okay, definitely it plays a role in the Indian scenario, but having an 1 crore rupees in the pocket or having some corporate insurance is not at all the indication for biologics. Okay, but if the patient is affordable and at the same time having only a mild disease, we need not go for biologics. But if the patient is not affordable and had a very bad disease, definitely we should think of starting a biologic DMARDs, and we should motivate him to start a biologic. So in Indian scenario, only finances comes a major first part while considering for biologics. But Western world and rest of the world, finances is not at all a major issue.
Madam, what is the role of leflunomide, and what is the dose, usual dose?
In which disease you are asking about?
RA.
So in the past, we used to give a loading dose of leflunomide, but it is associated with a severe toxicity. And there have been a reported cases of neurotoxicity too. So as of now, though the guidelines say a loading dose, we rheumatologists follow a low dose to start with and gradually hiking. So usually we start with 10 milligrams and gradually hike it to a maximum dose. Yes.
Okay, madam.
Again, in pediatrics, it again depends upon the weight and the body surface area.
Thank you, madam. It's a very nice presentation. Actually, you have, as rightly pointed out, 85% of the patient's history is the most important, and only 5% need. I think that should be actually kept in mind. And this repeated repetition of the investigations, which are generally a bit costly, is also should be kept in mind. And if there are no questions, we'll wind up the session. Thank you, ma'am.
I thank all for your patience listening and the organizers for this wonderful opportunity.
Madam.
Wonderful lecture, and I hope you have your lunch and leave, madam, please. So as we are running late, so we thought most of the audience is online, so we'll continue and we'll cover the sessions. So the next two sessions are virtual. So it will be a cardiology talk by Dr. Bhupal Garu, and also Rajinikanth Garu from Chennai is also joining virtually. So the talks will be about 20, we have reduced the duration, they are only 20 minutes talk each, followed by a short gap, and the next session, the afternoon session, will be starting by 2:15. So I request all of the audience to assemble for the afternoon session by 2:15. Presently, the virtual talks will be going on. Kindly, those who are interested can continue to stay in the hall. So I'd like the moderator and the chairperson to introduce the next speaker.
Good afternoon, one and all. And coming to our next topic, it's about post-COVID cardiac complications. And I'm very happy to introduce the speaker, Dr. V.S. Bhupal. He did his MD and DM from NIMS, and he had several papers and publication on his name, and received many awards in the field of medicine. And his special interests are in complex coronary interventions, peripheral intervention, including EVAR, that's endovascular repairs, and carotid interventions, and other heart interventions. So I welcome you from Ashram. Hi. So yeah. For the next 20 to 25 minutes, please cover all the topic of COVID-19 and cardiac complications. As we are running short of time, as you are aware, it's around 20 to 25 minutes. Thank you.
Yeah, good afternoon, everybody. First of all, I thank the organizers for giving me an opportunity to give a talk today, and I would like
You're
to thank.
not audible.
Not audible. Hello, am I audible? Hello.
So you are unmute your.
I have unmuted actually. I think we should remove the speaker. Hello? Hello, am I audible now? Hello? Audible? Yes, audible. Hello, am I audible? Hello? Hello, am I audible, sir? But your voice.
Yes, you are audible, sir.
Okay. So
Yes.
So, good afternoon, everybody. First of all, I would like to thank the organizers for giving me this opportunity this afternoon for presenting a topic today, and I would like to thank Dr. Tamiraju sir for his kind introduction. He was my senior during my DM days, so we already he was a good cardiologist, and we used to look him up for various suggestions and help during our DM days. So I'd like to thank Tamiraju sir as well, and as he is the moderator today. So coming to my topic today,
Dr. Bhupal, you are not audible to us. Please check whether you are unmuted or not.
hello. అదే సార్ అదే చూస్తున్నారు సార్ మా టెక్నికల్ టీమ్ మీద దీనికి మైక్రోఫోన్ మైక్ పెడితే వాళ్ళు నాకు ఆడుతుంది కదా, ఇయర్ ఫోన్స్ లేవా? ఇయర్ ఫోన్స్ లేదా ఒకటే. హలో, am I audible? Hello? Hello?
Sir, 1 minute, sir. We are checking with audio.
Yeah. Hello, am I audible, sir?
Sir, you can start, sir.
Yeah, am I audible now? Am I audible?
Yes, sir. You are audible. You can start your presentation.
Yeah. Okay. So, good afternoon, everybody. First of all, I would like to thank the IMA and Ashram Medical College faculty for giving me this opportunity for giving a talk in this event. And I would like to thank Dr. Tamiraju sir for his kind introduction given to me. And today I will be talking on COVID-19 and cardiac complications. As we all know, COVID-19, how much havoc it has wreaked in the past 2 waves. So we have faced a lot of this thing from COVID-19, and you know how the mortality rate was during the second wave, and majority of the mortality rate was due to cardiac complications, and majority of COVID patients, they had cardiac complications. So we need to know how COVID-19 affects heart in order to manage these patients effectively. And COVID-19, as you know, though it has come down, still I don't think it is completely out and done. So we might see a third wave or not, that we don't know, but it might be there as an endemic, and we may see sporadic patients of COVID here and there with the periodical spike. Probably. So we need, as physicians, we need to know about COVID-19 in and out in treating our patients effectively. So how does COVID-19 affect your heart? Basically, various mechanisms by which COVID-19 can affect our heart is either by direct toxicity, because ACE2 receptors are predominantly present on myocardial cells. So the main entry receptor for COVID-19, as we all know, I mean, SARS-CoV-2 virus, as we all know, is AC2 receptor, so it can affect the heart directly, causing direct cardiotoxicity, and there may be hypoxemia-mediated cardiac effect, and there might be a supply-demand mismatch due to severe hypoxemia, and it might be secondarily involved due to the cytokine storm, that is excessive inflammation seen, and heart can be affected due to disseminated intravascular coagulation as well. And the various conditions that might present are acute coronary syndrome, arrhythmias, myocarditis, venous thromboembolism, heart failure, and cardiogenic shock. And the other manifest. Hello? I'm sharing my slides actually. Okay, just. Now slides are visible, sir. Okay. So one of the major cardiac manifestations of COVID-19 is acute cardiac injury and myocarditis. And myocarditis, it appears in COVID-19 patients several days after initiation of fever. And this is mainly due to upregulation of ACE2 in the heart and coronary vessels. As you know, SARS-CoV-2, the entry level is ACE2 receptor, which is predominantly present in heart and coronary vessels. So it can affect heart directly, causing direct cardiotoxicity. And the other major manifestation that we have seen during COVID-19 pandemic was ST segment elevation myocardial infarction, that is STEMI. This is due to the increased risk of plaque rupture and thrombus formation due to the aggressive procoagulant state seen during this illness, resulting in either an STEMI, that is ST elevation MI, or non-ST elevation MI. And the other way of myocardial injury is associated with disseminated intravascular coagulation. So DIC is a life-threatening condition which is present in almost 70% of non-survivors with COVID-19, about 0.6% of survivors of COVID-19. So the other topics which I would like to discuss today are hypertension and COVID, and various biomarkers, cardiac biomarkers and COVID, and acute coronary syndrome and COVID, myocarditis, heart failure, DVT, pulmonary embolism, arrhythmia seen during COVID, and various drug interactions which might be seen in during COVID, and pericardial effusion. So firstly, coming to hypertension and COVID, as I have already discussed, ACE2 is expressed in lungs, hearts, and vessels, and which is a key member of renin-angiotensin system, and which is important in the pathophysiology of cardiovascular disease. And prevalence of pre-existing hypertension seems to be higher in COVID-19 patients who develop severe disease versus those who do not. So prevalence of hypertension is higher in patients with patients who develop severe COVID. So what is the relation between hypertension, ACE2, and COVID? So there was some previous speculation that renin-angiotensin inhibitors may influence SARS-CoV-2 binding to ACE2, promoting the disease. But this was initially, this was the thought that ACE2 inhibitors may increase the severity of COVID, but a large observational study which was done in Asia, Europe, and North America did not show a harmful association of ACE inhibitors or ARBs. In fact, patients who are on ACE inhibitors or ARBs, they were associated with lower risk of COVID-19 infection or serious complication or death from COVID-19 infection. So there was initially a dilemma whether to continue patients on ACE2 inhibitors or ARBs who are already on, these drugs. If they develop COVID, whether to stop them or not. But it has been finally proven that these patients should be continued on ACE inhibitors or ARBs, and they need not stop these drugs. So there is no clear evidence that using ACE inhibitors or ARBs lead to upregulation of ACE2 in human tissues. And to date, there is no clinical evidence to support, and patients on ACE inhibitors or ARBs should not stop their treatment. Coming to biomarkers, various biomarkers that help in diagnosing disease during COVID. So cardiac troponin T, I, and BNP or NT-proBNP concentration should be interpreted as quantitative variables. So whenever you order for a biomarker during COVID for various reasons, it should be a quantitative test and never a qualitative test. So positive or negative doesn't help you much. You should see the quantitative value. So in the absence of typical angina, chest pain, or ischemic ECG changes, patients with mild elevations, that is less than 2 to 3 times the upper limit of normal, do not require workup or treatment for type 1 myocardial infarction. So mild elevation in TROP-T or TROP-I is seen during COVID, and mild elevation of BNP as well as NT-proBNP is seen during COVID due to direct cardiotoxicity, which is not significant, which need not be given undue importance. And the D-dimer is helpful in quantifying activated coagulation due to endothelitis and thromboembolism, and serial measurements of these cardiac biomarkers is important rather than one single value. And coming to troponin T, as you can see, elevated troponin T carries poorer prognosis. So in hospital mortality was 7% in a study. It was 7% for patients without underlying cardiovascular disease and normal troponin, whereas it was 13% for those with cardiovascular disease and normal troponin. And mortality was 37% for those without cardiovascular disease but elevated troponin, and it is almost 70% for those with cardiovascular disease and elevated troponin. So quantitative troponin assessment is helpful in predicting mortality in COVID patients. And coming to natriuretic peptides in heart and heart failure during COVID-19 infection. So as natriuretic peptides are basically biomarkers of myocardial stress. So whenever there is increased myocardial stretch, or whenever there is elevated end-diastolic pressures in the LV, we see a rise in NT-proBNP as well as BNP. And this can be elevated among patients with severe respiratory illnesses, typically in the absence of, even in the absence of elevated filling pressures or clinical heart failure. So like troponin, elevation of BNP or NT-proBNP is associated with an unfavorable course among patients with ARDS. So elevated BNP or NT-proBNP in a patient with COVID also adds to predicts a poorer prognosis in these patients. And in COVID-19 infection, patients often demonstrate significant elevation of BNP or NT-proBNP, and significance of this finding is uncertain and should not necessarily trigger an evaluation or treatment for heart failure unless there is clear clinical evidence for the diagnosis. First of all, there is no need of routine testing of BNP or NT-proBNP in a COVID patient, and it should be ordered only when there is a suspicion of heart failure, which can guide you to a certain extent. Coming to COVID-19 in cardiovascular and metabolic diseases, that is case fatality rates and common comorbidities in non-survivors, that is severe disease. So this was a study from Guan et al, which was published in NEJM, which was done in about 1100 patients with confirmed COVID-19, and out of which 170 patients had severe disease with comorbidities, and the mortality was highest in patients with cancer. cancer was a comorbidity in about 5% of patients, but the mortality level was almost 30 to 35% in cancer patients. And the next comes underlying respiratory disorders like bronchial asthma and COPD. The mortality rate was about 25 to 30%. And patients with diabetes had a mortality range of 20 to 25%, and hypertension mortality was around 15%. And patients with cardiovascular disease, the mortality was around 10 to 15%. So, and the prevalence of these comorbidities, patients with cardiovascular disease, in severe disease, the prevalence of cardiovascular disease was highest among all these diseases. It was about 10.5% in these patients. So, and the other important dilemma which we faced during COVID-19 is a diagnostic dilemma, and many a times it is challenging to identify acute MI during COVID-19 because cardiovascular manifestations in COVID-19 patient are complex, and patients may present with acute MI, myocarditis simulating a STEMI presentation, and a stress cardiomyopathy, non-ischemic cardiomyopathy, coronary spasm might be there, or myocardial injury without a documented type 1 or type 2 acute MI might be seen. And many of the patients testing positive for COVID-19 can be asymptomatic. Despite significant abnormalities noted on chest CT scan, there appears to be significant risk of asymptomatic transmission of the disease. And many of the symptoms they share, COVID patients and patients with acute MI, COVID patients also might have non-specific chest pain and breathlessness. So clinically, it is difficult to differentiate patients with acute coronary syndrome and acute COVID illness. So there will be a diagnostic dilemma unless you look at an ECG. So various tests are available. Non-invasive, coming to non-invasive imaging, do not perform routine cardiac imaging in patients with suspected or confirmed COVID-19, and perform imaging studies in patients with suspected or confirmed COVID-19 only if management is likely to be impacted by imaging results, and the imaging protocol should be kept as short as possible. And doing routine and majority of the times ECG is helpful in identifying various cardiac abnormalities during COVID-19, and echo should be ordered I mean only if it is necessary and if it is going to change your management. And because echo involves direct contact of the technician or doctor with the patient, so you should limit the contact and you should protect yourself. So findings which exclude the likelihood of acute coronary syndrome on echo are presence of no RWMA and RWMA not corresponding to any vascular territory suspected, and presence of global hypokinesia. Usually patients with global hypokinesia, it might be due to myocarditis rather than any acute coronary syndrome. And other non-invasive imaging modalities available are transesophageal echo, CT, and cardiac CT may be preferred to TE in order to rule out left atrial appendage and intracardiac thrombus prior to cardioversion in case of arrhythmia. And CT coronary angiogram can be alternative to conventional invasive angiogram. And cardiac MRI is preferred in myocarditis, and exercise testing it is not used during COVID days. I mean in COVID patients. So what are the challenges managing MI patients in COVID-19 era? And there might be patient delay due to lack of transport, due to stigma. Many patients, many ambulances or even relatives, they might fear contacting illness from these patients. So transport may be a challenge during COVID, and unavailability of primary care services, and false overdiagnosis of acute MI due to abnormal troponin due to myocarditis. And you need to assess risk benefit ratio of optimal STEMI management. So these are various management guidelines how you should manage STEMI during in a STEMI in an acute MI patient with COVID. So if it is a definite STEMI and if it is a PCI center, primary PCI is indicated with level 2 PPE, and if it is a non-PCI center And if it takes more than 2 hours to transfer the patient to a STEMI center, that is center with a cath lab facility, pharmaco-invasive strategy is preferred. And if you are suspecting either a STEMI mimic or a probable STEMI, observe the patient and put him on conservative management, avoiding too much exposure to cath lab staff. And if the prognosis is futile, if the patient is very sick, that is in scenarios like the patient develops MI on ventilator due to COVID lung injury, prefer conservative management and don't try to push the patient to a cath lab and try various procedures on such a patient. Better prefer conservative management. Or if the patient is in cardiogenic shock, or if he develops out of cardiac arrest, if the prognosis is futile, better prefer conservative management in such a patient. If the patient has NSTEMI or unstable angina, and if patient is stable, try conservative, postpone angiogram or revascularization, and it is better to do it later after situation settles. But if hemodynamic changes are there, consider coronary angiogram or PCI with adequate precautions. So this is the same. So when to consider primary PCI? If it is an anterior wall ST elevation MI, if the patient presents early within 6 hours, that is within window period to the hospital, and if the patient is young, relatively young, and the prognosis is good, and if there is low clinical probability of COVID-19. So patients with NSTEMI in COVID-19, that is COVID-19 positive or probable patients with an NSTEMI, they should preferably be managed medically. And if there are high risk clinical features, that is gray score greater than 140, or if the patient is hemodynamically unstable, then urgent coronary angiography and possible PCI should be performed. So if at all the patient is
Can you please summarize?
Sorry, I'm
Please summarize.
sorry. Hello?
Can you please summarize in 5 minutes as we are running short of time? Please.
Okay. So acute heart failure, this is one presentation due to severe myocarditis, and so DVT and acute pulmonary embolism are one of the major complications seen during acute COVID. And this is one patient who came to our hospital in COVID, and he had large acute pulmonary embolism, left pulmonary artery, as you can see. So how to give anticoagulation for a COVID patient? If the patient is a high risk patient, that is with increased oxygen requirement, increased D-dimer, increased creatinine, and increased CRP, put him on a heparin drip and give him full dose anticoagulation, that is enoxaparin 1 mg per kg BD. And if he is not a high risk patient, consider apixaban 2.5 to 5 mg PD or enoxaparin. And all the patients with COVID, once they are discharged, better continue anticoagulation for at least 2 weeks post discharge. And arrhythmias are another important manifestations, cardiovascular manifestations which we see. These are various tachyarrhythmias which I have seen, atrial fibrillation, SVT, and these are various bradyarrhythmias which I have seen, sinus bradycardia, junctional rhythm. And majority of, and some drugs used for COVID-19, they have tendency to prolong QT, leading to torsades T points. So we should be watchful. We should be monitoring the patients with daily ECG whenever he gets admitted to the hospital. So summarizing, these are various cardiovascular concerns and treatment considerations that can be considered. STEMI and NSTEMI, you should consider either primary PCI or you should versus thrombolytics. Myocardial injury, these patients have worse prognosis, and patients with hypercoagulable state, you need to put them on thromboprophylaxis. Patients who are on ACB or AC inhibitor or ARB use, continue treatment. Patients using hydroxychloroquine, azithromycin, monitor QT. Patients with severe immunosuppression, it might be blessing in disguise, especially in patients with cytokine storm. And patients with hemodynamic instability, IAVP and ECMO, they should be used guardedly. So summarizing, increase use of pharmaco-invasive strategy, Myocardial injury is common in COVID-19, causing troponin elevation. Echo only do it if it helps in decision making, limit auscultation time, and most importantly, protect healthcare workers and limit your exposure. Thank you.
Thank you, Dr. Gopal. But because of lack of time, we could not.
Yeah, actually, my talk was supposed to be for 20 minutes, but I mean 30 minutes it was cut short.
Yeah. So in last minute adjustment because of.
Yeah.
Anyway, it's very nice presentation. Just we'll see whether there are any questions from the audience. So if no questions, we'll summarize. So the cytokine storm is the biggest storm, I think, than any other storm till now we have seen. And the COVID-19 is like picture abhi bhi baki hai. Even after COVID-19, we tend to see many complications in cardiovascular thing. You rightly pointed this thrombotic very nicely. So what is your impression on D-dimer and follow-up in those patients who are initially positive and cardiac implications of D-dimer positive?
D-dimer, it gives an assessment of prothrombotic state of the patient. So D-dimer, at least usually what we were doing was we wut putting the patient on anticoagulation for 2 weeks and we are repeating D-dimer at 2 weeks. If at all it is elevated, we are continuing patient on anticoagulation. We are stretching him for 1 more month. If at all D-dimer is lesser, I mean, if it is normal, we are stopping anticoagulation after 2 weeks.
Thank you. So if there are no further questions, we'll wind up this session. Thank you, Dr. Gopal.
Yes, sir. Yes, sir. Thank you, sir.
Cirrhosis. So our next speaker, next topic is recognition and referral of cirrhosis. Dr. Rajinikanth, I'm pleased to introduce Dr. Rajinikanth garu. He did MS, MRCS from UK, diploma in LAPA in France, and some fellowship in liver transplantation. He has 22 years of experience in treating patients. He is a clinical lead and senior consultant in Global Hospital, Chennai. He got trained and worked in liver department, which is a world-renowned King's Hospital in London for 6 years. He has European fellowships in liver transplant and hepatobiliary surgery. He has expertise in living donor liver transplantation, cadaveric liver transplantation, pediatric liver transplantation, and cancers of liver, pancreas, and biliary tract. Now, I request Dr. Rajinikanth to start his presentation.
Thank you for the great introduction. Am I audible for all? Am I audible? Are you able to see my slides?
Sir, you are not audible, sir.
Am I audible now?
Yes, sir, you are audible.
Yeah, you are able to see my screen?
Yes, sir.
Okay. Thank you. At the outset, I would like to thank AP IMA and mainly Srinivas Raju and Dr. Nandakishore for inviting me to give a talk on recognition and early referral of cirrhosis for mainly for liver transplant. Normally, cirrhosis is managed by primary physicians and gastro surgeon, medical gastro people. So how to refer and when to refer, that is my talk today. I'll be as quick as possible because of lack of time. On my talk, it shows liver cirrhosis recognition and early referral, briefly cases, and I'll briefly touch on types of transplant and outcomes. So as you all know, the cause of cirrhosis are lined up in this. But in India, the most common cause, and especially in South India, most common cause is alcohol and viral hepatitis and NASH. And alcohol is it's the rapid increasing of use of alcohol as well as the diet. These two are considering most important factors in liver damage. Alcohol causes liver damage by causing steatosis. If you are not stopped, or if you ignore the steatosis, it will go into steatohepatitis. And until then, it can reverse. Once it crosses fibrosis, it will not reverse. So it becomes cirrhosis. Then they'll go into the compensated, decompensated liver failure. Alcohol consumption, amount of alcohol consumption is directly proportionate to liver cirrhosis, which shown in the slide. Also, if you obstinate alcohol, you can reduce the liver cirrhosis. And the other important thing is recently increasing trend, as morning many talks are discussed regarding the diabetes and obesity. These are the recent epidemics. These are man-made epidemics, which are again causing liver damage, and it can cause metabolic syndrome, and because of the high calorie diet we are consuming and also lack of physical activity, all this modern life. So they are causing the liver damage, especially obesity, diabetes, hypertension, all these causing liver damage. So in India, if BMI greater than 30 or even 28, you are more prone for liver, fatty liver, and then fibrosis and cirrhosis. So because our diet habits have changed past 20 years significantly, we are eating a lot of Western diet as well as Eastern diet. Both are harmful for both. If you combine East and West, it is causing a lot of fat accumulation in the liver, and which in turn causing liver cirrhosis. So that is one part. And other thing is chronic hepatitis B and C infections, also more in South India especially, and they can cause inflammation and fibrosis. If you are not diagnosed, it can cause liver cirrhosis. Liver cirrhosis, there are types of cirrhosis where you don't see any symptoms, but you have to be index of suspicion, especially these are the risk factors like alcoholic patients and obese patients, diabetics, hepatitis B patients. At primary level and secondary level, you have to be closely followed up by liver function test and 6 monthly ultrasound and annually CT scan. In that, once a liver cirrhosis is formed, it's important to refer to from primary care to secondary or tertiary care. Cirrhosis with decompensation forms, these are the symptoms: ascites, jaundice, encephalopathy, and GI bleeding, spontaneous bacterial peritonitis, and renal dysfunction also can cause. This is hepatorenal syndrome. So these are the signs and symptoms you would find in the OPD. How do we select the liver disease patients for liver transplantation? When you refer this patient for liver transplantation. So normally there are 3 types of scoring. We have Child-Pugh score, MELD, UKEL. For pediatrics, pediatric end-stage liver disease score. So commonly at clinical scenario, we use Child-Pugh score and MELD score. These two are easily to detect as an OPD basis. Once this Child-Pugh score, based on the points and the grades, once you cross child B, B7 and B8, they are indication for transplant. Similarly, there is a lot of apps available how to calculate MELD scoring. Once MELD score of 14 or 15 is the indication for liver transplantation. And similarly, once you are following up with the liver cirrhotic patients, they tend to form liver hepatocellular cancer. So cellular cancer is formed, liver transplantation is the only choice for the long-term survival. For how to when you refer and when to transplant to the HCC is we have criteria called Milan criteria and UCSF criteria. If the lesion is less than 6.5 centimeters, we can transplant these patients and they can be disease-free for lifelong. I'm just quoting two examples. A 60-year-old gentleman diagnosed CLD. He has all ascites, jaundice, encephalopathy. He came to our OPD and we assessed him. He has all metabolic syndrome and also is alcoholic. So he's alcohol abstinence for 3 years. Then his liver shows cirrhosis. He's a child C, male 17. And luckily his relatives came for donation and we used half of his son's liver, right lobe we take and we implant it to the patient. And sorry, donor is the wife. So wife is donated half liver and we took 520 grams of the liver and we implanted to the patient. And the operation went well. This is the post-op course. Day 1 we extubated, day 3 normal diet, day 10 brain removed, and day 13 we discharged him. This is a simple example how a liver cirrhotic patient can survive normally. Similarly, a 72-year-old gentleman with hepatitis B CLD came with hepatocellular cancer, which is Milan criteria. He is waitlisted for liver transplant, and luckily a cadaver donor has come. We transplanted. This is a 50-year-old donor who had an accident, brain dead. We transplanted him into this 72-year-old gentleman, and he has done very well post-operatively, and we discharged him. This is the DDLT anastomosis. These are technical details. And once it is done, we discharged him on day 14 to 20 days. In between, we discharge. So this is possible only because these two gentlemen who has done first transplant is Thomas Tarzell on the left, and also is Roy Collin who has invented cyclosporin. Because of these two gentlemen, it's possible with all these transplants. And it is once upon a time, this transplant used to be a Western. If you want to do transplant, you have to go to a different country. Now it is available in India and it's fastly developing this field. At Global Hospital, we are doing around 150 transplants with the international outcomes with 90% 1-year survival and 85% 5-year survival rate. And these are the types of transplant: cadaver liver transplant, living related liver transplant, and one liver we can split into two and we can give it to two people, one adult, one child. This is a split liver transplant. In India, cadaver transplant is very less, only 10% accounts. Mainly living related transplant is 90%. So this is how you do. Briefly, I go touch the techniques. You open the abdomen, you see the liver is cirrhotic, you remove entire liver, and first you take out liver. For half an hour, you are with no liver. Then you anastomose this new liver. The left side liver is healthy, right side liver is not healthy. So this liver you anastomose. 4 anastomosis usually we do, and once it is done, we refuse. Key back technique. These are all technical aspects. Portocaval shunt we use of portocaval shunt. This is hepatic anastomosis, and once it is done, we do the portal venous anastomosis. Portal venous anastomosis. Then we perfuse. This is portal venous anastomosis. Then we perfuse the liver, and then arterial anastomosis. I'm skipping through, these are all technical aspects, and this then bile duct anastomosis. These are some complications which you can get post-op. They are bleeding, some vessel thrombosis. These are all only less than 5%. You get some infection is the main risk, some graft dysfunction and rejection. Rejection also 10 to 20% in liver transplantation, and some renal issues. This we can, venous outflow is very rare. And surgical outcome, mainly it's a teamwork. You have to have a good surgical team as well as good intensive care unit team. And all these well-trained people you have to have. Otherwise, a lot of complication can come. So this acute rejection only 20%, within 3 months it happens. Chronic rejection less than 5 years, but it's a rare, less than 5 to 10% only you get rejection. So surgical technique, surgeon is defined by a lot of training he needs to get. Good infrastructure has to be there, dedicated ICU. Brief note about living donor transplantation. The relative or either a near or far relative has to give half of liver. Usually there should be less than 45 years and healthy people has to donate the liver. Same blood group person has to donate the liver. So we take first donor hepatectomy. This consists two operations we do simultaneously. Donor hepatectomy, then recipient hepatectomy. In donor, we take half of the liver, we do cholangiogram and we divide the right lobe bile duct. And once it is done, then we do this is a half liver we explant from the donor and this is implanted into the recipient. So what we do is we do the PTFE interposition graft for middle hepatic vein reconstruction we do. And this is we do at the back bench. The recipient, once you explant liver, we implant this liver into the cava of the recipient. This is a caval anastomosis. This is once caval anastomosis is done, then portal venous anastomosis we do. And once it is done, we reperfuse the liver. You see here, half of the liver is placed and blood is flown into this. After this, we do the artery and bile duct. And we see the intraoperative Doppler once it is done and the bile duct is done. These are outcomes. We have analyzed the 1,000 cases. The 1-year survival rate is almost 90%. 3-year survival rate is 87%. This is on par with international standards. The trend of 300 cases, first 300, some complications. Slowly, the complication rate is less than 5%. Vascular complications sometimes can happen, but they are very 1 to 3%. So in conclude, over 1,000 transplants, 3-year survival is 88%, 5-year survival 84%, less than 5% biliary complications, and less than 3% vascular complications. So index of suspicion for primary physician and follow-up at the primary level can happen. But once you diagnose liver cirrhosis with the decompensation, it's very important to refer that patient to secondary level or tertiary level centers where liver transplant facility is available. Liver transplant is a life-saving with good outcomes for liver cirrhotic patients. Otherwise, if you don't transplant, the mortality is inevitable. So a brief note for all doctors, you have to encourage organ donation for, if suppose by any bad luck cadaver happens, you have to tell the family it's good to have organ donation. So we can use the heart, lung, liver and kidneys. Thank you for your attention. Main thing is teamwork is the main essential. So encourage organ donation. Thank you. I'm happy to take up any questions.
Thank you very much, Dr. Rajinikanth, for your very nice presentation. And if there are any questions from the audience, please.
Rajinikanth, what is the longest follow-up of liver transplant and how severe is the post-op immunosuppression that one has to undergo? How difficult it is?
Yeah, very good question, sir. Whoever is there. Longest I've seen is 30 years. And they are hale and healthy. And I still see them. And as the years goes on, you can reduce the immunosuppression to minimum. And this 30 years patient is having only 1 milligram of Prograf morning and 1 milligram of Prograf in the night. That's all immunosuppression he has. But first 6 months, you need to have a triple regime, that is Prograf, tacrolimus, mycophenolate mofetil, and steroid. These 3 regimen will be there. Within 1 year, we can stop mycophenolate, and within 2 months, we stop steroid. So liver is a privileged organ. You don't need to give a lot of immunosuppression like kidney, where you need to give a lot of excessive immunosuppression. Once they pass after 1 year or 2 years, we maintain them on only tacrolimus.
Thank you. Thank you.
Thank you, sir. Actually, it's a very nice presentation about another revolutionary treatment. And it's your nice gesture of organ donation is very well taken, sir. Thank you. If there are no other questions, we'll conclude this session.
Thank you very much. Thank you very much.
Thank you, sir, Dr. Rajinikanth, sir, for your wonderful presentation, sir. On behalf of
Thank
IM
you.
AP State, we are very thankful to you, sir.
Thank you, sir.
So we conclude this session, and I request the organizers to give a memento to the moderator and chairpersons. So as we are running late by more than 1 hour, so we have covered a little bit during the lunch session. There was no choice because audience is online. There was no other choice. So I think we will be continuing with the academic program since so that will not be delayed by much in the evening session. So like that, we want to continue with the session. Next session, that is a post-lesson lunch session, which is supposed to be starting at 2 o'clock. Now we'll start now. So as the speakers and the chairpersons are ready, in about 5 minutes, we'll start the post-lesson session, post-lunch session. So welcome back to the afternoon session. So we are continuing with the scientific program as scheduled. So the next session will be mostly surgical topics. So it will be laparoscopy, surgery and beyond by Dr. Ganesh. Then evolution of breast cancer treatment by Dr. Vikrant, and surgical management of advanced CAD by Dr. Shiv Prasad Mukunavar. So for this session, I'd like to invite Dr. Sailaja Garu, who is an oncosurgeon, Ashram Hospital, as the moderator, and Dr. Ramesh Chandrasekhar sir of Swaripa Nursing Home, Eluru, as the chairperson, and Dr. Malamadaya sir, who is on the way. He will be coming and joining them. So just welcome the moderator and the chairperson, and kindly take over the stage and start introducing the speaker. Meanwhile, sir is ready with the slides.
Good afternoon to all. Hope everyone had a good lunch. And I'd like to introduce Dr. Ganesh Goti. He is a practicing robotic and laparoscopic bariatric surgeon. He did MBBS and MS in Guntur Medical College and underwent surgical training in UK MRCS and FRCS he did. And he did fellowship in pediatric surgery, robotic surgical training he underwent in 2018 and 19 in Royal London Hospital and St. Luke Hospital. He did fellowship in American College of Surgeons, and currently he's a HOD of gastroenterology department in Kamineni Hospitals, Vijayawada, and he is practicing bariatric surgery at weekends in Hyderabad and Visakhapatnam. Sir, please start your presentation.
Good afternoon. I am Ganesh Gurti. First of all, I'm immensely grateful to the APCON IMA Yeluru Organizing Committee, Ashram Medical College Management, and Management of Kamneni Hospital, Vijayawada, from where I am coming today and representing the Department of Gastrointestinal Surgery from Kamneni Hospital, Vijayawada. I know it is post-lunch session, so you all might be a bit sleepy. So I'll try to make it as quick as I can. So today's topic is laparoscopic surgery and beyond. Laparoscopic surgery is already an established practice for the last 20 years. So I would like to just take through the evolution and invention of laparoscopic surgery and its applications in our hospital, that is Kamneni Hospital, Vijayawada, and the most latest cutting edge technology. So laparoscopic surgery, because of its minimal access, that is through small incisions, it is called minimal access surgery or keyhole surgery or band-aid surgery. Laparoscopic surgery was initially started in practice mainly in gynecological surgery as a diagnostic tool in the early part of 20th century. And then later on, it turned into therapeutic approaches with application in all other specialties, including general surgery, gastrointestinal, surgical, urology, and thoracoscopic procedures. The first laparoscopic appendectomy was actually done by a gynecologist in 1981. And rather than being appreciated, he was actually ridiculed for performing this procedure. And then he was threatened with erasure of his medical license because at that time, all other departments and also including his own gynecological association thought he's practicing an immoral and unethical methods of operating on patients. But shortly afterwards, in 1985, the first laparoscopic cholecystectomy was performed, and thereupon it was taken up gradually over the all specialties, and laparoscopic cholecystectomy became the gold standard for gallstone disease. So after a lot of initial criticism and opposition, the laparoscopic surgery has actually changed the way we practice surgery from open surgery to laparoscopic approaches for most of the surgeries done on the abdomen and some of them on the thorax. So nowadays we do even advanced procedures through the laparoscopic approach and including surgical oncology. So what are the advantages of laparoscopic surgery? The most important is it gives better access to the areas where traditionally open surgery wouldn't give. That is the areas of diaphragm and the deep in the pelvis. Sorry, we lost the slides. The screen share was changed for some reason. Sorry for the inconvenience. Zoom lo, you have to change the share to PowerPoint. Huh? Net again. Okay. Yeah. నీ ల్యాప్టాప్ పెట్టేస్తా, వీడియో లేకుండా చెప్పేస్తా. Thank you. It gives better access, and being minimally invasive with less pain response, it can have lesser physiological demands and better cosmesis because of the smaller scars, and obviously lesser pain, less risk of wound infection, and less period of hospital stay, and early discharge, early mobilization, and earlier return to normal activities and back to work. What are the disadvantages? Initially, it was not cost effective, but with the advent of technology, it became more affordable to most of the people. And to be frank, the only disadvantage nowadays is there is no feel. But for an experienced laparoscopic surgeon, he actually can feel the tissue with the help of the instruments. So the application of laparoscopic surgery in general surgery, we do many procedures through laparoscopic approach, diagnostic laparoscopy for non-specific abdominal pain, appendectomy, and hernias. All types of hernias can be operated through laparoscopic approach. And the gold now for bilateral inguinal hernia, laparoscopic approach, LAP approach is the gold standard approach. And the laparoscopic approach, but inguinal hernia can be performed through two different approaches. One is totally extraperitoneal, that is TEP, where you don't enter the peritoneal cavity, and the other option is transabdominal, that is where you enter the peritoneal cavity and raise a peritoneal flap to get to the hernia area. So this is the totally extraperitoneal area, and this is okay. This is the mesh we place over the areas, and this is the direct hernia space. This is the indirect area space, and these are the cord structures, and this would be the femoral hernia space. So in TEP approach, you cover all three hernias with the single mesh. I think the videos are not playing well, so I would skip the videos. The application of laparoscopic surgery in surgical gastroenterology would be, again, most of the procedures can be performed through laparoscopic approach, and the gold standard for gallstone disease is laparoscopic cholecystectomy. And this would be the anatomy of the gallbladder with respect to cholecystectomy. I think the videos have a problem, so I'm not going to play the videos. So this is the structure. This is the gallbladder, and this is the cystic duct and cystic artery area. So this is where we clip, and then we'll remove the gallbladder of the liver. This is diaphragmatic hernia repair, and this is the diaphragm, and this is the viscera, and this is the hernia in the diaphragm. And there are two approaches. One, we can put a mesh, cover a mesh, and then secure it with either suturing or tackers, or we can close the rent with suturing, and on top of it, we can put a overlay mesh. And all the bariatric surgeries can be done through laparoscopic approach. In fact, the bariatric surgery got into second lease of life after the advancements of technology furthering the laparoscopic technique. So this is the sleeve gastrectomy, where we remove about 80% of the stomach, and we will leave a sleeve shaped stomach of only 20% of residual stomach of 20% size. So this is the stomach, this is a stapler, and this is the line we usually staple it. I'm sorry, we couldn't play the videos properly. Thank you, sir. I'm just trying to fast forward it. It's not allowing me, so that. So this is how we staple the stomach. We have a orogastric tube in the stomach to help us to maintain that size of the sleeve. So this is the lesser curvature site, and here would be the duodenum. And you'll see the spleen shortly in the next few seconds. So that is a spleen where you can see the spleen, and this is where the esophagogastric junction would be. This is the most critical area for this surgery, because there is a very high risk of damaging the spleen when you put the stapler in. And all the pancreatic surgeries can be done through the laparoscopic approach. For Whipple's procedure, which is any lesion in the head of the pancreas, we can do the laparoscopic approach. Here we are demonstrating a distal pancreatectomy, sparing the spleen for a lesion in the tail of the pancreas. So that is behind the posterior to the pancreas, the dissection. That is where you can see the lesion in the tail of the pancreas. And then the vessels were pulled up. And then we are using the advanced bipolar to divide the pancreas. The important step, next step would be to secure the duct. This is the rectopexy. This is the slide with the rectal prolapse. This is the prolapse. And then there are different approaches for surgery for rectal prolapse. It is perineal approach or abdominal approach. Abdominal approach can again be classified into open or laparoscopic. And the rectopexy can be classified depending on the mesh rectopexy or just tissue repair. And in mesh placement also we have different types of techniques. Here we have pulled up the rectum and tacked the rectum and sigmoid to the sacrum. In some of the surgeries associated with rectal prolapse, associated with constipation, sometimes it is advisable to remove the sigmoid. That means along with sigmoid colectomy, we have to do rectopexy. So we tacked the mesh to the sacrum, and now we are putting sutures on both sides of the rectum to the mesh. And then after this, we'll close the peritoneum to reperitonize the pelvis. Loop colostomy. This 35-year-old female, young female, had a horrible road traffic accident with major damage to the perineum. So we needed to do fecal diversion, for which we did laparoscopic loop colostomy. And once the patient is pretty much better now with all the perineal wounds healed very nicely. So in a month or so, we would plan for laparoscopic colostomy closure. Can do lap assisted mesenteric cyst or other lump excision as well, especially if they have the probability of malignancy is very low, and specimen better be removed without rupture. This is a pedicle mesenteric cyst, so we're able to remove it easily. But sometimes it is not that easy to remove the mesenteric cyst, in which case it is safer to convert to open. So there's a mesenteric cyst, and there's the pedicle we are dividing now. There is a bit of vascularity, so we're using the bipolar. So what are the advances in laparoscopic surgery since in the last 2 decades? One of them is SILS, that is single incision laparoscopic surgery. So rather than having multiple incision, a single incision of 1.5 to 2.5 centimeters to introduce multiple instruments and a camera through the same port site to do uncomplicated procedures like gallbladder surgery or appendectomy or diagnostic laparoscopy. So this is the port site with multiple instruments, provision for multiple instruments, and this is the lever with the gallbladder. Advantage is single scar with the possibility of better cosmesis and being a minimally invasive, being a form of laparoscopic surgery, it will have all the other advantages of lap surgery. The disadvantages are the lack of triangulation of laparoscopic instruments and the necessity for a special type of instruments and the very much limited indications for the surgery. And so it was accepted to a very limited group of people and only in limited departments. Same again, this is another modification in the laparoscopic surgery. There is a natural orifice transluminal endoscopic surgery. The 3 different approaches are, one is transoral, transanal and transrectal, and transvaginal and transuterine. So these are the approaches through which they do target different organs for surgery. It again has the same advantage, similar advantage as the other SILS, because there is no external wound, there is no scar, so better cosmesis and all the advantages of laparoscopic surgery with earlier recovery and less pain, less wound infection, lesser hospital stay. Again, the disadvantages is creating a opening in the viscera like stomach, uterus, and these things are not generally quite accepted well. And again, the acceptance among the surgeons and among the patients is pretty low. The other advances are mainly technological advances, bigger monitors, better monitor, better with better resolution. And rather than using the other modifications, rather than using carbon dioxide for pneumoperitoneum, using abdominal wall retraction systems, which are actually very cumbersome and expensive. So that was not routinely used. And then the most latest modification or the advance in the laparoscopic surgery is application of artificial intelligence in laparoscopic surgery. Like in many fields, artificial intelligence has a wide spectrum of applications and it entered the laparoscopic surgery as well. It is being practiced since the last 20 years on a regular basis in Western world. I think I strongly believe that it's going to stay and it actually will take over most of the laparoscopic work once the costs and financial things get better with the advancement of technology. So this is the one type of robotic surgical robotic system. This is the American company. It's the Intuitive, which had almost monopoly until 5 years ago. And over the last 3 years, there are other models coming up. And this is the patient operating table. And this is the robot with 4 arms. And a scrub nurse and a surgical assistant would be sitting, would be there along with the patient at the operation table. And this is the vision cot. That is, there is a monitor with vision and the other equipment. And this would be the surgical console. That is where the surgeon sits and operates. Some modifications in the latest versions of surgical robot is, this is the surgical robot. All 4 arms can be separately placed rather than having a bigger one. The separate limbs can be placed from different directions of the patient table. And again, there is a surgical console here, and there will be a vision cot, visions, where you have monitors. This is a UK-based company, and many more varieties are coming up with a lot more modifications. So, robot-assisted surgery, there is a robotic surgery. There is a misconception among the public that, watching so many films, they do fear that the robot might get out of control and do the procedure by itself. But that is wrong, because the robotic surgery works on the basis of master-slave principle. Master is the surgeon and robot is the slave. The robot cannot move in a single millimeter without the surgeon's involvement. The first robotic surgery was done in orthopedic specialty. And then from late 90s and early 2000s, it was performed more so in thoracic and laparoscopic approach. Thoracoscopic and laparoscopic approach. Initially, it was practiced mainly for urological and thoracoscopic mediastinal procedures like esophagectomy. And later on, it was taken up by surgical oncology, gynecology, gastroenterology, and general surgery. It is there since the last 20 years. It is a lot more widely practiced and accepted across the world since the last 5 years. What are the advantages of robot-assisted surgery over traditional laparoscopic surgery? We can see better, we can move better. That is the main advantage. And the surgeon, rather than having 2 hands, surgeon can have 4 hands. That means he can control 4 arms, 2 for operating and other 2 for the camera. So the vision is a magnified 3D vision. It is magnified 8 times in one type of model and 6 to 10 times in another types of models. And the depth perception is much better than a traditional laparoscopic vision. And the camera is under the surgeon's control. And here the surgeon, the robotic surgeon, is a combination of laparoscopic surgeon and laparoscopic assistant surgeon. He will control 4 limbs of the robot. And the dexterity and the freedom of movement. The laparoscopic instruments are usually rigid. They move only in 1 or 2 directions, whereas the robotic instruments actually have a endo wrist and elbow in the instrument. So they actually have a better movement than a human wrist. They have 7 degrees of movement, and it all actually filters the tremors of the surgeon's hand. So the advantage is, in a tied surgeon, sometimes the surgical tremor will be there. In laparoscopic surgery, because of the long instrument, a small tremor of the surgeon's hand can be magnified when it is coming to the other end of the instrument, operating on the patient tissue. But whereas in robotic surgery, the surgeon's tremor is completely filtered. So the top 2 are, we can see better. The lower 3 are, we can move better. And then we have more control over the instruments and the camera. So all that lead to better precision and a potentially less collateral damage and lesser complications. The other advantage is robotic surgery can be practiced as a remote surgery. Robotic surgery was actually started because of it was initially developed for the purpose of war zones, so that the medical personnel doesn't have to be in the war zone. They can stay far, and then they can operate on the wounded soldiers who are placed in the war zone if the infrastructure is present in those areas. So, and then later on, the robotic surgery was transferred to the civilian population. So that possibility is there, remote surgery. So the possibility of remote surgery will actually provide better healthcare facilities to different areas of the world. And also it improves the training opportunities because of the remoteness possibility of remote surgery. The disadvantages of robotic surgery is mainly cost. It's mainly cost, because it used to cost a lot more 5 years ago, 10 years ago than now. And hopefully with the advent of technology and with the end of monopoly, there is only one American company which used to monopolize this market until 5 years ago. And then over the last few years, there are other companies from different countries are coming up in the market. So that usually leads to reduction of costs, and hopefully that would be in the next 5 years. And because of the presence of robotic arms, the time taken to convert a laparoscopic surgery to open surgery would be more in robotic surgery. But that disadvantage is also being tackled in the latest models of the surgical robot. And access to training is very much limited now. It took me a long time to get training in the robotic surgery. I had to go to different countries, and even in India also, I had to go to different places. It took me almost 3 years to become a certified robotic surgeon. So those things, all these things need to be improved to give better access of robotic surgery to the general population. Once again, thank you for your time, and thanks for this opportunity.
That's a good presentation, Dr. Ganesh sir.
Thank you very much, sir.
Are there any questions? I myself have a small question, sir.
Sure, sir.
Can you just give me 1 or 2 surgical scenarios where definitely robotic surgery scores over our routine laparoscopic surgery?
A lesion in the posterior superior aspect of the liver, in that area, the access is much better with the robotic surgery. Being the instrument, the robotic instrument having the endowrist, it acts like a human wrist, but it has the advantage of laparoscopic approach. So it can go over it and remove it. Whereas with laparoscopic instrument, you can only do directly with a minimal restricted movement.
Thank you, sir.
And other traditionally accepted advantages in prosthetic surgery.
Okay.
True, madam. Yes. Anastomosis is much more.
Urethral anastomosis is better with robotic.
True, madam. Yes, madam. Any anastomosis, suturing is much more easier in robotic surgery because it combines the advantages of both open surgery and laparoscopic surgery. Because the hand moves in laparoscopic surgery, it is a different skill, the suturing. Whereas in robotic surgery, you feel as if you are just doing an open surgery, but you have the advantages of laparoscopic approach of minimal access. You are right, madam.
You're practicing both, so you better understand that. And even in oncology also, lymph node retrieval is better with robotic because of it 180 degrees orientation.
True,
the
madam.
lymph node retrieval is also better with robotic surgery.
True, madam. Yeah, true, madam. Yeah.
Thank you, sir, for your excellent presentation with your videos. We are better able to understand the techniques well. Thank you, sir.
Thank you very much, ma'am. Thank you.
On a lighter vein, I think we'll see more and more great robotic surgeons in future because medical students these days are by default good gamers.
That's true, sir.
I request Dr. MLV Prasad Garu to come and hand over the memento to Dr. Ganesh Garu.
Dr. MLV Prasad Garu, please hand over the memento to Dr. Ganesh Garu.
Sir.
Now we are moving on to the next session. Cancer. We know that it is the most deadliest disease and the most fearsome disease. Now I'd like to introduce Dr. Vikrant, surgical oncologist, currently practicing in American Oncology Institute, Vijayawada. He did his MBBS, MS, DNB in surgical oncology and had rich experience in various fields of surgical oncology, such as gastric, colorectal, and genitourinary surgeries. And he has keen interest in minimal invasive surgery also. And he is involved in presentations in both national and international conferences. And he is an active member of ASA and IASO. Dr. Vikrant, please.
Yes, ma'am. Live. Good afternoon, everyone. Thank you, IMA, for inviting me to this talk. So since Ganesh sir has taken us into the future, I'll just rewind back into the past just to see how the evolution of medicine per se and breast cancer has come into play. The history of breast cancer is a complex maze in an attempt to understand the nature of the disease and the will of the physicians to conquer it with surgery, chemotherapy, radiotherapy, and hormonal treatment. The first ever descriptions of cancer is done way back in 2500 BC in the Paparitial age, when it was described that anything which is cool to touch, bulging, and which is spread all over the breast is considered incurable. These are one of the earliest written documentation which were found in the papyruses. Hippocrates in 400 BC, he described that cancer is caused by imbalance in humors. He described 4 humors. Humors means fluids, body fluids. One is blood, phlegm, yellow, and black bile. Any imbalance in these 4 humors will cause cancers. That was the perception at that time. Galen in about 200 AD, so he attributed the cancers, breast cancer, to the accumulation of black bile in the blood and concluded that it was a systemic disease rather than a localized disease. He also postulated the observation that cessation of menstruation was somehow linked to cancer. So in a way, he was the first one to point out that old age is related to cancer. In line with his theory, Galen first, he has done the earliest excision of breast lumps, but he allowed it to bleed freely because he thought that the accumulation of black bile was the cause of the disease. So he did not suture the wound or he did not do anything to close the wound. He just let it bleed freely. So that was the time when the word cancer was coined, because they made the observation that the body of the crab looked like the mass of the cancer, whereas you can see the extension. The extensions, that is the legs of the spider, the legs of the crab were like the neovascularization, which usually do happen in cancer cases. That is how the term carcinose was coined. So from 400 to 1500 AD, not much movement in medical science happened because people were occupied in religious war. So no upgradation in scientific thinking happened. No autopsies were allowed by any religion. So they could not find out the cause of disease or the progress of disease, and they could not find much treatment in this era. The next thinking happened in the 16th century when Leonardo da Vinci and Andrea Vesalius, they have made some inroads into anatomical descriptions by doing animal anatomical descriptions and then attempting the same on the humans. In the 16th century, John Hunter, he was the first person to describe that the breast cancer can spread through lymphatic spread. So he also termed that if the tumor is movable, there is no inappropriacy in removing it. So if there is a mobile tumor in the breast, it has to be removed. That was the earlier concept that was proposed by John Hunter. These were the early instruments which were used to do breast surgery in those days, more like a guillotine of the breast, I should say. In the 19th and 20th century, the modern medicine have started. Rudolf Virchow first described that it is because of the cell division which caused the cancer. Virchow also believed that it is the severe irritation of the cells which caused the multiplication of cells causing cancers. And also in the 19th century, that is the second half of the 19th century, that anesthesia and asepsis were introduced, and this was the starting of the golden era for surgery. This person, William Halsted, he was the father of breast cancer surgery. In 1894, he publicly demonstrated that radical mastectomy was the cure for breast cancers. That was the time when the surgeries were done. So he proposed that the cancer first spread to the lymph nodes, and only from the lymph nodes it spread to the systemic organs. So it is a sidewise movement of the cancer cells. So now this theory is also not in vogue. Yeah, he proposed that the suspected tissue, the entire tissue had to be removed in a single piece. Otherwise, the wound will be infected by the cancer cells, and there can be secondary recurrences in the tumor. These strict rules of non-violation of the tumor precluded a preoperative biopsy also. So only by clinical observation, they used to do such a radical surgery. So look at that, you can directly see the chest wall. Okay, so the entire breast tissue along with the pectoralis major, pectoralis minor, axillary vessels, everything was removed in Halsted's radical mastectomy. So when a postoperative patient is seen, you can directly see the chest wall, the ribs directly. This was the surgical extent at that time. But surprisingly, for the next 60, 70 years, this was the only surgery that was being done for breast cancer surgery. You can see that. The complications are also very gross. You can see the monstrous lymphedema in the figure down below. So in the 20th century, the second half of the 20th century, there were some modifications to a radical mastectomy. The Peitis and Auchincloss, they have proposed that the removal of the muscles, that is the pectoralis major, pectoralis minor, were not really necessary, because the spread of the tumor is not exactly like Halsted described. That is not from the breast tumor directly, it may not spread to the lymph node in all the cases. And the muscles need not be removed for this. So these modifications were the first to be done even after 50 to 60 years after Halsted mastectomy. Bernard Fisher, I would say he made a significant contribution because he was credited with bringing clinical trials into statistical methodology to breast cancer research. He was the first person who described that doing a wide local excision is as effective as mastectomy in attempting a cure for breast cancer. Though radiation X-rays were discovered in the late 1894, radiotherapy was used for breast cancer only in the 1940s, because till then the uses of radiotherapy were not totally known. Hormonal therapy, breast cancer as a hormone responsive disease was known in the 1950s, and tamoxifen, the first anti-hormonal agent, was used in 1970s. In the late 1990s, Umberto Vernesi is an Italian surgeon. So he thought that partial removal of the breast and adding radiation is equivalent to mastectomy in curing the breast cancer. He also proposed that the entire lymph node removal may not be necessary for the cure of breast cancer. Sentinel lymph node biopsy it came into place 3 decades ago. I'll explain it later. In 1980s, HER2/neu was cloned, and trastuzumab as a treatment for HER2 positive breast cancers, it was approved by the FDA in the 1990s. And in 1995, BRCA1 gene and BRCA2 gene were also cloned. Aromatase inhibitors, which is also used for hormonal manipulation of breast cancer, they were also came into existence in the 1990s. So the last 3 decades made a significant contribution for the development of breast cancer treatment. So this is the injection of the blue dye, so which we use is methylene blue. It is injected peritumorally or in the subdermal region. And within 10 minutes, if you do the dissection in the axilla, this is how the node looks like. And if we take this lymph node and send it for frozen section, if it is positive for malignancy, then a proper axillary lymph node dissection has to be done. If the lymph node is negative for malignancy, then probably lymph node dissection also can be omitted. So this is one great improvement in the past 2 decades. The evolution of multidisciplinary treatment. Though surgery, radiotherapy, and chemotherapy, along with hormonal therapy, they all improved in their own way. But it is the combination of these treatments which caused the maximum improvement in cure rates. Even now we see these patients. Suppose this patient probably 50, 60 years ago, she used to undergo radical mastectomy. But now we have given neoadjuvant chemotherapy. And after chemotherapy, we have done a surgery and then a flap, LD flap for the coverage of the area. So this is how the treatment has evolved over the years. Though we do see the stage 3 diseases now, but the treatment is much better now, because with the advent of neoadjuvant chemotherapy, we are downstaging the disease by giving chemotherapy, and then we are operating in a better environment compared to previously. You might be knowing her. In 2013, she suddenly announced that she was BRCA1 positive and she wanted to undergo a bilateral prophylactic mastectomy for prevention of breast cancer. See, on one side, we are seeing diseases of this stage. On the other side, they want to undergo a prophylactic mastectomy. So, Angelina Jolie, I don't know how much she understood about breast cancer treatment, but what she has done is she has done great amount of advertisement for breast cancer. So most of the people, they underwent BRCA1 testing because of her, and some people also, they got the bilateral mastectomies inspired by her. The present standard of care for an early stage, that is for stage 1 and stage 2, still is breast conservation surgery. And in elderly patients who are not willing to conserve the breast, it is modified radical mastectomy. For locally advanced diseases, neoadjuvant chemotherapy has to be given so that the micrometastasis have to be dealt with immediately, followed by surgery and radiotherapy. And in all stages, hormonal treatment has to be added if the breast cancer receptors are positive. The new term is oncoplastic breast surgery, because 100 years ago, breast cancer was totally in the surgeon's domain. Now, with the advent of neoadjuvant chemotherapy and radiotherapy, probably the role of the surgeon got diminished, but the surgeons were not very happy about it. So they coined a new term, oncoplastic breast surgery. So they combined with the principles of plastic surgery just to make the cosmesis look better. So oncoplastic breast surgery, it is the new term and it is in vogue in most of the places. So it involves the plastic surgeons and the cancer surgeons in maintaining the cosmesis of the breast compared to that of the opposite side. So cure sometimes, treat often, comfort always. This is for oncologists, I guess, though it was coined by Hippocrates, but it definitely suits for oncosurgeons. This is the cure rates. Previously, when I was doing my training in oncology, the 5-year survival rate was only mentioned. 10-year survival rate was not mentioned at all. Nowadays, 10-year survival rate in breast cancer is almost 80 to 90% in stage 1 and stage 2. Whereas stage 3, previously it was less than 40%. Now it is between about 60 to 70%, which is a great improvement in survival rates. For 10 years also, even for stage 1 and stage 2, it is above 60%. For stage 3, it is around 40%. Stage 4, anyways, the numbers are very less, but still the survival of 10 years is not very much mentioned for breast cancer. Our aim is to minimize the number of stage 3 and stage 4 cancers. So we believe in early detection and treatment. So annual mammography is one thing which is advised. So if there are any suspected lesion, ultrasound guided FNAC or biopsy has to be done so that early pickup improves the cure rates. Thank you.
Thank you, Dr. Vikram. As you told, we moved on from radical mastectomy to breast conservative surgery, and breast cancer anyway, it is the most common cancer. Can you tell what are the contraindications for breast conservative surgery?
First thing is patient wishes. Most of the times, how well you counsel the patient will always listen to the neighbor of his house. Patient will never listen to the doctor. They'll only listen to their neighbors. If the neighbor says it is okay, then it is okay. Okay. For clinically, it is tumors less than 3 to 4 centimeters of size and node palpable lesions. We are, sorry. Okay. Less than 3 centimeters of size, we are advising them breast conservation surgery. For tumors which are more than 4 centimeters in size and very close to the skin, we are not advising breast conservation surgery. And one more thing is multifocal disease or multicentric disease, to be precise. If there are multiple lesions within the same breast, then also breast conservation surgery is not advised. It is better to do a mastectomy in those patients. And if there are bulky nodes, then also patient is advised to undergo neoadjuvant chemotherapy, then only breast conservation surgery can be considered.
Thank you. Any questions from the audience? Thank you, Dr. Vikrant, for your lucid presentation. We will moving on to the next session. I invite Dr. Parthasarthi Garu to present the moment to Dr. Vikrant.
తప్పకుండా సార్. Moving on to the next topic, next speaker, I would like to introduce Dr. Shivprasad B. Mukanwar, a cardiothoracic surgeon. Dr. Mukanwar did his MS General Surgery from prestigious PGI Chandigarh. Later did his MSH from another great institution, AIMS New Delhi. He performed about more than thousands of open heart surgeries in both adult and pediatric patients and published numerous scientific papers in both national and international journals. He specializes in off-pump CABG, minimally invasive cardiac surgeries, aortic aneurysm surgeries, lung surgeries, LV remodeling surgeries for heart failures, and innovative surgeries like hybrid ASD closure, awake cardiac surgeries, modified Ross surgeries. With this, I present to you, ladies and gentlemen, Dr. Shivprasad B. Mukanwar, cardiothoracic surgeon.
Good afternoon, everyone. Thank you, sir, for your kind words and giving my introduction. My topic is regarding the surgery in advanced coronary artery disease. You already know that abdomen is a Pandora's box and anything can come out. But unfortunately, thorax is such a non-recordable black box. Whatever surgeon is doing inside, most of the people, including anesthetists, may not be knowing. So why this topic we have chosen is everybody knows what is coronary artery disease and how the surgical treatment, that is CABG, is done. And unfortunately, including the cardiologist and a few of the surgeons, even cardiac surgeons, they don't address some of the aspects of coronary artery disease which required more than CABG. So what I was saying, chest pain, everybody knows. The most important thing is coronary artery disease. They do present with breathlessness and heart failure. In fact, the Framing Heart study has shown that 52% causes of heart failure is coronary artery disease. And this is what we see when somebody refers for any patient, cardiologist and everybody thinks that this is a heart. Okay, this is a normal heart, but as a surgeon, we receive the heart like this. They are obese heart and they are not functioning well. Those ejection fraction is 50%. Whenever we do surgery, often we end up in some sort of problems. And we all know that after myocardial infarction, suppose if the patient develops myocardial infarction, he undergoes many problems. Like one is the loss of muscle and becomes this akinetic segment that may get distended, become dyskinetic segment and become aneurysmal. So when patient comes, everybody presume has come in the normal stage or this akinetic stage. And invariably only by doing CVG, he may go home, but he will come back to us again and again because we have not addressed the regional wall motion abnormalities of the heart, which were neglected. So what are these advanced coronary artery disease means? These are the coronary artery disease with the heart with the dilated dimensions, with a large non-functioning akinetic segments, with aneurysms, with mitral regurgitation. Some of them are a traumatic, some of them are a ventricular septal rupture or a free wall rupture. So when we offer CBG in such cases, CBG is not the only treatment in such cases. We have to add some other surgical spectrum along with CBG. So if you don't add, they will come back with readmission. Often 30% of our practices following CBG all over the world, they come back for redo surgery or some other things which are left during first time CBG. So here I want to tell you that whenever you see any case of a CBG, if he's coming back to breathlessness, you have to remember that there is something which could have been done either medicines or with the surgery, not CBG alone. If you address all those things, these patients will get discharged with very less recurrent admissions. So this concept, like many strategies were involved in before 2000, year 2000. Though people went from changing the mode of surgery from on-pump arrested heart to beating heart. So initially, like this is the heart which is standstill, and we are doing anastomosis. This is arrested heart, and this was the gold standard. And we found that many people are coming back. Later on, shifted with the off-pump mechanism where heart is beating, and we are doing anastomosis. Either of the method, it didn't resolve the problems which were arising following surgery. So there was something else which were missing. In last 2 decades, we started addressing. In our hospital, we address the holistic approach, including all the problems with the coronary artery disease, which can be dealt with surgically. So instead of telling scientific data, I'll just briefly, few cases I will enumerate, I'll just discuss with you. One of the common thing which is neglected following CVG is mitral regurgitation, which is because of ischemia itself. If you don't address, patient will come back with breathlessness again. His chest pain must have been resolved, but not the breathlessness. One of our patient who presented with the ischemic MR, he had ejection fraction of 45%. And when we did echo, you can see this mitral wall between the left atrium and this left ventricle. It is leaking, causing regurgitation. This is exactly the, mitral wall is not approximating here. And this other side is the color flow showing the leak in the mitral valve. His coronary angiogram, we did multiple blocks, which you can appreciate here. When we performed CABG with mitral valve repair, this was the end result on table. You can see mitral valve is closing well. There is no regurgitation. If I would have done only CABG for this patient, certainly would have come within 5 years, come back with breathlessness. We have repaired his valve. Now the chances of survival, readmission, symptom-free readmission, 10 years much better if we wouldn't have addressed his mitral regurgitation. This patient was discharged on 6th day and went home. What I'm showing is a graph where if you manage CVG with a medical treatment for mitral regurgitation, the cardiac events are 63%. If we address with the MR, with the mitral regurgitation along CVG, only 22%. Even the symptoms also very high if you leave mitral regurgitation in coronary artery disease. Next, another advanced lesion is some of the coronary artery disease, they come with chest pain, which may not go even by treating, giving anti-anginals. And we found that such patients have some sort of a aneurysm of the left ventricle. Normally, in such cases, when we evaluate with echo, it shows some bulge here from the LV apex. And CT scan showing same bulge in the LV apex, which the apex is also calcified. And in such cases, surgery is the only treatment. Only bypass surgery in such cases is not useful. We have to address the aneurysm also. Then only his longevity and outcomes are better. And these aneurysms we can repair. Most of them are on pump with arrested heart and sometimes on pump with a beating heart. Blood? Can we listen to the audience? This is it, one of our case. Increase. This is LV aneurysm repair. This is fibrillating. Because our the LV aneurysm repair.
This is not
The surgeon is short. This is what the surgeon.
only septum is pushing. This is because this close is not contacting. Feel here. Here also like this much is not contacting.
And in the heart.
This much is not contacting.
And
this is not contacting. This is whitish infarcted area. This
so
is
what I'm
whitish
saying is,
infarcted area.
sometimes we do such
Can you make out?
cases on beating also with pump support. This was the
Stop it.
Not moving it. Yeah, this is the preoperative chest X-ray with aneurysm. See, the cardiomegaly is reduced following the CABG with aneurysm repair. This was the patient who went home on day 9. Another multiple photos. I'll skip this. Another case we see it's a rare case. Sometimes LV aneurysm, they present with chest pain and ventricular tachycardia. Suddenly they are thought like MI and patient will be taken for thrombolysis or angioplasty. But this is a unique case where patient having aneurysm only with arrhythmias, he presented to us. The left ventricle, this is the left ventricle, what we are seeing here now. The dye is injected into left ventricle and there is a pouch which is coming below. Here. There is a leak from the posterior aspect of the left ventricle. You can see that that was an aneurysm. When we operated this case, which was on pump with arrested heart, there was a rent, we have closed it, which was aneurysmal. And only this patient required aneurysmal closure. And unfortunately, the coronary artery was very diffuse. We couldn't do CABG, but it was managed medically and patient went home, discharged on day 9. So this is about LV aneurysm. You know, some coronary artery disease, they come with ischemic heart attack, but there is no aneurysm. You know, that black line where it is very thin, muscle is lost. Can we do something for this? Like in next slide, what I will be showing is a cartoon segment. You can see the blue line. Here is the infarcted segment. And the red one is a viable tissue. If by surgically exclude the infarcted segment and make entire left ventricle viable, and which will be functioning very well, because uninfarcted heart ejection fraction less. If I exclude it, the ejection fraction will increase. Similarly, in another histological slide, same thing. The anterior wall, which is yellowish color, which is non-viable. One of our patient, he presented with the kinetic segment. Angiogram we performed, there were multiple blocks. This is a left ventricular angiogram. Catheter is in left LV. You can see the heart is not moving, only the basal area is moving. Apex and the rest of the parts are not moving. What we did in this case is LV restoration surgery. We took out the infarcted segment, excised it, and reconstructed the left
LV is opened parallel to LAD and the patch reduction is being done now.
Here I am showing echocardiac improvement of this same patient.
The left side is this is
This
free of
where the cursor is. You can see it's a hockey stick like a globular heart.
and here this
which is
part is
dilated.
akinetic, partly dyskinetic with spontaneous
The right side.
contrast. This is post-op immediately. You can
There are
appreciate
recruited segments.
all the most
The
of the
akinetic segment is gone.
all of
Entire
the
heart
left
is
ventricle
viable
has
and
been
functioning.
recruited well here. Apex here is a patch present.
Same patient after second day after surgery.
This is post-op day
You can see
2
the
image.
left ventricle. This is LV, which the
Video
chamber is moving.
was
All the
on
chambers are moving.
LV
So we have restored his
remodeling
LV
surgery.
by geometric alteration
Patient
by
is doing
doing this
well,
remodeling
extubated
surgery.
and ambulating.
Nowadays we are doing regularly this LV remodeling surgery along with CVG. This patient, he was my first case who discharged on day 10. One of the advanced lesion is following ischemic heart attack is rupture of the interventricular septum because of infarction. It is called post-MI ventricular septal rupture, that is VSR. Here we have to repair the hole between the left ventricle and right ventricle, and also the block coronary arteries which are blocked, we have to do CABG. This is our patient who is breathless, tachycardic, and desaturated. He is literally orthopneic, coughing. Heart rate is 140, saturation is 88. She has a post-MI VSD. When we did, you can see there is a flow going from left ventricle to right ventricle. That is a ventricular septal rupture of this patient. And when we opened the left ventricle,
Is infected.
bypass initial some grafts.
You can see multiple rents here. 1, 2, 3. It's a huge infarcted area with VST, multiple VSRs.
So this
1,
case,
2, 3.
this
From
case,
here to here, it is infected area.
surgery successfully. We placed the patch across the ventricular septal ruptures. Now there is no flow between the left ventricle and right ventricle. The patient went home on day 10 with good LV function, and she underwent CVG plus VSR closure. So this is one of the advanced form of coronary artery disease which patient present with a mechanical complication. Post-MI VSRs are very rare. I'm 100% sure in a surgical lifetime, we end up in doing around maximum 5 to 6 cases. And fortunately, unfortunately, we could able to do 6 of such repairs in last 1 year. So far, we have done more than 10 repairs in last 3 years. Another complication of advanced lesion is left ventricular free wall rupture. If the infarct happens to the lateral wall of the heart wall gets ruptured and it starts leaking. Where I'm finger pointing, there is a rent in the left ventricle. Okay, this was a case who presented in night around 12 o'clock with no almost negligible pulse, only cardiac pulse was present with a massive MI with a LV rupture. And LV rupture almost catastrophic. When we opened the pericardium, when we opened exposed the heart, entirely it was ruptured, it was bleeding, all over blood was present. Normally we place sutures and close it, but sutures won't hold on the infarcted heart. In this case, this is probably the first time we used with a patch closure with the acrylic glue, and this glue it was not available, and Fevikwik is the one glue which is acrylic glue. We autoclaved it, used it, put it over the heart, put this PKF patch, and surprisingly this patient went beautifully and he went home on day 7. And in my recollect, earlier one case was operated in Delhi with this repair, and this is the second case in India. Because these patients don't come to us, they are gone by the time their heart is ruptured. So we at Ramesh Hospital, we manage all spectrum of a coronary artery disease. CBG is not the only tool. The take-home message is any patient having ischemic heart disease, if he is coming back to you something, if there are any surgically addressable issues, those things needs to be addressed even after surgery, CBG. Sometimes 5% of our cases following CBG, we are taking them for redo surgeries for mitral valve or some other problems. And Ramesh Hospital is the one of the topmost this post-STEMI CBG following ST elevation heart attack. We have done CBG is the highest volume in India in the world. We have done 500 cases in US and in European countries. There are literature of 200 or 300 cases reported, and we have the highest series. And we have the highest series of CBG with a left main with MI. It is in the world, not only in Andhra Pradesh. Thank you very much. Probably this is the alien subject. I don't presume people will be having any questions.
First of all, really impressed with the amount of work you have done in the work you have shown. I don't know how many of the medical students have followed what the doctor has operated. Operating on a post-MI LV rupture and saving the patient. That is real Marvel's Avengers stuff. I think you need a standing ovation, sir. Because that is Dr. Professor P.V. Sudhakar, Principal, Andhra Medical College. He's got a question for you, sir.
Good afternoon and congratulations for a wonderful work, which is the offbeat procedures that you have been doing. But my only comment has been on the tissue glue. So tissue glues are commercially available. So cyanomethaxylate glues are commercially available. They can be used. The second one is you can always use the fibrin glue, which is prepared, which is manufactured by Baxter company. Now that you have autoclaved and got away, but I don't think that it would continue because that leads to a lot of tissue reaction over a period of time. So it's not always possible to get away like that. But you have commercially available tissue glues, the cyanoacrylate tissue glues, as well as the fibrin tissue glues. I think better you try them.
So they are available. And in that moment, it was not available in Vijayawada. It was not available, sir. So we modified it. 3 months following this LV rupture, we got his MRI done. And MRI showed, good preserved thickness, no erosion, no aneurysm. No, we couldn't publish in our own faculty because nobody will tell you, people object if I use Fevikwik and close this rent. We have to have a proof. So we did MRI. Then we put it in a WhatsApp our group to see the reaction in the cardiac surgical team. When everybody appreciated when we wrote the paper and we sent it for publication. Thank you. Thank you, sir.
So it's an excellent presentation by Dr. Mukanawar, sir. Kindly accept a memento on behalf of the organizing committees.
Lastly, I'm really thankful for the IMA giving me this opportunity to speak some of the scientific things what we have done. And thank you each and everyone. Thank you.
I once again thank the organizers for giving us an opportunity to chair this session. And that was great stuff, listening to Dr. Vikrant, Dr. Ganesh Garu and Dr. Shiva Prasad. And we would like to close this session with this. Thank you.
Sir, please accept a memento on behalf. Sir, I request Dr. Vijay Sagar sir to come over and hand over a memento to the chairperson. And So it's our proud privilege and honor to invite Dr. P.V. Sudhakar Garu for today's first oration, Gurumurthy Memorial Oration. So it is our privilege. We kindly invite Dr. Sudhakar Garu to come on to the dais, and we invite Dr. Samaram Garu to be the chairperson, and also Dr. M.L. Prasad Garu, Andhra Hospital Seluru, to be the chair for this session. Thank you.
Good evening. I welcome all of you. IMA AP State Gurumurthy Oration. The orator is Dr. P. Sudhakar Garu, Principal, Andhra Medical College. He will speak on plastic surgery. Regarding Dr. Sudhakar, we'll introduce our coach here.
Good afternoon, everybody. I think you don't require any introduction. Very well-known plastic surgeon from Visakhapatnam. He is professor and HOD of Plastic Surgery Department, KGH. Formerly Superintendent, Chairman Board Studies, Dr. NTR Health University. Is a member of Specialist Board. Former Director, Visakha Institute of Medical Sciences. Former Vice Chairman and IC AP Medical Council. Special Officer, COVID-19 North Coastal Area. I think at that time he received award also for that. He did his he received so many awards, among which award for outstanding services by district collector 9 times. I think he requires this thing, applause. PSCF International Scholar Award for American Society. RG Saria International Fellowship of Association Plastic Surgeons of India. Received State Best Teacher Award, Government of Andhra Pradesh from Honorable Chief Minister Y.S. Rajshekar Reddy, year 2007. Delivered many orations of IMA and Association of Surgeons of India. Recipient of Rupa, Shilpi and Seva Brahma Awards. With these few words, thank you.
Okay.
Respected chairpersons, ladies and gentlemen, I deem it's a privilege to stand before you on this occasion, and I wish to thank Dr. Srinivas Raju and the entire organizing team for having invited me to deliver this prestigious oration. My special thanks are to Dr. N. Subramaniam, Dr. M.V. Vijay Shekhar, Dr. P. Krishna Sai, who have helped me in getting the information on Dr. Palakodeti Gurumurthy. Orations of this nature give us an opportunity to recapitulate the great work that's done by the persons in whose name these orations are instituted. I'm truly privileged to deliver this oration today of a great person on whose name this oration has been instituted. Dr. Palakodeti Gurumurthy Memorial Oration. Dr. Palakodeti Gurumurthy, a unique personality, a great human being, had many features which need to be emulated by each one of us even today. Dr. Palakodeti Gurumurthy was an outstanding physician of the yesteryears years, a great social worker and reformer, a freedom fighter. This is what I could gather from his life history. Being a wonderful physician as well as a great freedom fighter and a social worker, he was elected as the municipal chairman of Rajahmundry, being in the hearts of everybody in Rajahmundry. He was the founder of Andhra Medical Association in 1939. And this association was formed by amalgamating many smaller associations in various cities in the state of Andhra Pradesh. And they rose the membership to over 600 those days. And later, he has merged this with the Indian Medical Association at the national level, which used to be known as Andhra Provincial Branch of Indian Medical Association in the lines of the Indian National Congress those days. And he served as the president of Andhra Provincial Branch of Indian Medical Association, that is the state IMA that what we have today, from 1945 to 1947. It's truly an honor to deliver an oration on his name. Here you can see Dr. Palakode Gurumurthy along with Jawaharlal Nehru. So just to depict the greatness of the individual about whom we all should learn. Ladies and gentlemen, this afternoon I stood here not to speak about plastic surgery, but a topic which is dear to all of us, a topic each one of us, an MBBS graduate, would have to learn, would have to understand. I took up a topic of common interest to all of us, which is the prescription and advertisement issues and challenges. And this general topic needs to be discussed. Why do we have to discuss about a topic of this nature? Here, if you see this celebrity, whom we...
But unfortunately, whether you agree or not, most of the doctors are bad.
You have to remember that statement. Maybe, of course, you may be feeling that, but you have to change that idea because your idea is not that. You may tell it like that. In the cinema, there is a different issue, but in the public platform, and to tell that the majority of the doctors are bad.
I can understand, but I'm sorry, sir. I really stick by my words.
For those who could not hear properly because of the noise there, he says, these are the people who represent the common public today. He says, unfortunately, whether you agree or not, most of the doctors are bad. And the ex-DME protests saying that you have to withdraw that statement. That may be true in cinema, but it's a different issue altogether there. But on a public platform, you're not supposed to say that the doctors are bad. But he retorts saying that I can understand, but still I really stick to my words. So this is the public perception, what we see.
But unfortunately, whether you agree or not, most of the doctors are.
So with that public perception, I think we are all vulnerable. Why are the doctors vulnerable in the society? Because some of them treat us as gods. They expect everything that the God does for an individual, or expect the God to be done. And they think that the hospitals are the temple of health, and everybody that goes into the hospital should come out hale and healthy, and there cannot be any mortality. And for every death, it is the doctor who would be responsible. And the people's unrealistic expectations are something which we all have to deal with day in and day out. The expectations are so unrealistic that you cannot match them most of the times. And many a time, patients come with a lot of hope. And if that hope is not met with, then there are so many other issues that crop up. But at the same time, we have to have some introspection into what we are doing. Are we doing everything right? Are we following what the patients are expecting of us? Are we doing the real service, or are we doing the business? So over a period of time, as you understand that the service activity of us has turned into something like a business, because patient has been made a consumer because of the Consumer Protection Act. And trade license has to be taken by all of us when you run a hospital. And you're required to have 17 different government approvals to start a hospital. And of course, the taxation, which is at the uppermost level when you are dealing with this, when you are earning something through the hospital or through the patients. In order to have a balance between what patients expects of us, what the society expects of us, and what we are supposed to do, there are so many of our own organizations which have set up certain rules. The first one is the IMC, Indian Medical Council 1956 guidelines, in which they have promulgated certain rules of etiquette or certain rules of ethics, which were incorporated in 2002 and updated till 2016. Recently, as you know, that National Medical Council Commission has taken over, and they have largely depended on what has been given by the erstwhile Medical Council of India. They have not made regular rules and regulations. But the Indian Medical Association at the national level thought it is appropriate to have our own guidelines for the medical ethics or the rules and regulations which we follow in order to meet the expectations of the people. These are called the IMA Code of Medical Ethics 2021 recently. But the main problem here is that there is no sanctity to what IMA tells us. IMA gives us guidelines, but there is no way that people can adjudicate on what the IMA tells us. IMA is not a legal body. IMA cannot make it as an act. So it has to come through the government. That's where we are lagging behind. But if you see this particular document of 2021, it basically expands whatever has been said in the Medical Council of India document of 2016, but a little wider expansion. But a lot more need to be done to this 2021 document, which I have read completely. So that indicates that we are far from the reality. We have to have a realistic approach towards this particular problem. So when three of these put together, if they give us certain guidelines, and if it is made into an act, if they are to be made, they are made mandatory to be followed, then only the sanctity to this particular document will come up. We all know that we want to practice ethically, but the four cardinal features of an ethical practice are, as you all know, the autonomy. That means you give patient a chance to know what treatment is being done and what the options to be known and what options need to be selected by them. And the justice means you take care of every patient equally, whether it is rich or poor, whether it is from any society. And always try to do good and do no harm, which is much more important. If you do not know about something, better refer such patients and not try to do any harm, both intentionally or unintentionally. Coming to the prescription. So here, there are so many of these clauses that are available in the Medical Council document. However, I took only two of these for the sake of convenience and for the paucity of time. One being the prescription, the other being the advertisement. As you know, the clause 6.3 of the document given by the Medical Council of India says a prescription has to be made solely on the medical need, only when it is necessary. And a doctor should not run a medical shop or a surgical shop, can supply medicine or the surgical items out of interest towards the patient in his own chambers. And one cannot have a favor in return to a prescription or selling a particular medical aid, what we call no quid pro quo. And one has to respect the autonomy of the patient, where to buy. You cannot force a patient to buy at a particular place. Should not refer a patient to a place where the item is available, which is managed or owned by the physician. These are the cardinal signs or the cardinal points or the principles that were put forward. We all know about this. And
they also said in the clause 1.5, every physician should prescribe drugs with the generic names, legibly and in capital letters. This is where the problem comes. When people talked about the generic names, when people, including the Supreme Court, has given a verdict saying that prescriptions are to be in the generic names, they never spoke to the doctors. The main stakeholders here being the doctors, they never took the advice of the doctors, but it all went unilaterally, more so from the administration and judiciary. So here comes many problems. So for this, the IMA document, which I was referring to in 2021, has said all drugs prescribed by the physician should always carry a proprietary formula and a clear name. This is what the explanation that was given in the recent modification, but this is also far from the necessity in the sense that we really do not know what needs to be done. So let us see what the challenges that we have. So by prescribing generic drugs, basically we are all depending on the quality, which is highly questionable. We know quality is the only thing which gives us an idea that particular drug needs to be purchased. Who is ensuring this quality? No one ensures the quality in this country. That's the reason why many of the doctors are scared of prescribing by generic name. If generic prescription is to be made, then what happens to the experience of the doctors who have been doing for many years? For many years, you are prescribing a drug with a particular name. Your experience says that it works for the large majority of the patients. Now you are suddenly converting it, saying that you have to prescribe only generic. So what have you done with your experience over these days? Are you going to experience again? Are you going to experiment on the patients so that you will know as to what is happening to this particular generic drug? Are the courts pushing us towards that end? Number two, what happens to those drugs with multiple ingredients? Let us say that there is a B complex where you have 10 different ingredients. Instead of writing B complex, should you have to write all the 10 ingredients along with the quantity of that? Then what about the cost? Most of the times it is said that the generic is to be promoted for the sake of cost. But if that is true, why the cost of the different generic drugs is different? Why the government is not able to fix a particular rate to generic drug of all those which are available on a particular name? And will proponents use it? All those people who cry for writing generic drugs, will they really use the generic drugs if they are prescribed the generic drugs, or will they go for the commercial preparations? And lastly, if that is so, why not a legislation come out that no person can use a drug which is other than a generic formula? That means there is something fishy about this. And another one is you have to write capital letters in all these prescriptions is something what has been said. Is it really practical? If you are giving some 10 different drugs in a particular prescription, is it practical to give a prescription in capital letters for all the 10 drugs? Did anybody ask you whether it is practical or not before passing on the judgment? Here is an example. You can see here how well that we follow the quality here. Here is a cough syrup, the ingredient being povidone, supplied by the government, supposed to be given to the patients who are suffering from cough, but the ingredient is written very clearly that it is a povidone. And here are the tablets, dicyclomine, which contains dexamethasone. So whatever has been said outside does not contain what inside. So this is the way of quality that we are maintaining in our country. And do we really have to go with the generics under these circumstances? Legibility is something which needs to be understood. I think this is the point where we cannot go back. This is something we all have to accept. So if you are not legible, perhaps we have to take lessons like this. Here I'm putting forward a prescription given by a super specialist. You can see the top part of the prescription here, very legibly written because it was written by a receptionist. But when it comes to the doctor, this is how the prescription is. If such prescriptions go into the hands of the judiciary or to the higher authorities, what face do we have when we are dealing to counter that? Coming to the advertisement, a lot has been said in the MCI document with regards to the advertisement. So ambiguous it is. So the difference between the creating awareness and advertising is very thin. The margin is very thin. The line is gray. So we will have to understand that what is there to create awareness and how do you advertise. Do we have to really advertise? Are you allowed to advertise? They have given a lot of inputs into when should we advertise, how much should we advertise. But what needs to be understood is media. With the media exploding these days, what media can be used, what cannot be used. Very little has been said on that. The size, how big should be a particular advertisement board or a board which creates awareness amongst people, and how ethical it is to write. For the first time it has been done, for the highest number of cases that have been done, the best of the cases that has been done, and he is the only surgeon who does this. So here are certain problems that we should have certain introspection, that you see all these words in day-to-day practice. The junior most trying to tell the senior most that he is the first one to do that, though it has been done earlier. And he would be saying that he has done the highest number, though that number has been surpassed many times by many people earlier. So this is giving a false notion and the false indication to the individuals. So here we have to have a soul searching to understand what needs to be done. Then coming to the soliciting of the patients by advertising, either directly or indirectly is not allowed. And an individual physician group or an organization or institution are not supposed to do that. This is basically a self-aggrandizement, as you all know. So your professional skill, qualifications, specialties, achievements, attainments, all that are advertised. And the people who have more money will do the more advertisement. People who are really worthy may not be able to do so much. So ultimately it becomes something like misguiding the common public, thereby defeating the whole purpose of the medical profession. Certain norms have been laid down in the medical council document again on when you are supposed to do advertisement, like on starting of the practice, on changing the type of practice, on changing the address, or on temporary absence from duty, or resumption into another practice, or succeeding another practice, or public declaration of charges. Charges can always be advertised, but at the same time, there is a loophole here. The moment you are changing 5 rupees of your charge, reducing or increasing, you can have a full page advertisement, which basically gives you an opinion that a lot of good is being done to the public. And similarly, MCA also said in chapter 7.11 that one should not contribute articles to the lay press. And on the other hand, they said that you can write to the lay press under your name on the matters of public health or hygiene living. These two are very contradictory. So that is the reason why a lot of discussion has to take place, and this air has to be cleared on this so that people can practice properly. And giving interviews with regarding to the disease or treatment is something which is forbidden as far as the medical council is concerned. And at the same time, it says that you can give radio, TV, internet chat, and send announcements to the lay public on your talk in a TV or the radio. These again are contradictory. So these are the areas which need to be addressed. These are the areas which need to be thought of when we are dealing with the advertisement. Certain institutions which are particularly, when we say these days, the corporate sector usually make a lot of advertisements, but the particular purpose, advertisement with a particular purpose, like whether that particular facility is a maternity home or a nursing home, can always be done. And it should not be more than the name of the institution, types of the patients admitted, type of the training. But as you see that there is an interlude in many of the serials these days where advertisements, regular commercial advertisements are taking place, which are far from what is expected by the normal individuals. Similarly, signboards. You can see nowadays the signboards are seen on top of the trees, on the top of the electrical poles also. But this is quite a deviation from the Medical Council guidelines. So they said it should not be unusually large signboard. What is unusual is something that needs to be answered here. And one should not write anything other than the name and qualifications and the title. And whatever that you have on a prescription pad only has to go onto the board. That's what the Medical Council says. But how many of us are following that? And it is not proper to fix our signboard on the chemist shop or places where the individual do not reside. But you can see the boards at the street ends. You can see hundreds of the boards along the national highway of some of the facilities and some of the doctors. How far are we justified in doing that is a matter that needs to be understood, that needs to be an introspection. So any form or any matter of advertising through any of the mode, like the boasting of the cases, operations, or cures or remedy. I have found out this particular cure and all, it should not be done by anybody. And one cannot publish a report without a peer review. That has to be understood. But even before it is peer reviewed, you know that it is coming up in the lay press these days. And printing of the self photograph of an individual on the letterhead is forbidden by the Medical Council, or on the signboard outside his clinic also it is not allowed. But at the same time, you can have the sketch of the particular system, like for example, a kidneys and urinary bladder by a urologist or a gastrointestinal system. A sketch is always allowed as per the MCI. In conclusion, I wish to tell you that we have to understand that we have crossed the stage of service to the business. So we have to have a realistic approach into how much we can advertise, how to prescribe, and we have to follow the good prescription practices. Though some of the prescription practices that have enumerated, that are laid down in the popular documents need a lot more discussion. Perhaps the National IMA should come out with a better document than what it has done in 2021, as I have gone through that very scrupulously. And regarding the advertisement, it should be neither too low so that we will not be able to tell the people or give an awareness, nor it is too high, like what we see in the interlude of many of the serials where there is a lot of advertisement. So moderation is the key. It should be via media, and certain guidelines need to be framed to that extent. And ultimately, it's the guidelines which need to be changed over a period of time. I'm sure that the IMA AP state and the IMA National IMA will come forward to address all these issues and come out with a document in order to reduce the litigation in terms of the doctors who are facing it, or at the same time to have a better public perception of what we are doing and have a peaceful practice by all of us. Thank you very much for this wonderful opportunity. Thanks for your patient hearing.
Thank you, Dr. Sudhakar Garu. You got a wonderful speech. That too, on the floor of the IMA. You give an excellent speech. You need this type of lectures in IMA, and IMA committed for the medical ethics. Very clearly, we narrated about all these things. If any questions, please ask with him. Dr. Sudhakar is ready. Any questions? Any clarifications? Okay, but IMA wonderfully diagnosed Sudhakar Garu, excellent speech. We can, as a past president of the Indian Medical Association, I'm from the bottom heart of appreciating for presenting this lecture. Thank you very much.
Sir, thank you very much, sir, for an excellent oration. Gurumurthy Memorial Association oration, sir. Just for the information of the kind audience, the orations are not supposed to be questioned. So any discussion could be taken up later. Oration is not for discussion or bilateral talks. That is the honor we are giving the speaker. So I'd like to thank Dr. Sudhakar Garu, and I invite Dr. Subramanian Garu, President IMA, to give a shawl and a token of appreciation to Dr. Sudhakar Garu for his oration.
Thank you. It gives me a great pleasure for this state IMA AP state oration, Dr. Gurumurthy Memorial Oration. As I think I already told about Dr. Gurumurthy, a product of West Godavari district, but he studied in Andhra Medical College, Visakhapatnam. Because of that, we conducted Gurumurthy Memorial Oration in Visakhapatnam several times. When I was the secretary and president also, maybe some dozens of times we organized Gurumurthy Oration. But because of separation of the state and then these orations could not be fulfilled. So for some time, for the last so many years, it was not conducted. But once I took over as the president, we again reorganized this thing. I formed the orations committee, and they recommended all the 3 orations will be done in the state conference time. And so today we are organizing this thing. And for this, I am very happy. One of the distinguished person, my own student and a very eminent speaker and a plastic surgeon and an administrator, whatnot. In the COVID time, whole of Andhra state, the government of Andhra Pradesh also recognized service as a COVID coordinator and officer. And then I am very happy to present this memento on behalf of the IMA AP state to Dr. Sudhakar.
Thank you. Thank you, sir. Sir, please be on stage, sir. Sir, both of you, sir, please be on stage. So I invite Dr. Kanumuri Ramesh Garu, Professor of Urology, Ashram Hospital, also onto the dais for being moderating this session. So the next session would be on by Dr. Subramanian Garu from Tirupati, sir. Erectile dysfunction. Sir, please come onto the dais and laptop better.
Delegates, a small announcement. The next, after this, there will be another oration which will be followed by the inaugural function. Request all the members to stay back till the inaugural function over. And most importantly, today's evening's banquet, the venue was printed as cues and balls, but it has been changed. Kindly spread the message. It is in Sukibhava Kalyana Mandapam, Chintalpudi Road. You can easily locate it on Google Maps. Please tell your friends, whomever you are in touch with. The venue is not the one which is printed on your badges. It has been changed to Sukibhava Kalyana Mandapam, Chintalpudi Road. Thank you.
Good evening, everyone. I'm very happy to welcome Dr. Subramaniam, who's a noted urologist in Tirupati. He has done MBBS, MS, MCH from Jipmer Pondicherry. He has his own hospital known as Rush Hospital. He's been a professor and a head of department in Tirupati Medical College. He was ex-state president of IMA, ex-state president of APNA, ex-member of NTRUHS, ex-EC member of Medical Council, and an international member in American Urology Society. So I welcome Dr. Subramaniam to give his address on erectile dysfunction. Thank you.
Thank you, sir. Respected chairperson, co-chairperson, and Guru Garu Samaram Garu. He is really in the field of sexology. He brought the wonderful changes. He saved so many families. Really, Pranamal sir. Today's my topic is sexual dysfunction. 4 decades back, when we were the student preparing for the PG exam, most common cause of erectile dysfunction was psychogenic. This was the answer. Now, the most common cause of erectile dysfunction is organic, 90%. Now we are able to evaluate. Now with this science, andrology, there is an ocean of change in that. Now we have awareness what is the etiology and diagnosis and giving therapy. Now at least 90% of cases we are able to give good treatment and solve the problem today. That is the present status. Sexual dysfunction unable to get proper erection and maintain proper erection to perform satisfactory intercourse. There are many, this is a syndrome almost. We have many other types. One is premature ejaculation, retarded ejaculation, or anorgasm, no ejaculation. These are the common types. Patient comes with these complaints. And loss of libido is another thing. The most common physiological sexual disorder for the male population. Sexual dysfunction, we estimate people from 40 to 70 years, almost 40-45% of men or women having this problem. It's not a rare. And it increases the age, proportion to the age. And woman sexual dysfunction, not given much importance, but now patients are coming forward and getting treated. Risk factors are like angina or myocardial infarction, like cardiovascular diseases, diabetes mellitus, hyperlipidemia. Earlier, alternate diabetics used to have this erectile dysfunction, minor or major. Now, nearly 75% of diabetic patients are coming having the mild or moderate or severe erectile dysfunction today. Etiology, again, the multifactorial, organic, hormonal, anatomical, drugs. There are many drugs for psychiatric problems and hypertension. These are having some effect and causing erectile dysfunction. Psychogenic, already mentioned, 10% of the cases psychogenic, pure. The organic causes, it may be vascular, CVD, atherosclerosis, hypertension, hyperlipidemia, and smoking. Central causes includes Parkinsonism, stroke, or multiple sclerosis, tumors, spinal disease, or injury. Peripheral cause, peripheral neuropathy, diabetes, alcoholism, uremia, and pelvic surgery. Any pelvic surgery, pelvic radiation leads to nerve damage, leading to erectile dysfunction. alcoholism. Liver metabolism is altered. So tests on metabolism, so it leads to erectile dysfunction. Diabetics, multifactorial. Neuropathy, sugar, more sugars, and arterial involvement. Everything is multifactorial. It leads to the most common cause nowadays. Hormonal cause, not much common, is rare actually. But we can see these secondary sexual characters, much other things, or some thyroid or hyperprolactinemia or Cushing disease, hypogonadism, secondary sexual characters absent. Even after 40-50 years, we have to see the size of the prostate. Size of the prostate is a good clue that patient androgenically is good, because it shows depends on the prostate growth depends on the testosterone levels. These are the good signs. 40-50 do PR also to know the testosterone level. Peyronie's disease. This is a nasty disease, more than 300 years, no correct treatment. That is, they will have plaque in the corpora, and corpora cavernosa becomes fibrotic. It won't expand. It causes pain on erection and curvature. The Peyronie's disease, this leads to problem. Micropenis, anomalies, maybe hypospadias, epispadias, any lesions, performance failure. This is very important because today nowadays we're actually using number of medicine. Beta blockers, tricyclic SRIs, phenothiazines, phenantine, carbamazepine, antihistaminics, is ulcer drugs, Semtidine and ranitidine, recreational drugs like tobacco, alcohol, marijuana, other drugs. These have to change according to, suppose cardiac drugs, you have to consult with the cardiologist. You have to change the drugs to not having any effect on the brain or blood pressure or locally. Psychogenic, already mentioned, it requires psychologist evaluation, result of intimacy, lack of arousability, situational, partner change, it improves, depends on the partner. Performance anxiety, psychiatric illness, anxiety state, depression state, psychosis, alcoholism. All lead to different levels of erectile dysfunction. History is very important, it gives a good clue. Mostly the two entities. One is organic erectile dysfunction or psychological erectile dysfunction. This detailed history is very important. Cardiac gradual onset, suppose patient getting 6 months, it is organic. Patient having within after some upset in the house, or it's only 1 week or 10 days, 15 days, is psychological, maybe. Normal ejaculation, that shows psychogenic. Normal libido. Medical risk factors include trauma, surgery, and other pelvis. Current radiation or modification of things. Lifestyle is also very important. Smoking, drinking, no obesity, not having proper physical exercise to the body, all leads to organic. This history suggesting psychogenic is very important. Even history you can get. They will say every male patient, they will have 3 types of erections. One is central, second one is contact, local. Third one is REM sleep phase. You're getting nocturnal erections. Every male will have every night 3 to 4 erections in REM sleep period. But we can evaluate. Even patients say, sir, I have early morning erections, otherwise I'm not able to perform. Early morning erections is very important. Say it is a psychological. Okay. Number 2, we can assess. Simple methods are available. How to assess? We have sleep labs. We have Regiscan to record this. And then sometimes we can have even postal stamps strip. We can attach to the pennies. It broken in the night means it was enlarged. Night enlarged, how much enlarged? There are different methods to diagnose. Nocturnal erections. Nocturnal erections is a sign of psychogenic disease. The sudden onset is psychogenic, early collapse of erection, self-stimulated waking erections, premature ejaculation, major life event, psychological problems. Examination, after detailed history, exam is very important. Genitourinary examination is anatomical abnormality, size of the testis, to hormone levels, testosterone, pulse, is there any pulse difference? That helps decrease blood flow to the area, coarctation, aorta. Rectal examination over 50 is very, gives how the androgenic status of the male, very important. Investigations, you can do battery of tests. That's one approach. But now, you can give one tablet of Viagra or sildenafil. Patient has a normal erection, is able to maintain, sustain, you continue that treatment. That won't require much investigations. Suppose patient not respond to CIS, that is Viagra challenge test, so requires investigation like sugar, energy important, lipids, LFT, TSH, serum testosterone, urine test, vascular studies, how is the venous leak or blood flow, arterial flow, neurological studies, psychodiagnostic evaluation. Management, now first thing is patients not taking the proper doctor, that's the main thing. They're getting into TR with us, they're getting implant of some other urologist. Why? Because they don't know that. Not much discussed. Only thing, the senior sexual like Samaram sir, he creating a lot of awareness that really solving the problems. That is why they're coming to urologist also patient. And the main goal is to treat the cause. What is the cause? What is the cause? We have to analyze, evaluate, and confirm and treat it. And lifestyle diseases, because daily exercises, that improves nearly more than 10 to 20% normal erections in obese patients. Smoking, drinking, stress will have to be reduced. And testosterone estimation is low because male menopause. Now after 40 to 50 years, testosterone is going down. Male menopause. You have to estimate. It's available almost every center. It's low, they got to give, but it's somewhat rare. It's not that common hormonal causes. You can replace testosterone. But to give testosterone, normal patient gets feedback inhibition and leads to other problems, including gynecomastia. Post-traumatic arteriogenic thing, we do if the vessel is big, we can do vascular surgery, anastomosis, to inferior epigastric to dorsal penile artery or a deep vein. Sarcogenic will hand out cycle, analyze and treat. But any type of psychological, neurological, or anything, the first line of treatment is oral drugs, that is sildenafil. The wonder drug of the century, Viagra. You need not invest in every patient, and it is a waste of money. First line treatment is oral therapy. Oral therapy, you have PD inhibitors, sildenafil. Second line, vacuum constant device, the intraurethral prostaglandin, that means mucosal absorption by putting prostaglandin into the urethral mucosa, it absorbs and produces erection. Third line, intracavernous injections, pepperine or pentolamine combinations. Fourth line, penile process, now become very affordable to the patient. Earlier, the instrument cost up to 50,000 to 1 lakh. Now it is 15,000-16,000 we are getting from Bombay, Shast prostate. Around 50,000 we can make patient sexually active. It's very affordable now, not a rare thing to the patient. PDS inhibitors, sildenafil, tadalafil. Tadalafil have more half-life, 36 hours nearly. Pentolamine and yohimbine, central acting drugs. Apomorphine, melanocortin receptor agonist, melanocortin, serotonin receptors, trazodone. But still, people feel sildenafil and tadalafil is the best. They have good result, reproductive result. Other things, varying results, not that reproducible. Oral therapy, PD5 inhibitors, improve relaxation of the smooth muscle, increasing cyclic GMP of the vascular wall. Is well tolerated, efficacy reduces up for fatty food. Starting dose 50 milligrams up to 100 milligrams you can do. Tadalafil longer half-life, already mentioned. Vardenafil more potent. The contraindicated patients receiving nitrates, recent stroke, MI, unstable angina, and arrhythmias also it's contraindicated. If any cardiac problem, better to have a show to your prescription to cardiologist, then better to alter if any doubt. Otherwise, a very safe drug, but I think we need not worry. Pentolamine is alpha-1 and alpha-2 receptors produce corporal smooth relaxation by blocking the postsynaptic alpha-1 receptors. Yohimbine is central active drug. Apomorphine is also available on the market. The central active drug, the dopamine receptor. The second line treatment is a vacuum device. It's a simple device. There is a cylinder that kept around the penis. Is connected to the pump or a manual pulling the air out of the peripenile place. So vacuum was created. That vacuum pulls the blood into the penis. So the younger is then small loop that is on rubber band will be pushed into the base of the penis. So the younger penis, it remains there like that. So it is, some people they are very happy with this. Clinical success rate around 90%. But it requires partner cooperation, good management, good minimum knowledge. But it gives some people very good. It requires good motivation, support, partner support is very important. Sometimes pain, you will be always targeting a rubber band, something holding there. Some bruising, some numbness, just minor things. Is available, is manually could be managed or even mechanical, machine also available that produce vacuum. Intraurethral drugs, prostaglandin E1. This is also gives very good research. Just to have to pellet is pushed into the urethra, getting absorbed and produce very good result. This also, but little costly. This absorbs the mucosa into surrounding carpet and produce local action. But the best result, always patient asks for a intracavernous injection. This gives a good stiffness compared to tablets. The patient, many people are asking for the intracavernous injection. That is intracavernous injections. This also will teach the patient self-injection or the corona, that corpora midline to 3 o'clock in between to avoid the urethra or dorsal vessels. So insulin syringe will be injecting to the corpora. Will teach the patient, they themselves practice. It gives very good rigidity. This papaverine and alprostadil are the main drugs used for this thing. Side effects very important, priapism. Many people, they'll come with prolonged erection more than 3-4 hours. But even if our staff are trained in this, immediately the OP staff, they will wash the corpora with saline, or they will not respond, then we'll go for a fistula creating corpora to glands. We'll put true cut biopsy needle or 11 number blade, push through the glands into the corpora. The channels are opened, so it will come down. Anything patient have to give instruction. If not coming down, D-tumor is not there after 4 to 5 hours, you have to report immediately. That's the only problem with this. And continues to produce some corporal fibrous. The ultimate final course is implants. Implants is 1 piece, 2 piece, 3 piece. One is malleable, flexible. Other one is that is pumps. It is even diabetics, 50% up to diabetes, they'll respond to the oral drugs or intracavernous injection. But the final answer is this gives up to 98% of couple satisfaction. Stiffness is guaranteed. But only in diabetic, they will have to take all the precautions of putting the patient, the first case in the OT, avoiding sugar control, other things. But this is a silicone rods, flexible silicone rod, we'll be putting into a small incision in the root of the penis. Here we'll give small incision. We'll drill the corpora completely with Hagar's dilators. We'll measure tip to up to this point of this attachment. We will trim the silicone rods. 2 rods will be kept. This is silicone rod. Malleable, we can flex it. We'll put it. This is a rigidity is guaranteed. Only thing is we have to scare all the precautions like surgery in the diabetics. Most of people are diabetics. This 1 piece is cheaper, but the second one, this is 2 piece and 3 piece. These patients are very happy with this. This is pump. Here is the reservoir. Once the partner or himself presses the pump, the fluid from reservoir go to the corpora and erection. After that, they want erection, then press the pump, again they drain into the pump. These are more complicated. So failure rates generally up to 10 to 11 years, no problem, many cases. But after that, this break sometime. The failures are more with the 2-piece, 3-piece inflatable process. This is very cheap, very cheaper. Patient can satisfy his partner. That problem is definitely they are very happy with this single this thing. But we want more natural, but cost difference are there. Nearly 1 lakh rupee difference for this to that. That also there. Anyhow, now no place for divers and all with this problem. But patient generally there will be a lot of galata, and finally the girl will be in their mother's house. That's the situation, they will come to us. But at the end, they won't break up. They ask, is he having erection? Normal. We have to do Regiscan. Regiscan, that is sleep like whole night recordings. But Regiscan we won't do for treatment purpose. but legal purpose I produce this scan. It is available in cities, availabilities. And anyhow, these are the present status of the treatment. Anyhow, much more physiological and much more effective treatment may be further stem cells and genotherapy and genetic therapy may be in future correct physiological treatment for these problems. Anyhow, I thank the organizers and chairman, co-chairman. Thank you, sir, for presentation hearing. Thank you, sir. Jai Hind.
Thank you, sir, for such a educative lecture. Thanks for the media that more and more men are coming in the open for their sexual dysfunction. So in the OPD, you encounter a lot of cases of erectile dysfunction, and then thanks for highlighting that most of the cases can be cured after thorough investigations. The session is open for discussion. Sir, would you like to add some words? Sir, yourself. Thank you, sir.
Thank you, sir, Dr. Subramanian sir, for your excellent lecture on erectile dysfunction, the causes, and elaborating all the treatment also. So kindly accept a memento on behalf of the organizing committee. I request Dr. Sudhakar sir, kindly memento. Sir. Sir, come out. Sir, kindly have a photograph. Thank you, sir. Sir, Oresh, next to that, sir. Sir, kindly stay back, sir, for the oration. I've been last. Sir, kindly stay back, sir, for the oration. Thank you, sir. So now today's last academic program, it's an IMA memorial lecture in the name of Dr. Peri Shastri Garu. And today it's a privilege to invite Dr. Shankar Magadayan Garu for the Peri Shastri oration. And also another coincidence and a privilege is, I'll chair, please. Chair, one request, one chair. So I'd like to invite Dr. P.S. Sharma Garu. He is the grandson of Peri Shastri, who is and in whose memory the present oration is being done. So a coincidence, he is here. So we'd like to invite him also as a special guest. The grandson of Dr. Peri Shastri Garu. P.S. Sharma Garu is an active IMA member from Amalapuram.
Slideshow.
Good evening, friends. So today's the last topic. I hope you have some more energy for 25 minutes of
1 second, Shankar. Good evening, all. It's great privilege to introduce Dr. Shankar Mahadev, one of our batchmate. He did his MBBS from Rangaraya Medical College, 1975 and 81. Then he did his MD radiology from I think Hyderabad, Osmania General Hospital. Now he worked as professor of nuclear medicine, MNJ Cancer Hospital. Then after split, he shifted to Visakhapatnam. Now he is retired from his services and practicing at Gunturu, various specialty hospitals, American Oncology Hospital, Omega Hospital and all. Rangarayan product.
Thank you for your nice introduction, sir. So all of you are aware that as some Swamijis say, what are we? We are nothing but a speck in this universe or a drop in an ocean. So when you see so many people coming in as doctors also, there are very few people who make a mark. And that mark, you can say, is one of the, is Dr. A. Peri Sastry Garu. So born in Bobbili, he has led 75 glorious years. And after that, 50 are very active. He's the first batch student of Andhra Medical College, Vizag, and has also practiced from 30 to, I think, nearly 48 to 50 years, he practiced actively. And one more thing is, he became a state IMA president. He shows his willingness to serve the doctors. And he toured at, I think at age 70, he toured all the local branches in the entire state of Andhra Pradesh. And also, he's showing his willpower from 50 to 55 years to 75 years till he died. He walked 3 miles morning and evening without fail, it seems, except for the last 1 month. So it shows his willpower. And also, the greatest thing which I can say is he is a member of the medical board that has started in Kakinada, which led to start with Rangaraya Medical College and which led to thousands of doctors coming out successfully. And I am one of them. And also, that vision, you can say, has led many of us to be what we are today because of Rangaraya, a glorious Rangaraya Medical College. We are proud of that college. Anywhere you say we are proud of Rangaraya Medical College. And the last is, but not the least, he has donated his body along with Dr. Harlan to the Rangaraya Medical College Museum, where you can go and see the skeleton. Thank you very much for your patient hearing and your ovation to the doctor. So I will be, nuclear medicine is a relatively new topic, and I'll try to breeze through it. You have to, I think, you have to follow it, because I have to tell the entire specialty within 25 minutes or 30 minutes. So I'll try to cover it very fast. It's a new specialty. I mean, relatively in Andhra Pradesh, the divided Andhra Pradesh, but in Hyderabad, it's since 30 years. So in this new specialty, because the specialty is not everywhere, that's the problem. That's why many doctors are also not aware. I will try to cover the entire nuclear medicine in 25 minutes, which is a clinical specialty. So I will try to cover this on 4 headings. One, the basics of nuclear medicine. Next is the diagnostic part. You have the gamma camera, where we study the function of any organ. Then the PET CT, which you are all aware. PET MRI, already few machines are there in India. And also the therapy, which many of you are not aware. So coming on to the basics, it is a specialty which has progressed dramatically, like all other medical specialties in the last 30-40 years. It is relatively a new specialty, like it started in 1940s. So, and what is this main is, it is a specialty where we use radioisotopes for diagnosis as well as therapy. So a little bit of physics, you know the structure of atom. You have protons and neutrons in the nucleus and orbiting electrons. So in this orbiting electrons, so the atomic number is, the number of protons is the atomic number. When you say isotopes, you have more number of neutrons compared to protons. Those are called isotopes. And some of these isotopes, naturally occurring isotopes, are stable, because these isotopes are produced since the starting of the solar system millions of years ago. Most of these naturally occurring are stable, while man-made isotopes are not stable. So when these are unstable, they try to attain stability by releasing some of the energy, either by some waves or by some particles. So it releases energy either by gamma rays or by some beta radiation or by some alpha particles. So you have 3 rays which you have to, before I start the clinical aspect, either in radiotherapy, nuclear medicine or radiology, you have these 3 rays. So when Röntgen discovered X-rays in 1895 in Germany, 3 specialties were born. And out of this, radiotherapy and radiology started immediately within 1 year. But nuclear medicine started only in 1940. So we have alpha rays, beta rays, gamma rays, as well as neutrons. Alpha rays cannot penetrate skin, so it cannot be used for radiotherapy. Beta rays can penetrate only a few millimeters in the skin. It also cannot be used for radiotherapy or for radiology. And only gamma rays and X-rays can penetrate through the human being. So these are used for diagnosis as well as radiotherapy for treatment of cancer. It's only the difference in energies. So alpha rays, beta rays cannot penetrate. So what we use in nuclear medicine, we inject into the body. it goes to near where the cancer cell is or where the disease cell is there, and it gives this excessive energy into the cell. So what I want to use for, suppose I have a cancer patient, what I want to use? I want to use alpha rays, I want to use beta rays. So depending on the cancer size, cancer depth, I use these different types of alpha rays. It cannot penetrate skin, but it can penetrate 10 cell diameters. That is around 50 to 90 microns. So I can treat some of the cancers in nuclear medicine by giving alpha emitters. So beta, you have less than 200 micrometers, 200 to 1 millimeter, or more than 1 millimeter. So depending on the type of cancer, I use different isotopes to kill these cancer cells. So basic of nuclear medicine, you can say, you got one radioisotope, one side, where it is giving continuously radiation. I cannot switch off. 24 till it dies, isotope, it gives continuously radiation. So for each element, there is some half-life. So that half-life is, it might be 5 years, few seconds, or it might be 16 to 2000, 3000 lakhs of years. It becomes half of its original value if it reaches that half-life. So this technetium isotope is the one which you use in gamma ray nuclear medicine. Most of the scans, when we say the bone scan, thyroid scan, cardiac, everything, in a gamma camera, we use technetium isotope because it got a 140 keV, very low range, and it doesn't have any beta radiation, it doesn't harm us. That's why it's a pure gamma ray emitter. It's used for diagnosis. But this isotope cannot go to all the organs. So what I do is, I attach a pharmaceutical to take this isotope to the concerned organ. Suppose I want to study the liver, I attach a different ligand. So to take this isotope to the concerned organ, I attach a pharmaceutical. This is called radiopharmaceutical. Similarly, I can attach for a cancer cell, for localization, for a target protein, I can attach a targeting molecule. So when you say a precision medicine, targeted therapy, or a magic bullet, this is the concept. So when you say the basic thing is production of radionuclide, either in the reactors or in the linear accelerators or in the cyclotrons. We produce, we get it daily, we import or we get it from the Bioatomic Research Center. Then the ligands there readily we have in the freeze. Depending on the patient, the study we want to do, we attach in the lab, then we inject into the patient, we give in the orally or in the gaseous form. Then we give to the patient, we wait for some time for it to be distributed, then we study. So what is the main difference between, you can say, radiology and nuclear medicine? Radiology, we send either X-rays from outside, goes through our body and have an image on the imaging instrument. While nuclear medicine, we can't have that. We inject into the patient. Tracer is, the nuclear radioisotope is distributed throughout the body, and rays is coming completely out of the body. And these are scanned by an imaging instrument. Practically every organ can be, we can know the function of the organ. So what are the main advantages when you compare it with other radiology? It is functional. It is functional, it is functional. That is the main advantage. The specialty is there because we give the function of any organ. It is safe, no side effects. Patient don't die because we have given a contrast. Patient doesn't tolerate good, doesn't go into shock. The minimum thing is you may get some itching, that's all. It is non-invasive. And you can quantitate the function. I can say, okay, this kidney is functioning 20%, 30%, 50%. I can quantitate any organ, the amount of the function is, the organ is functioning with. It's extremely sensitive, more sensitive than X-rays and CT scans. And it gives very less radiation dose. So when we started as PG, it was a rectilinear scanner, the first one. 1980s, we had at MNJ Institute of Oncology, RCC, Hyderabad. When we were PGs, we used to have a dot picture on the paper. Then we had a ECL gamma camera donated in 1990, 2000. We are using that. Now we have a dual head gamma camera, which we bought. Then recently, since 1 year, we got a PET scan donated from the central government at MNJ Institute of Oncology. So the basic is patient is there injected with the radioisotope. It is continuously giving out the rays. These rays fall on a sodium iodide crystal. Their light is produced. This light is magnified. With the help of computers, we get an image. That is a simple thing. And thus, when this gamma camera rotates around the patient, we get a three-dimensional distribution like in a CT scan. So these are the isotopes which we get. Either we import or we get a generator which we produce every day in our lab. These are the different vendors, different equipment, PET CTs, PET MRIs, gamma camera, etc. So coming on to the functional gamma camera diagnosis, nuclear medicine started with a tweaking of the iodine isotope, preparing the iodine isotope and producing iodine 130, which is experimented in rabbits. Then they went to humans and started with an iodine 130 first image, then started therapy with an iodine 131 in 1940-41. So when you say anybody, if you say it's a thyroid scan, it is technetium isotope only. We use iodine 131 because of the beta radiation, and it may cause harm to the patients. We use it only for cancer thyroid, not for benign cases. For benign cases, we use technetium isotope. And when you want to use ideal iodine isotope is iodine 123, but that is not available in India. That's why we use a technetium isotope and iodine 131 isotopes for cancer thyroid patients. So how do you diagnose? Patient comes with a nodule in your OP. What do? You do T3, T4, TSH. Then next step is you advise an ultrasound scan. Well, you know how it is functioning, but you don't know whether it's adenoma or it's a malignancy, or it's maybe a multinodular toxic goiter, multinodular goiter, a benign nodule. So a cold nodule where it's not functioning, it might be an adenoma or a malignancy, which we advise FNAC. Or a completely hyperfunctioning thyroid, where a pyramidal lobe also is active. It's a hyperthyroid or Graves' disease. Or a multinodular toxic goiter, where patches of non-functioning or hyperfunctioning gland is there. Or a single hyperfunctioning hot nodule. Or it will become autonomous and suppressing the rest of the thyroid gland. Or a thyroiditis. It has the symptoms of hyperthyroid, but there is no uptake. So it's have a benign treatment. A patient, young patient, which has come to our OP with hyperthyroid symptoms. You have the investigations also like hyperthyroid. So we do a scan after the ultrasound. Then you see that the flow is not that much. It's minimal to moderate. There is absolutely no uptake in the thyroid gland. So this is to differentiate hyperthyroid Graves' disease from a thyroiditis, where we treat only medically. This is the investigation of choice. So any patient comes, many the patients, kids come with a nodule in the neck. So the dictum, I think all of you know, don't put a knife in a nodule in the neck unless you know where the thyroid is there. This is an ectopic thyroid. So many of these patients comes. So, and we just see the thyroid scans of ultrasound, then we diagnose, and then we refer back to the endocrinologist or whoever is seeing that patient. Our patient may come with hyperthyroidism. So how to differentiate? So when you suspect hyperthyroidism, even after CT, MRI also, you have a doubt whether it is there or not. We do a technetium sestamibi scan. In this sestamibi scan, the tracer goes both to thyroid and the parathyroid. But after 2 hours, you see that the tracer washes out of thyroid and it's only there in the parathyroid adenoma. It's very elegant, the nuclear medicine. This is a salivary gland scintigraphy. It's not, we don't put pressure or we don't do. We just give a small IV injection, it goes the parotids and salivary glands. We want to know if they're functioning, infection, inflammation, obstruction, Sjogren's syndrome. We want to know. So we just inject, then after 20 minutes, we put some lemon drops in the mouth. We see whether there is an immediate excretion from the salivary glands. The next is lacrimal gland scintigraphy or dacryoscintigraphy. Here we put just a drop of tracer into the eye. We see whether there is an obstruction from the lacrimal gland into the, from the nasolacrimal duct into the nose. The drainage is good. There is an obstruction and epiphora is there or not. Or you want to know the lymphatic channel, any lymphedema is there, any lymphatic channels obstruction, lymph nodes are there, or some congenital problems, we just put some small injections into the web space. We can do a lymphatic channels and lymphatic drain in the lower limbs, upper limbs, axilla, anywhere. Similarly, I want to know the deep vein thrombosis. We just put, of course, some of the cases you can do ultrasound also. It's comparable. We just inject into the cannulate the veins in the lower limb or upper limb where you want to study, and just we push the tracer. Beautifully, you see whether there is any obstruction or not. In a dialysis patient, we just put the one or two drops into the dialytic fluid and put into the abdomen. We'll see if there is any spillage into the lungs or not after 1 to 2 hours. Similarly, you can put the CSF into the tracer into the CSF, do a lumbar puncture. As it goes into the CSF, we know there is any normal pressure hydrocephalus, or patient has any hypotension, or there is an injury and there is a leak of CSF. We'll know all these things. Similarly, nowadays, the cancer breast, they are doing all mastectomies, etc. But this concept of doing a sentinel node imaging, already they're doing in Hyderabad, not in AP. So in this sentinel node imaging, you just inject the tracer around the tumor in the breast that goes to the lymph nodes. You dissect the lymph nodes, patient is on the table, then you dissect and say whether the lymph nodes are involved or not. If the lymph nodes are involved, you do a classical radical mastectomy or modified radical Pattis mastectomy. If it is not involved, there's no need for that. You can just do a simple mastectomy, thereby preventing future lymphedema for some of these patients, around 10 to 15% of the patients. Coming on to the bone scan, where most of the nuclear medicine department's workload is. Patient comes with pain. You don't know it's because of the bone pain, soft tissue pain, muscle pain. You're an athlete, you're a gymnastic, you're a dancer, you're a tennis player, or you want to go to the gym, actively work, first day itself, 1 hour running and everything, you develop pain next day. So you want to know whether it's a tibial splints or stress fracture, etc. This is a normal bone scan, which you see uniform distribution of the tracer. This is a case of metastasis, multiple dark spots everywhere, a case of metastasis from cancer. Patient you fall from the bathroom or somebody hits you just jokingly, you develop pain in the ribs. So trauma of the ribs, or stress fracture, a normal excessive pressure, it might cause you a stress fracture. After X-ray, bone scan is the investigation you have to do wherever you have that facility. Otherwise, you can go for a CT scan because it's more sensitive for an X-ray or a CT scan also. So our battered baby syndrome, when the patients willfully cause injury to the babies, by the pattern of the injuries, we can say the parents have caused it, battered baby syndrome. Or infections, osteomyelitis. We do a 3-phase bone scan. In all the phases, you see increased tracer uptake, diagnosing as osteomyelitis. Or avascular necrosis. Post-radiotherapy, post-steroid uses, you have a decrease in uptake of tracer. Or active arthritis. So in rheumatoid arthritis, you have uptake of the tracer in all the small and big joints. Then Paget's disease and also osteoid osteoma, the investigation of choice, where you see uptake in 2 layers. Or processes, whether there is loosening or an infection, patient comes with pain. So you can identify that one. Or any cancer, bone cancer, to know the metastasis. Coming into the cardiac, mainly now with the advent of the CT angios, MRI angios. So we have all the instruments. So this is mainly used for diagnosis of coronary artery disease and risk stratification in the intermediate group, as well as the therapy, viability, and also before you go for a ischemia or bypass, you have to go for this study. MUGA is like an echo. Mainly we are using in oncology hospitals to know the cardiac toxicity when you use chemotherapy drugs. But we can use for most of the cases like in MUGA. It's not operator dependent. That's the main advantage. And here we do stress and rest, like in treadmill. You see nicely distribution of the tracer in axial, coronal, sagittal views. You see the distribution nicely in all the distribution on the 3 vessels. And the distribution is normal. Patient doesn't have any ischemia. Patient doesn't have any infarction. Patient is completely normal. Or you have a defect here. You don't have any activity here in stress as well as the rest. That means patient has infarction. That means whether you do any stenting, when they do any bypass, practically it is useless because you are giving oxygen to a dead patient. Similarly, in this, there is a decreased uptake. It is completely normal here. So in this case, there is ischemia. There you can do a stenting, you can do a bypass. It's useful. A ventilation perfusion scan, previously the diagnostic investigation for pulmonary embolism. So you do a ventilation, we can know what is the distribution in the alveoli. Or you can know, you want to know the vascularity in the lung, you can do a perfusion scan. So depending on what you want to, clinically what you want to know, like asthma, some or COVID, whatever you want to know, what is the alveoli remaining, or you want to go for a pneumonectomy, you can do a ventilation scan. Which function in the kidney you want to study. So we can do different isotopes are there. So this is a practically normal renogram. Both the kidneys are showing good normal uptake, transit and excretion. I can quantitate the function here. The graph shows 50-50. Or in a acute infections of pyelonephritis or a renal scarring, I do a DMSA scan. Many babies from the birth, or you can say neonatal hydronephrosis. During pregnancy itself, we say babies' kidneys are hydronephrotic. We follow them after 1.5-2 years, they become normal. Suppose there is an obstruction. So we do a diuretic renogram. So if it is significant obstruction, there is an obstructive pattern, there is no drainage. There is no drainage there. So we advise the surgeons to go ahead and relieve the obstruction. Suppose there is a non-obstructive stasis, immediately after Lassus injection, there is complete drainage. Similarly, in a horseshoe kidneys, whether these are functioning nicely or not. Or renal transplant, instead of going for a biopsy after renal transplant to know what is the pathology. Here is a normal transplant in the right iliac fossa, good uptake, transit and excretion. And we can know either an acute rejection is there, or ATN is there, acute or chronic rejection is there, or a rejection because of the drugs use. So these are the different patterns which, by depending whether the vascularity is good, there is drainage is delayed, we can diagnose instead of going for a biopsy. A continuous, regular follow-up scans are necessary for that. And here is for a vesico-ureteric reflex for the babies. These are simple. I'm not explaining the procedure because there's no time for that. Hepatobiliary scans. So right hypochondric pain, what do you want to know? What is the diagnosis? So immediately you do hepatobiliary scans, nice uptake. Then within 40 minutes, it goes to the cystic duct, hepatic duct, cystic duct, CBD, gallbladder, nicely draining into the small intestine. So these are the diagnostics. Suppose a baby comes, jaundice even after 1 month also. We don't know whether it's an neonatal hepatitis or a biliary atresia. In biliary atresia, if you do surgery within 2 months, baby is alive and he or she can go for a liver transplantation at a future date, saving the baby. You don't diagnose within 3 months, there is a permanent damage, patient is going to die. So neonatal and biliary atresia. Similarly, to differentiate between differential acute cholecystitis, chronic cholecystitis, or in sphincter aorta function also. So within 60 minutes, if you have the gallbladder, it's okay. If it's a more means, then 90 minutes, it's a chronic cholecystitis. Then acalculous cholecystitis or sphincter of aorta function. Here CBD obstruction is there, a delayed scan after fatty meal. Gallbladder is contracting nicely. You have a good gallbladder ejection fraction. GI bleeds. For lower GIT bleeds, this is the investigation of choice. You can give nicely the isotope, you label the red blood cells, you'll see where this bleeding is occur. Our sulfur colloid scan, before the advent of ultrasound, we used to do this sulfur colloid scan to know all the secondaries in the liver. Now we are not doing that much. This is a hemangioma, where initially you have a photopenic area, then the traces slowly accumulate. This is the investigation of choice for hemangiomas. The diagnostic investigation for a bigger ones, for a very small lesions, MRI would be more ideal. This is a choledochal cyst, congenital hepatobiliary cyst, slowly it accumulates. Baby is not growing well. So you just do a simple saliviogram and you will see whether there is a reflex of the tracer into the trachea. Okay, or a Meckel's diverticulum causing pain. You give the tracer, it shows uptake in the ectopic gastric mucosa. So coming on to the brain spect, here mainly for the dementias, epileptic focus localization, and the investigation of choice you can say is brain death. Where you don't see any vascularity, usually you do this and say the patient is brain dead, you can go for organ transplantation. Or epileptic focus localization, whenever the patient is having an attack, you see hypervascularity, you have to go for surgery and remove that part. The patient will be free of these epileptic attacks. And you can, in Parkinsonism, you can compare with the technetium product, or you can compare with the FDG PET scans, the diagnosis is good. Or as cysternography, where is a fracture and a fluid leakage in the temporal lobe. Coming on to the, you can say, CT scan. So most of the investigations say regarding the structure, either CT, MRI. But when you go to the drug distribution, small animal experimentations, molecular pathways, cellular level, you have to go for PET and SPECT only. So CT, MRI gives a structural information, while the PET and SPECT gives a functional information. So nowadays, this is a combined a CT with a PET scan. So getting anatomical information with functional information. So what is the basic? Here the pharmaceutical is fluorodeoxyglucose and the isotope is fluorine. So you combine both this one and it enters the cell, it enters the glycolytic pathway. So the cell recognizes that it is fluorodeoxyglucose. It's not a natural glucose 6-phosphate and traps the fluorodeoxyglucose in the cell. So that's why wherever there is an increase in metabolism, we'll know as it appears as a hotspot. So in oncology, 90% of the work of the PET CT is there and 10% in neurology and cardiology, in diagnosis, in staging, restaging, residual mass, as well as the response monitoring, quantification of metabolism, unknown primaries. You can say oncology, the investigation of choice is PET CT. Don't go for a CT scan, go for a PET CT directly. There's no point in spending the patient's money twice. So whether it is more sensitive than MRI, see the sensitivity of a PET scanner. It can detect between 10 to the power of minus 11 mole to 10 to the power of minus 12, while MRI has sensitivity of only around 10 to the power of minus 3 to 10 to the power of minus 5. So the basic concept is inject into the patient a positron emitter, where your isotopes are more proton rich. These positrons comes out of it, attached with the electron, and then produces 2 photons of 511 keV, 180 degrees to each other. With the help of a coincident imaging, we have image. So many of the patient doctors come to us and say, I thought it's a PET scan, it's going to catch everything. Where is the cancer? So you should not go with advertisements in the TV and everything. Previously, when a PET scan has come in Hyderabad, they used to sell, we can catch one cell in the patient, one cancer cell. That's the biggest hoax, because one cell, lakhs of cells even doesn't make 1 millimeter. So PET scan cannot, because it doesn't have the resolution. So PET CT, what is the limitations? Wherever there is an hyperactivity of the FDG administration, or wherever there is an active tissue repair, inflammation is infection, you have a hotspot. That's why it's not as accurate as in Western countries, because we have more amount of TB. TB catches that. TB picks up the FDG, that's the drawback. So it is the PET-RT planning where early case of cancer lung, we have irradiated completely. This is the before RT and after RT gone. Usually for thyroid, you don't advise PET CT. As any malignancy becomes undifferentiated, PET CT FDG takes up nicely. This is an anaplastic cancer thyroid. One of the most malignant cancers, patient dies within 6 months or 2 years. This is a patient comes with male, 77 years, with pain abdomen. We do a scan. It's a CS stomach. Then we continue. We have uptake in the lymph nodes. Then we continue to uptake in the nasopharynx. This patient presented double malignancy simultaneously. Our case of, we ask the patients for follow-up. These are the patients that see a breast on both the sides. On follow-up, patient developed lung cancer. Then we irradiated, patient is okay. But sometimes you see the FDG uptake does not pick up anything in a neuroendocrine tumor. But gallium scan has picked up nicely. We should know what is the disease, what is the isotope we have to use. Prostate, FDG is not useful, gallium is useful. Here is a FDG scan which is picking up extensively, very intensively the prostate cancer. Usually it doesn't pick like that. So it has a pathological information. Adenocarcinoma, the small cell carcinoma. That's why it picked up nicely. Or a 64-year male patient having abdominal distension, lung involvement, and also the splenic involvement, liver is showing multiple lesions, doesn't pick up. Then we can diagnose of Cox or lymphoma, biopsy is done, it came as Cox. So you should remember the benign tumors also infective lesions. Or nowadays you have all the old age people you're getting with the dementias also, a classical case of Alzheimer's or a frontotemporal dementia. Or this is a case of rare case of the Tourette syndrome where you have tics. Or a hypometabolism in case of temporal lobe epilepsy where we go for surgery. Or a classical case of sarcoidosis where you have a lambda sign. Or a cardiac PET inviability, this is the investigation of choice. So here you show decreased uptake, normal uptake, a classical case of ischemia, where you do a procedure, you're 100%, you're successful. Infarction means no activity anywhere, this is infarction. So normal scan, where you show uniform uptake in all the walls of the heart. Few slides, 5 minutes, sir. MRI, PET MRI, recently it has come in a few centers. So main advantage is MRI is superior to the CT scan because you know the soft tissue contrast is there. Brain it's superior, gynec tumors is superior, prostate is superior. So when you combine this functional imaging with an MRI, you can have you can say investigation. So less radiation dose, that's the main advantage. So PET you can know what are the brains that are simulated when you think, when you listen, when you look, and all the patterns. Sometimes you don't have any uptake like in toxoplasmosis or in lymphoma, you see intense uptake of tracer. So major benefit of PET MRI is reduction of radiation to the babies, to the children, adolescents, and repeated investigations we can do. Nearly 83% reduction in the radiation dose. Next is very beneficial. That's why even the German group has said for lymphomas, go for a PET MRI where you have that facility. In the case of classical cervix, you see the uptake in the uterine wall. Or a classical case of prostate cancer, you see the remnant uptake in seminal vesicle. So from the beginning of 1900 itself, I'm coming to the therapy in nuclear medicine. The last few slides, please. Where is the magic bullet? Where I can treat the cancer cell or disease cell and don't give radiation, don't harm any normal cell anywhere in the body. Where is the magic bullet? And this was told by the Paul Ehrlich in 1900. And this they have tried now in chemotherapy. You say the targeted therapy, precision medicine, but nuclear medicine has reached that magic bullet when they have tried with the iodine therapy. So with new radionuclides, I can give an isotope and see where this is getting distributed in the body, and then treat that part. That is the advantages. And they have compared various systemic options. They have found that radiotherapy has shown the best efficacy with minimal toxicity compared to all other systemic therapies. This is how I give the isotope. I can give as a radioactive element, a small molecule, peptide, antibody, etc., etc. And I give since 1960, you can say 40s, we are treating iodine-131, treating millions of patients with thyrotoxicosis and cancer thyroid. And even today, we are treating with iodine-131, same doses, and cancer thyroid, the same concept that was told in 1940s. A patient of thyrotoxicosis, where there is intense uptake of tracer in the salivary glands, showing avid uptake of tracer in the thyroid glands, they give a single dose of iodine, a liquid or a capsule, patient happily goes home, becomes hypothyroid, I treat and just keep on medical treatment for the rest of the life. Because it is found in the studies, thyrotoxic patient, there is increased mortality compared to the hypothyroid patient. And here is solitary thyroid nodule showing a decreased uptake of tracer. Then we go for a thyroidectomy, a cancer thyroid patient, and surgery is the treatment of choice. You should remember that for all cancer thyroid, surgery is the treatment of choice, followed by iodine-131 therapy. In this, we have to done a scan, and it shows a residual thyroid tissue. We treated iodine 131 therapy, 6 months completely gone. And wherever the cancer, thyroid, well differentiated carcinomas, we treat, there is a uptake with iodine 131. There is a 20-year survival, 99%. Wherever there is no uptake of iodine 131 in well differentiated thyroid cancer, the survival is poor. So well differentiated thyroid cancer, after surgery, please send them for iodine 131 scan. Or wherever there is, you don't do proper surgery, significant residual thyroid tissue, a lot of thyroid tissue, have to go for a repeated surgery or treat multiple times. Why this is iodine is taking up, why this technetium is taking up, it is because of the sodium iodide symporters in the follicular cells. Or thyroid metastasis in the lungs. I treat repeatedly and slowly goes away. P32 is the one of the first isotope we are treated with polycythemia vera and essential thrombocythemia. Even today also above 65-70 we can treat. So you have chemotherapy drugs also. So multiple painful skeletal metastasis is there. With a simple injection, there is pain relief. I can try 4 isotopes, samarium, P32, and just comes to the OP, takes 1 injection. There should not be any neurological compression. So I do a bone scan, uptake is there, I treat. A simple injection, you have a surgical synovectomy. All patients with rheumatoid arthritis, seronegative arthritis, psoriatic arthritis, I can treat to put an installation into the joint. That is radiation synovitis. We put into the joint, depending on the big joint, small joint, I put isotope, stay for 24 to 48 hours, patient goes home. The synovium is destroyed. So similarly, for hepatic tumors, this is one of the therapies, I give yttrium-90. So you just give isotope, you see the distribution of the isotope, technetium MIA, then we treat with yttrium-90 isotopes. So radioimmunotherapy, I can treat with the lymphomas. I give with the either yttrium or with the iodine 131. We inject the isotope, after therapy completely gone. Recent additions, neuroendocrine tumors, we don't have an effective therapy. In this case, there is a concept, theranostic approach. The same target in the cell, like somatostatin receptors, we scan, we treat. This is called a theranostic component, which is the latest in nuclear medicine therapy. We do the scanning with the technetium isotopes, iodine 123, gallium. We treat the same target, iodine 131, lutetium, alpha emitters.
Sir,
So
time
this,
is up.
yeah,
Please,
last slide. You can say this is the actual heart of the slide. You have iodine 131 with the sodium iodide symporter, we treat therapy. Sodium MIBG, I can treat with neuroblastomas, pheochromocytomas, paragangliomas. Radium not available. Lutetium and yttrium for neuroendocrine tumors. This technology we are treating already. This is available. For cancer prostate, we treat with lutetium and actinium. For lymphomas with this one. So this is the therapy. And so this is very safe, completely safe. We give as dose as a chest X-ray only. The thyroid scans. So comparison, a smoker will give more radiation to the body, 53 MSV, where a PET scan give only 10 to 14 MSV. Thank you for your patience.
Thank you very much, Shankar. Highly elaborative, and really we came to know through you only the difference between radio diagnosis and treatment with isotopes. Thank you very much for giving valuable lecture. Thank you.
So now with this COVID, this thing, is there any role of nuclear medicine in?
We'll discuss later.
Thank you.
Thank you, Mr. We're really growing the new, for so many people, new topic. This is nuclear medicine, but it is coming up very excellently covered. And the hope of the day, and tomorrow, the nuclear medicine in every aspect will see it. Per fitting oration for Peri Sastry Garu. Really, Peri Sastry Garu, I know him very well. I moved with him in IMA, very nice person. Though he old timer for us, but with latest concepts always. Very nice person. That's why I say this is a very, very fitting oration for him. And at the same time, I congratulate and thank our P. Sharma. He is the grandson of Perisasri Garu. And so nice. Thank you very much, sir. On behalf of IMA AP State, I congratulate you for giving excellent oration on the name of Dr. Perisasri Garu.
Thank you, sir. Thank you.
Thank you, sir, for your elaborate oration, sir. And please accept a token of gift from the organizers. So I request the moderators and the chairperson to stay back for a small felicitation, sir. Dr. Vishnuvardhan, sir, please come on to the dais to felicitate the chairpersons and moderators.
Thank you, sir.
Thank you, sir. So to the audience, just before the inauguration of the conference by the guests, there's a small cultural program by the Ashram cultural team.
Hi guys, good evening all. Today I'm going to entertain you.
Kiran,
Yes.
Two important announcements. So for the guests who have come from the outstation, tomorrow morning there's going to be a bus which is taking all the people who are interested to go to Chinna Tirupati Dwarka Tirumala. So it will start from the hotels. Bus of 40-seater bus will go from the hotels. It will be taking the guests and they'll come back by 10 o'clock. So the bus starts by 6 o'clock and returns by 10. Whoever is interested can contact the hotel help desk. It will come to the hotels individually and pick the guests. 40-seater bus is going to Dwarka Tirumala. The second announcement is there is a small change in the today's evening banquet program. It is not originally we have proposed an outdoor venue, but since the weather is not with helping us, so we shifted to an indoor venue, Sukhi Baba Venue Hall near Chintalpudi Road, Ashok Nagar Bridge down. So it's easily located on the Google Maps. So anyone who is wanting to come to the banquet can come along with the badges or the coupons, and it will be starting by 8 o'clock after the function.
The location has been shared on APCON 21 group. Kindly share with your friends and spread the message.
Hi guys. So this is Kiran. So here I am working as IT manager in Ashram Medical College. So now I'm going to play some invisible drums. So can you see any instrument here on the stage? Yes or no? But I can see the instruments and I will play this. And I will play total drums. And now I will do some bass guitar and drums. And now, so if anybody is interested to sing any song, please come onto the stage. Anyone is interested to sing any song, it's an offer. So there is some time. If anybody interested, please come here and sing. I will do for any song. And now, anyone interested, please come. So next I will play the tabla instrument. I will mix the drums and tabla. Thank you. And if anybody interested, please come. Any song, any language. So now I'm going to do some the dangerous song. So nachaleda evarki? So why no claps? So it's not an easy playing all instruments with my mouth, sir.
Small announcement.
Can I continue?
Nothing. The people at the left, or the audience at the left, are requested to come to the center of the stage, center row, please. Just for completion, please come out to the center.
Now I'm going to do some Jurassic Park. Jurassic Park. Anyone interested? Please come. Any song? It's an offer and not an offer because it's everyone there. Anyone? Any song? Right? So now I do the Jurassic Park in English. It's coming. Come on, John. See that side. It's coming. What? See that side. Jurassic Park is coming soon. So the same Jurassic Park mana Telugulo dubbing చేస్తారు. అది ఎలా ఉంటుందో చేసి చూపిస్తాను. Hey John, అటు చూడు వస్తుంది. Hey నువ్వు అటు తిరుగురా. Hey పరిగెత్తు. John నువ్వు పరిగెత్తు నేను వస్తాను. Jurassic Park is coming soon. Thank you and a small request. So ఎవరైనా song please ఎవరైనా song పాడేవాళ్ళు ఉంటే please come పైకి రండి. Someone from the audience
can come around. There's still some more time just for entertainment. Any students, medical students, nursing?
Yeah. So last and final cricket commentary. The match between India versus Pakistan. The ball from Shoaib Akhtar to Sachin Tendulkar. What a shot from Sachin Tendulkar. The ball is gone out of the field. The next ball, Shoaib Akhtar to Sachin. The 2 balls, 2 sixes. What a shot! And after అయిపోయిన తర్వాత మ్యాచ్ అయిపోయిన తర్వాత ఇన్విటేషన్ అంటే స్టేజ్ మీద పిలుస్తారండి టెండూల్కర్ని. Tendulkar, the man of the match is Sachin Tendulkar. Please come on the stage. Tendulkar, tell about the match. Tendulkar voice అండి. Tendulkar, tell about the match. Yeah, it was a nice match here in Visakhapatnam. The boys well played well.
The Ashram cricket ground is very good. The ball is coming out of the bat. Thank you, guys. Thank you so much. The man of the series, Mahendra Singh Dhoni. Dhoni, tell about the match.
Yeah, it was a nice match here. We won the toss. First, we won the toss, and which was batting. And our guys, Raina, Kohli, they played well. And our bowlers, they got wonderful wickets. First 3 wickets. Thank you so much. Thank you, Ravi.
Thank you.
What's your name?
My name is Vishnu Kumari. ఈ భాషకందని భావం నీవు వెలకట్టలేని ముత్యం నీవు దేవుడిచ్చిన వరమే నీవు తీర్చలేను ఓ రుణం ఎదలో దాగిన పలుకే నీవు నీ ప్రేమకు ప్రతిరూపం అమ్మా నిన్ను మించిన దైవం ఏదియు లేదే లోకంలో ఈ తీయని బంధం కానారాలేదే నవమాసాలు నీలో నన్ను మోసావు నా ఊపిరికై నీ ప్రాణం పణంగా పెట్టావు రేయి పగలంతా నాకై శ్రమ పడినా నీలో మమకారం నీలో చూసానే నీ సుఖ సంతోషం కాచిన నాకై తీరని అనురాగం నీలో చూసానే.
Thank you. Thank you so much.
On behalf of the organizing committee, I would like to thank Mr. Kiran. Thank you for your encouraging performance and for lifting the moods of the audience. Thank you very much. Give him a big round of applause, please.
and taking care of the medical and health problems of state of Andhra Pradesh. He is very cordial and very much helpful to the medical profession, especially to the Indian Medical Association, Andhra Pradesh state branch. We approached several times and then had some solutions for our problems. Sir, the Indian Medical Association at the Andhra Pradesh state has got 19,000 members in its fold, doctors of the modern medicine, modern system of medicine, and who have been very actively participating in the recent COVID problem. And members of our association have done immense service to the public at large, both the urban and the rural public in the medical care of the COVID patients, risking their lives. And you know, sir, many of our doctors lost their lives, and some of them are left with no family support or anything like that. And we are also actively involved in the vaccination process of the COVID, and all our doctors are very active both in the rural areas and the urban areas in the vaccination, and we are continuing to do this vaccination process in our state. And we are very much coordinating with the activities of the government of Andhra Pradesh in various issues of the Medical Council, University of Health Sciences, and then COVID care, and also in the management of various national health programs that are implemented in the state of Andhra Pradesh. We are very much thankful to you, sir, for being here on this. And you have visited several places, especially the Visakhapatnam. And then the main problem for this IMA are the doctors. We have got certain problems, especially the fire safety precautions, and that needs rapid, very active your cooperation and help in this. And another important issue which I have brought to your notice in the past, the IMA AP state do not have, even though it is a big branch, do not have a building of its own, either at the state capital at present, Vijayawada, or at our executive capital, Visakhapatnam, sir. We have already represented yourself to issue some place, both the places, Vijayawada and Visakhapatnam, to construct a building of our own, because many of our activities like free clinic treatment to the public, we can do it if we are provided some shelter for the doctors community. I request you to, sir, to focus your attention and then do justice. We have got here another dynamic leader of National IMA, Dr. Jailal, the National IMA president, who is a professor by himself, and for his professorship, he takes care of all of us. He runs and does the things and keeps all of us running in performing various activities of the IMA national level. We are very fortunate to have you, sir, as a national president, and also we are very happy that you could make your time to attend to our state function here in the installation function of the IMA AP state. And we are very much thankful to you, sir, for being appreciating the activities of the IMA AP state, and then giving a number of members in the various standing committees of the National IMA and in the COVID Warriors Awards, and even the recent Yuva Leaders Awards also. We are very much thankful to you, and we will continue to have our support and then our active participation in the Andhra Pradesh state in the new regime also. And we request you to continue your cooperation and then help to us. It is very fortunate to have another important dignitary of the IMA national level, Dr. Ravi Vankaitkar, the treasurer of World Medical Association, who is the most dynamic leader. As a president, also, he did a lot of service to the Indian Medical Association. He visited several times the Andhra Pradesh IMA, and then we are very fortunate to have him this evening. Sir, We still remember your visits to various places in our Andhra, and also the membership drive you have taken up in a large scale in your presidentship. We are very happy to have our own member occupying the chairman post of the Academy of Medical Specialties at the national level, Dr. Srihar Rao Garu. Thank you very much for being here with us. And this majestic building, and then the facilities that are provided by the Ashram Trust and then Ashram Institute. We are very much thankful to the management of the Ashram Medical College and the institute. We are very happy to introduce the activities of the IMA AP State. We are very much activating many of the wings of the IMA AP State, like Women Doctors Wing, the MSN, academic wings, and other JDN and other HPI and other wings. We are doing our best, sir, in the last 1 year. And I am sure we will continue to have the similar activities in the new regime by the Dr. Srinivas Rao, the incoming Srinivas Raju Garu, in the incoming president. With these few words, I thank you once again, all of you. And now I request Dr. Jailal sir, National President, to please give your message. Before that, I request Dr. Srinivas. Now we will have the inauguration function of the thing by lighting the lamp by the dignitaries.
Lighting the lamp,
Oh.
unveiling
This highlight sariga.
unveiling చేసిన తర్వాత ఇప్పుడు చేంజ్ ఆఫ్ గార్డ్ అయిన తర్వాత అప్పుడు నాకు రెస్పాన్స్
Okay.
ఉంటుంది. రెస్పాన్స్ తర్వాత అప్పుడు వస్తుంది.
I request the organizers to keep this lighting the lamp ready. I request our dignitaries, sir, minister, sir, please come over, our national president.
महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिं मनसा स्मरामि
అదే చేసేస్తాం అని ఏముంది దాంట్లో. Now I request the dignitaries to unveil the commemoration sitting there of the AP State Conference. Please, sir.
the commemoration of the 6th IMA APCON.
Now the moment has come where the incoming President, Dr. Srinivas Raju, it's my present duty to hand over the charge to Dr. Srinivas Raju garu. Please.
This is the first time ever a member of Elur IMA has become state president. Give him a big round of applause, please.
Now I request the new president of IMA AP State, Dr. Srinivas Raju garu, to address the gathering.
Luminaries on the dais and off the dais. Especially today is a auspicious day for me and also the entire medical fraternity, not because of I'm taking an oath as the president, but after the draconian struggle of 18 months against the pandemic COVID, we are all here physically and emotionally, and we have to have a contact of eye, and also we have to assimilate your body languages. That is the greatest moment for me today. The great leader born in the Helapuri town, and who is a sincere and soft-spoken, is a nonchalant worker in the political field. It is none other than our health minister and also deputy chief minister, Sri Alla Kali Krishna Srinivas garu. I know as a health minister, he is always in the forefront to uplift the even medical students and also junior residents and government doctors and private doctors and the entire medical fraternity. Thank you, sir. And my president, Dr. Subramanian garu, he is a reputed neurologist, neurosurgeon in the Visakhapatnam. He has done human service in the field of medicine, neurology, and also in the fraternity of the medical fraternity and IMA. Thank you, Subramanian Garu. And my national president, the vibrant leader, the national IMA has its halls echoes with the sound and also his charisma and also his wisdom. It is a very great to emulate. He is one of the inspiration for me. Dr. Jalal sir, welcome sir. My guru and also the great social movement architect since his father's days and fearless medical worker and also sincere clinician, Dr. Goparaj Samaram Garu. Welcome, sir. And my dear friend in the Tirupati and evergreen charismatic leader, chairman of the AMS, Dr. Srihar Rao Garu, and my dynamic secretary and silent worker, Dr. Nandakishore Garu, and my colleague in the Eluru branch. Not only in the Eluru, is also my batchmate or a classmate in the RMC, Kakinada, and is none other than member of the APMC, Dr. Dirsala Varaprasad Rao Garu. And the most important of all, the treasurer of the World Medical Association, the great philosopher, the great farmer also, and is a architect of the Mahapanchayat movement in the medical fraternity. Against the mixopathy, against the crosspathy, he is none other than Dr. Ravi Vanketkarji. And my colleagues of the 2021 and my incoming colleagues, new colleagues, and 2022. Dear friends, along with my new office bearers, let me invite my colleagues in the 2022, starting with Dr. Ramani Garu, is Vice President, Zone 1. Dr. Anil Kumar from Zone 2. And Srinivas Teja from the Zone 3. And 3 joint secretaries, Shivashankar Reddy and M.V. Chowdhury and Madhukar. And the most important of all, the sincere and also hardworking candidate from the Nandyala, Dr. Ravi Krishna. He is the next president-elect of the IMA AP state. Yes, sir. I don't take more than 7 minutes. Dear esteemed members of the Indian Medical Association, I am extremely delighted to welcome all the delegates, faculty, and distinguished guests graced for this prestigious 6th annual IMA AP State Conference. I especially welcome my friends and well-wishers who have traveled here to participate in the privileged moment. I am honored and privileged to have been elected as president of our prestigious and privileged Noble Association. At the outset, first of all, I must pay my respects, reverences, and gratitude to all the leaders, especially past presidents and past secretaries who have done yeoman service to the association since almost 2 to 3 decades. Let me extend my reverence and gratitude to the members of my home branch, Eluru, for their unflinched faith bestowed on me. I am extending my heartfelt, respectful gratitude to Dr. G. Samaram Garu and Dr. N. Apparao Garu. Actually, Apparao Garu is suffering from COVID, so he is very, very weak. So he couldn't present in this gathering. Who played a pivotal role in shaping my career in the association. It is an amazing performance of the organizing team, along with state IMA office bearers, past state presidents and secretaries and Ashram Medical College management and media friends, that I must extend my congratulatory thanks to everyone, including large-hearted sponsors. Friends, let me thank one and all for the trust and love reposed on me and my team, appointing us as the executive custodian of the prestigious organization of the year 2022. We pledge that we strive hard to strengthen all wings and welfare schemes of the IMAP. Academics, safety and security of our members and their families, and quality medical education, safe and secure ambience for the resident doctors and doctors in government and corporate service and in medical colleges and in public health are one of our top priority. Safety and security and work rules, salary and healthcare, family security and academics are few issues that have been bothering the teaching faculty since decades. It is high time that our Indian Medical Association could do something to the reward teachers and resident doctors and interns working in medical colleges. That's why I am proposing for this year to create a new wing in the name and title as Federation of Medical Teachers. It is our earnest proposal of this year. On another side, focusing on medicos and junior doctors and strengthening the MSN JDN wings, which could empower the future of the IMA if nurtured properly. That is why since 60 days, along with planning of this conference, we have organized a cultural fest, knowledge quest, and Medi-Olympics for medicos of 30 colleges in our state. I request and I recognize the presence of the State of Telangana President, Dr. Sampath Rao. Please. And I request the presence of the Dr. Jagan Mohan Rao Garu also, Chairman of the FBS of Telangana IP State. Dear friends, our main objective is making the life of average practitioner safe, secure, and hassle-free. It is the main motto of my tenure this year. My message is incomplete without mentioning the great efforts of our state government under the dynamic leadership of Honorable Chief Minister Sri Jagan Mohan Reddy Garu against COVID pandemic and great reform in the healthcare. Let me take this occasion once again to extend my thankful congratulations to CM Sir, Sri Jagan Mohan Reddy Garu, and Honorable Health Minister Sir, Sri Krishna Srinivas Garu, for their innovative and progressive reforms in health sector and allocating 16,000 crores for it. Thank you, sir. The state government plans to establish new government medical colleges, healthcare hubs in every district on fast track mode. Regarding this, the state government requested from the CEO of the Andhra Pradesh Economic Development Board and requesting our IMA support in identifying the potential players who can invest in the state of Andhra Pradesh. So let me make this context to request our ministers to see that MSME facilities be applicable to the hospitals in our state, sir. Sir, central government already granted the MSME status to the all hospitals. So I request here also to put the all small hospitals and medium-sized hospitals in the ambit of the MSME. Thank you. It is good to hear that the new recruitment drive has been initiated and the hospital development committees restructured And most important of all, the expansion of service network, more than 2,500 procedures under Aarogyasri, including COVID and other viral diseases has been done. It is amazing to see that YSR urban and rural clinics have been constructed in the entire state. Thank you, sir. Strengthening of the sub-center and oxygen infrastructure and commissioning of the new emergency care blocks in some of the district hospitals are some of the reforms under implementation, and some are proposed to materialize in the span of 5 years. Let us remember the heroics of the entire nation under the knowledgeable leadership of Modi ji against the pandemic and executing the largest vaccine drive in the world. And what full marks to the central government under the leadership of Modi ji. In the fight against COVID pandemic, AP state under the leadership of Honorable CM Sir, Sri Jagannath Reddy Garu, and Honorable Health Minister Sir, Sri Alanani Garu, and Honorable Irrigation Minister Sir, Sri Anil Kumar Yadav Garu, and other ministers and executive authorities, especially police, revenue, sanitary, nursing, and paramedical workers, have done amazing service and became role model for the entire country. Take teleconsulting services, oxygen infrastructure, uninterrupted essential medicine supply chain, AP stand tall against the pandemic. It is entire credit goes to our Health Minister, Sri Alanani Garu. Sir, just only 3 or 4 minutes. I request any management committee on behalf of Ashram Medical College, Sri Hanumantrao Garu. Hanumantrao Garu. Dr. Vijay Mohan Garu, please. As a convener of the state COVID task force since 18 months, it is apt to mention here how we, the IMA, has been cooperated and coordinated with the government machinery to fight bravely against the draconian pandemic. Out of 18,000 state members, only 15,000 members are in the active service, and out of this, only 4,000 doctors are above 60 plus age group who have contributed teleconsulting services to COVID patients, and also few of them donated their money and might. And here we have to tell, sir, in Andhra Pradesh, almost 80 doctors have sacrificed their lives to the draconian pandemic of the COVID. My respects on behalf of entire IMAP state, and also on behalf of the entire audience here, my respects to the all COVID martyrs. So that's why we have commemorated this hall as the COVID Martyrs Hall, COVID Martyrs Memorial Hall, this one. Friends, let us remind one beautiful quote: success in the sum of small efforts. Friends, there are so many challenges. I think it is bored to you all. Anyhow, I have to work in 3 paradigms and 3 perspectives: quality medical education, public health, and safety and security of our medical fraternity. And including this one, MSN and JDN, Medical Students Network and Junior Doctors Network. So with these 5 perspectives and also 5 paradigms, I have to plan along with my team to deliver the necessary services to all the medical fraternity. And also, we, on behalf of IMAP state, we are supporting and extending our solidarity to the Indian medical service. At this juncture, let me request our Health Minister, sir, whenever there is any question or any request from the central government to the state government regarding the Indian medical service, please accept and also promote the Indian medical service in the field of the administration and also in the field of the Group 1 officers also. And let me conclude within 1 minute. Here I have to remember the quote of the Swami Vivekananda. Take up one idea, think of it, dream of it, live on it. Let the brain, muscles, nerves, and every part of our body be full of that idea. This is the way to success. So definitely we, the IMA, should follow and could follow and would follow this quote of the Swami Vivekananda. And dear friends, before I conclude, our mission is the make medical profession noble and affordable and make it safe and secure for the medical professionals. And our slogan is the be vibrant and be passionate. And our theme is the building the healthier future through partnerships. So to make our slogans and theme into reality, I am proposing to initiate the most useful mission to be accomplished on this globe with a partnership with the Indian Resuscitation Council. IMA's Mission Life Possible. This is going to, we have to train all the members in the local branch as under the training of trainer workshop. Then in return, these members in the local branch will train all the high school students and college students in the art of the calls and also BCLS and ACLS and CCLS. In this regard, I request Dr. Chakrao Garu, the chairman of the IRC, to extend their cooperation and coordination to the state IMA. Before concluding my message, it is customary. So we have 5 appeals to the state government, sir. Sir, allocate a piece of land. Allocate a piece of land in the Vijayawada to state IMA to construct the office and serve the community. And make few amendments in police manual and establish fast track courts and expedite the judiciary process in cases of violence and vandalism against doctors and hospitals. Recruit MBBS doctors permanently in all sub-centers instead of mid-level health providers, sir. That is more important, sir, because the profession of the doctor, the medical profession seems to be like a glittering glass. It is not a gold at all now. Because there is a underemployment and unemployment is there. Almost 1 lakh MBBS graduates also on the roads, sir. And sir, implement the existing acts in letter and spirit by nominating the members of the IMA in state and district advisory bodies and committees, sir. In enumerating the electric tariff and property tax, count the small hospitals below 25 beds as domestic category. With these 5 appeals, sir, it is our earnest request to the state government. I once again request all of you to render best of your cooperation and participation in our march together to build a healthier world. Friends, coming together is a beginning. Thinking together is a progress. Working together is a success. Long live IMA. Jai Hind. Program sheet ichcharu meeku. Is new job and new times. I request our Honorable Health Minister, sir, to release the souvenir of this conference. Yeah. Okay. I request the Treasurer of the World Medical Association, Dr. Ravi Venkatkarji, to release the IMA Magna Carta, which is the manual for all the IMA members. I request Honorable Health Minister, sir, to deliver his auspicious blessings and message.
ఈరోజు ఇండియన్ మెడికల్ అసోసియేషన్ నూతన అధ్యక్షుడిగా మా అందరికీ కూడా ఎప్పటి నుంచో పరిచయం ఉన్నటువంటి వ్యక్తి, ఒక డాక్టర్గా ఏలూరులోనే కాదు జిల్లా వ్యాప్తంగా రాష్ట్ర వ్యాప్తంగా ఆయన అందించేటువంటి వైద్య సేవల ద్వారా ఎంతో పేరు ప్రఖ్యాతులు తెచ్చుకున్నటువంటి డాక్టర్ శ్రీనివాసరాజు గారు ఈరోజు స్టేట్ IMA ప్రెసిడెంట్గా ఈరోజు పదవి బాధ్యతలు స్వీకరించటం నా హృదయపూర్వకమైనటువంటి శుభాకాంక్షలు, శుభాభినందనలు శ్రీనివాసరాజు గారికి తెలియజేస్తూ ఉన్నా. అదేవిధంగా ఇప్పటి వరకు IMA ప్రెసిడెంట్గా పనిచేసినటువంటి డాక్టర్ సుబ్రహ్మణ్యం గారు, ఆయనతో కూడా గత సంవత్సర కాలంగా ఆయనతో కూడా నాకు వ్యక్తిగతంగా చాలా పరిచయం ఉంది. ఎందుకంటే మనకందరికీ కూడా తెలుసు, సంవత్సరన్నర కాలంగా మన రాష్ట్రమే కాదు యావత్ భారతదేశం అంతా కూడా ఏ విధమైనటువంటి విపత్తును ఎదుర్కొన్నామో కోవిడ్ సందర్భంగా మనకందరికీ కూడా తెలుసు. ఈ సందర్భంలో చాలా సందర్భాల్లో నేను ఇండియన్ మెడికల్ అసోసియేషన్కు నా అభినందనలు, కృతజ్ఞతలు ప్రభుత్వం తరపున తెలియచేయాలని ఆలోచన నాకున్నా కూడా ఎప్పుడు నాకు అవకాశం రాలేదు. సుబ్రహ్మణ్యం గారు IMA ప్రెసిడెంట్గా, స్టేట్ IMA ప్రెసిడెంట్గా ఆయన ప్రభుత్వానికి ఇచ్చినటువంటి ఆయన సహకారం, స్టేట్ IMA కమిటీ ద్వారా, ఆ సభ్యుల ద్వారా ఈ కోవిడ్ పాండమిక్ సిచ్యుయేషన్లో వారు అందించినటువంటి సేవలు నిజంగా ప్రభుత్వం తరపున, మా తరపున కూడా నా హృదయపూర్వకమైనటువంటి కృతజ్ఞతలు. కోవిడ్ సందర్భంగా IMA అందించినటువంటి సేవలకు, వారు చేసినటువంటి త్యాగాలకు. ఎందుకంటే ఇందాక మాట్లాడినటువంటి డాక్టర్ గారు చెప్పారు, ఆ సేవలు అందిస్తున్నటువంటి సందర్భంలో ఎంతో మంది డాక్టర్లు కానీ, పారామెడికల్ స్టాఫ్ కానీ అందరూ ఎంతో మంది మరి ప్రాణాలు కూడా కోల్పోయినటువంటి పరిస్థితిని మనం చూసాం. అటువంటి పరిస్థితుల్లో కూడా ఎక్కడ కూడా వెనుకడుగు వేయకుండా వారి ప్రాణాలను సైతం లెక్క చేయకుండా ఏ విధంగా కోవిడ్ వంటి ఒక విపత్కర పరిస్థితులను భారతదేశం, మన రాష్ట్రం కూడా ఎదుర్కొంటున్నటువంటి పరిస్థితుల్లో, ముఖ్యంగా మన ఆంధ్రప్రదేశ్ రాష్ట్రంలో ఉన్నటువంటి డాక్టర్స్ కానీ, ఇతర పారామెడికల్ స్టాఫ్ కానీ, ముఖ్యంగా IMA ఇచ్చినటువంటి సహకారం ఎప్పుడు మేము IMA అని మేము పిలిచి మాకు ప్రభుత్వం తరపున ఈ సర్వీసెస్ కావాలని అడిగినా కూడా ఎక్కడ కూడా ఏ విషయంలోనూ కూడా వెనుకడుగు వేయకుండా ప్రభుత్వానికి వారు అందించినటువంటి సహకారం మేము ఎప్పటికీ కూడా మరువలేంది. ఆ విధమైనటువంటి సహకారం మరి సుబ్రహ్మణ్యం గారు ప్రెసిడెంట్గా ఉండగా మరి రాష్ట్ర ప్రభుత్వానికి అందించడం, వారికి కూడా నా హృదయపూర్వకమైనటువంటి అభినందనలు. ఎందుకంటే IMA ప్రెసిడెంట్గా ఎన్నో సమస్యలు మా దృష్టికి తీసుకురావటం జరిగింది. డాక్టర్ సర్వీసెస్కి సంబంధించినటువంటి ఎన్నో ఇష్యూస్ ప్రభుత్వం దృష్టికి తీసుకొచ్చి ప్రభుత్వం ద్వారా ఆ సమస్యలు పరిష్కారం అయ్యేలా చూడటంలో మరి సుబ్రహ్మణ్యం గారు చేసినటువంటి కృషి వారిని నా హృదయపూర్వకంగా అభినందిస్తూ, మరి ప్రెసిడెంట్గా మరి నూతనంగా శ్రీనివాసరాజు గారు బాధ్యతలు తీసుకున్నప్పటికీ కూడా మీరు ఇప్పటి వరకు చేసినటువంటి ఈ సేవలను మీరు కొనసాగించండి. తప్పకుండా మా అందరి సహకారం, మీరు చేసేటువంటి ఈ సేవలకు, మీరు చేసేటువంటి సర్వీస్కు మా అందరి సహకారం ఉంటుందని వారికి కూడా మరి నా శుభాకాంక్షలు సుబ్రహ్మణ్యం గారికి కూడా తెలియజేస్తూ, మరి ఈరోజు ప్రత్యేకంగా మరి నూతనంగా ప్రెసిడెంట్గా బాధ్యతలు స్వీకరించినటువంటి శ్రీనివాసరాజు గారు అనేకమైనటువంటి విషయాలు మా దృష్టికి తీసుకురావటం జరిగింది. తప్పకుండా సుమారు 2.5 సంవత్సరాలుగా గౌరవ ముఖ్యమంత్రిగా జగన్మోహన్ రెడ్డి గారు పదవి బాధ్యతలు స్వీకరించిన తర్వాత ప్రత్యేకంగా IMA విషయంలోనే కాదు, ఇండియన్ మెడికల్ అసోసియేషన్కి సంబంధించినటువంటి అంశాల విషయంలోనే కాదు, రాష్ట్ర వ్యాప్తంగా డాక్టర్స్ కానీ, వైద్య రంగంలో ఉన్నటువంటి ఇతరులు కానీ ఎదుర్కొనేటువంటి ప్రతి సమస్య మీద కూడా ఎన్నో సంవత్సరాలుగా ఎన్ని ప్రభుత్వాలు మారినా కూడా పరిష్కారం కానటువంటి ఎన్నో సమస్యలను మరి మీరు మా దృష్టికి తీసుకురావటం, ఆ సమస్యలను మేము గౌరవ ముఖ్యమంత్రి గారు జగన్మోహన్ రెడ్డి గారి దృష్టికి తీసుకువెళ్ళటం, ఆ సమస్యలకు ఆయన వెంటనే స్పందించటం, ఆ సమస్యలన్నీ కూడా పరిష్కారం కావటం మీ అందరికీ కూడా తెలియంది కాదు. తప్పకుండా భవిష్యత్తులో కూడా తప్పకుండా మీరు ఏ అంశాలనైతే మీరు వృత్తిపరంగా కానీ ఇతరత్ర ఏ అంశాలనైతే మా దృష్టికి తీసుకొచ్చారో, ఏ సమస్యలనైతే మీరు ఎదుర్కొంటా ఉన్నారో ఆ సమస్యల పరిష్కారంలో అంతకుముందు మేము ఏ విధమైనటువంటి సహకారాన్ని అందించామో భవిష్యత్తులో కూడా తప్పకుండా మీ IMA ద్వారా మా దృష్టికి వచ్చినటువంటి ప్రతి అంశాన్ని కూడా తప్పకుండా పరిష్కారం చేయడానికి, మా వంతు సహకారం అందించడానికి ప్రభుత్వ పరంగా ఎప్పుడూ సిద్ధంగా ఉంటామని చెప్పి మీకు సవినయంగా తెలియజేస్తూ ఉన్నా. తప్పకుండా ఇప్పుడు చాలా అంశాలను, మరికొన్ని అంశాలను మా దృష్టికి తీసుకొచ్చారు. అవన్నీ కూడా వాటన్నిటి విషయంలో మా సహకారం తప్పకుండా అందిస్తాం. మరో ప్రత్యేకమైనటువంటి అంశం, IMAకి సంబంధించి స్థలం ఒకటి ప్రభుత్వం తరపున ఇస్తే మాకు ఇప్పటివరకు IMA పర్మనెంట్ బిల్డింగ్ అంటూ కూడా విజయవాడలో కానీ విశాఖపట్నంలో కానీ లేదని చెప్తా ఉన్నారు. తప్పకుండా ఈ విషయాన్ని నేను గౌరవ ముఖ్యమంత్రి గారి దృష్టికి తీసుకువెళ్ళి సాధ్యమైనంత త్వరలోనే IMAకి సంబంధించి అసోసియేషన్ బిల్డింగ్ కొత్తగా మరి మనం ఏర్పాటు చేసుకుంటానికి వీలుగా ఆ స్థలాన్ని కూడా ఇచ్చే విధంగా ప్రత్యేకంగా నేను కృషి చేస్తానని చెప్పి మరి నూతన ప్రెసిడెంట్ గారికి నేను మాట ఇస్తూ, అదేవిధంగా నేను కూడా భవిష్యత్తులో ఇప్పటివరకు ఈ 2.5 సంవత్సరాలుగా ఏ విధమైనటువంటి సహకారం మీ IMA నుంచి మీరు ప్రభుత్వానికి అందజేశారో అదే విధమైనటువంటి సహకారాన్ని భవిష్యత్తులో కూడా మరి అందజేయవలసినటువంటి అవసరాన్ని కూడా నేను మీకు గుర్తు చేస్తూ ఉన్నా. ఎందుకంటే మీకు అందరికీ కూడా తెలియంది కాదు, గతంలో వైద్య రంగం అంటే, వైద్య ఆరోగ్య రంగం అంటే అది ఎలా నడుస్తూ ఉందో, ప్రజలకు సంబంధించి ఏ విధంగా ఆ వైద్య సేవలు అందుతూ ఉన్నాయో మనకందరికీ కూడా తెలుసు. అంతకుముందు ఎక్కడైనా ఒక విలేజ్లో ఒక వ్యక్తికి ఏదైనా ఒక ప్రమాదకర పరిస్థితి ఉంటే ఆ వ్యక్తి ఆ రాత్రిపూట ఆ గ్రామం నుంచి ఏదైనా ఒక సిటీలో కానీ దగ్గరలో ఉన్నటువంటి ఒక టౌన్కు వెళ్ళాలంటే అసలు అవకాశమే ఉండేది కాదు. ఎన్నో ప్రాణాలు కోల్పోయేటువంటి పరిస్థితి. ఇంకా మారుమూల ప్రాంతంలో ఉన్నటువంటి ఆ ఏజెన్సీ ప్రాంతాల్లో అయితే ఇప్పటికి కూడా మనం చూస్తూ ఉన్నాం. ఆ ప్రాంతాల్లో సరైనటువంటి సమయంలో సరైనటువంటి వైద్యం అందక ఎంతో మంది ప్రాణాలు కోల్పోతున్నటువంటి పరిస్థితుల్లో గౌరవ ముఖ్యమంత్రిగా జగన్మోహన్ రెడ్డి గారి పదవి బాధ్యతలు తీసుకున్న తర్వాత ఎన్ని సమూలమైనటువంటి మార్పులు వైద్య ఆరోగ్య రంగంలో ప్రజారోగ్య రంగంలో ఎన్ని సమూలమైనటువంటి మార్పులు తీసుకొస్తూ కొత్త కొత్త కార్యక్రమాలని కొన్ని వేల కోట్ల రూపాయల నిధులను వెచ్చిస్తూ ఎన్ని కార్యక్రమాలను అమలు చేస్తున్నారో మీ అందరికీ కూడా తెలుసు. ఆ కార్యక్రమంలో భాగంగా నాడు నేడు కార్యక్రమానికి సంబంధించి మన ప్రెసిడెంట్ గారు శ్రీనివాసరాజు గారు మీకు చెప్పారు. నాడు నేడు కార్యక్రమంలో మన రాష్ట్రంలో ఉన్నటువంటి పేద విద్యార్థులకు కూడా ఈ వైద్య విద్యను అందించాలన్న లక్ష్యంతో ఈరోజు ఇప్పటికి మనకు 11 మెడికల్ కాలేజీలు ప్రభుత్వంలో ఉంటే దాదాపుగా ఒకే సంవత్సరంలో బహుశా దేశ చరిత్రలోనే కాదు మనకి స్వతంత్రం వచ్చిన తర్వాత ఎప్పుడూ కూడా ఎక్కడా కూడా జరగనటువంటి విధంగా 16 కొత్త మెడికల్ కాలేజీలని కేవలం మన ఆంధ్రప్రదేశ్ రాష్ట్రంలోనే మరి ఏర్పాటు చేసుకుంటాం మనకందరికీ కూడా తెలుసు. ఆ 16 మెడికల్ కాలేజీలకు కూడా ఇప్పటికే టెండర్ల కార్యక్రమం పూర్తయింది. దానికి సంబంధించి మన గౌరవ ముఖ్యమంత్రి గారి చేతుల మీదుగా మరి శంకుస్థాపన కార్యక్రమాలు కూడా పూర్తి చేసుకుని దానికి సంబంధించి నిర్మాణానికి కూడా మరి ముందుకు వెళ్ళబోతా ఉన్నాం. కేవలం నాడు నేడు కార్యక్రమంలో కొత్తగా మెడికల్ కాలేజీలు కట్టడం మాత్రమే కాదు, దానికి సంబంధించి ఒక మెడికల్ కాలేజ్ వస్తే వైద్య సేవలు ఏ విధంగా పెరుగుతాయో ఆయా ప్రాంతాల్లో మీకు తెలియంది కాదు. ఎక్కడైతే మెడికల్ కాలేజ్ వచ్చిందో అక్కడ ఒక కార్పొరేట్ ఏదైతే ఒక అపోలో హాస్పిటల్ లేకపోతే కేర్ హాస్పిటల్ ఈ విధంగా అధునాతనమైనటువంటి సౌకర్యాలు ఉన్న హాస్పిటల్ లాంటి హాస్పిటల్ ఒక సూపర్ స్పెషాలిటీ హాస్పిటల్ దానికి అనుబంధంగా ప్రతి మెడికల్ కాలేజీకి మరి రావటం అనేది మీకు అందరికీ కూడా తెలుసు. ఆ విధంగా ఇప్పుడున్నటువంటి 11 మెడికల్ కాలేజీలకి అనుబంధంగా ఉన్నటువంటి హాస్పిటల్స్తో పాటు 16 కాలేజీలకి కూడా ఒక సూపర్ స్పెషాలిటీ హాస్పిటల్, ప్రతి కాలేజీకి అనుబంధంగా మరొక 16 సూపర్ స్పెషాలిటీ హాస్పిటల్స్ మన అన్ని ప్రాంతాల్లోనూ కూడా మనకు అందుబాటులోకి రావటం మరి ప్రజలకందరికీ కూడా వైద్యం పరంగా ఎంత మరి ఉపయోగపడుతుందో మిమ్మల్ని అందరినీ కూడా నేను ఆలోచన చేయమని చెప్పి నేను కోరుతూ ఉన్నా. కేవలం మెడికల్ కాలేజీలు హాస్పిటల్స్ వరకు మాత్రమే కాదు, గ్రామీణ ప్రాంతాల్లోనూ ఏజెన్సీ ప్రాంతాల్లోనూ ఉన్నటువంటి ప్రజలకు కూడా మన పట్టణాల్లోనూ నగరాల్లోనూ ఉన్నటువంటి ప్రజలకు ఏ విధమైనటువంటి వైద్య సేవలు ఏ అర్ధరాత్రి సమయంలో ఎటువంటి ప్రమాదం ఆరోగ్యం పరంగా వారికి వచ్చినా కూడా వెంటనే హాస్పిటల్కి వెళ్ళి వారు వైద్యం తీసుకుని ఏ విధంగా తిరిగి క్షేమంగా ఇంటికి వెళ్తూ ఉన్నారో ఏజెన్సీ ప్రాంతాల్లోనూ మారుమూల ప్రాంతాల్లోనూ ఉన్నటువంటి పేద ప్రజలకు గిరిజనులకు కూడా అదే విధమైనటువంటి అధునాతనమైనటువంటి వైద్యం అందాలన్న ఒక లక్ష్యంతో మన ప్రాంతంలో ఉన్నటువంటి 7 ఐటీడీఏలు ఉన్నాయి మన రాష్ట్రంలో. 7 ఐటీడీఏలోనూ ప్రతి ఐటీడీఏలోనూ అంటే ఉదాహరణకు మన పశ్చిమ గోదావరి జిల్లాలో ఒక బుట్టాయిగూడెం మనకు ఐటీడీఏ. ఆ బుట్టాయిగూడెం పరిసర ప్రాంతాలన్నీ కూడా కొండలు గుట్టలతో నిండిపోయి ఉంటుంది. ఆ ప్రాంతానికి సంబంధించి ఏజెన్సీలో ఉన్నటువంటి ఆ గిరిజనులందరూ కూడా ఆ ప్రాంతాల్లో కొండ ప్రాంతాల్లో నివసిస్తూ ఉంటారు. వారందరికీ సంబంధించి ఏ అర్ధరాత్రి పూట ఎన్నో మనం సంఘటనలు చూస్తూ ఉన్నాం, గతంలో కూడా చూసాం. ఏ సమయంలో ఏ గర్భిణీ స్త్రీకి అక్కడ ప్రసవం సంబంధించి ఇబ్బంది అయినా కూడా దారిలో రావటానికి కూడా కింద హాస్పిటల్కి రావటానికి కూడా అర్ధరాత్రి సమయంలో సరైనటువంటి మార్గం ఉండదు. అటువంటి పరిస్థితుల నుండి ఎక్కడైతే పట్టణాల్లోనూ నగరాల్లోనూ కూడా ఉన్నటువంటి ప్రజలు ఏ విధమైనటువంటి వైద్య సేవలు అందుకుంటా ఉన్నారో అవసరమైన సమయంలో అక్కడ కూడా అదే విధమైనటువంటి వైద్య సేవలు అందాలి. వైద్యం అందక ఏ ఒక్క పేదవాడు పేద మహిళ కూడా మరణించకూడదు, ఇబ్బంది పడకూడదు అన్న ఆలోచనతో గిరిజన ప్రాంతాల్లోనే మల్టీ స్పెషాలిటీ హాస్పిటల్ రాష్ట్రంలో 7 మల్టీ స్పెషాలిటీ హాస్పిటల్స్ కూడా మనం ఏర్పాటు చేసుకుంటాం. ఆ శంకుస్థాపన కార్యక్రమం కూడా మరి పూర్తి కావటం మరి నిర్మాణ దిశగా ముందుకు వెళ్ళటం మీకు అందరికీ కూడా తెలుసు. కేవలం మల్టీ స్పెషాలిటీ హాస్పిటల్స్ సూపర్ స్పెషాలిటీ హాస్పిటల్స్ మాత్రమే కాదు, గ్రామీణ ప్రాంతాల్లో మన పరిసర ప్రాంతాల్లో ఉన్నటువంటి గ్రామీణ ప్రాంతాల్లో కూడా ప్రతి గ్రామంలోనూ కూడా ఒక సబ్ సెంటర్ వైఎస్ఆర్ విలేజ్ క్లినిక్ పేరు మీద ప్రతి 4000కి ఎక్కడైతే జనాభా ఉన్నారో ఆ ప్రతి 4000 జనాభాకి ఒక విలేజ్ క్లినిక్. ఆ విలేజ్ క్లినిక్ కి సంబంధించి అందులో ఒక స్టాఫ్ నర్స్ ఒక మిగిలినటువంటి స్టాఫ్ అందరూ కూడా ఉంటూ అక్కడ సుమారుగా 12 గంటల పాటు అక్కడ వైద్య సేవలు అందే విధంగా మరి అక్కడ విలేజ్ క్లినిక్లను కూడా ఏర్పాటు చేసుకుంటూ ఉన్నాం. అదే విధంగా పిహెచ్సిలకు సంబంధించి కూడా గతంలో గతంలో పిహెచ్సిలో ఎక్కడ కూడా డాక్టర్స్ సఫిషియెంట్గా ఉండేవాళ్ళు కాదు, అదేవిధంగా స్టాఫ్ సఫిషియెంట్గా ఉండేవాళ్ళు కాదు, ఎక్విప్మెంట్ ఉండేది కాదు. ఆ విధమైనటువంటి లోపాలని సవరిస్తే, ఎందుకంటే పిహెచ్సి అనేది గ్రామీణ ప్రాంతాల్లో వైద్యం పరంగా ఎంత ప్రముఖ పాత్ర వహిస్తుందో మనకందరికీ కూడా తెలుసు. ఇప్పుడు ప్రతి మండలంలోనూ కూడా ఇప్పుడు ఒక మండలంలో దాదాపుగా 40,000 నుంచి 50,000 జనాభా ఉంటారు. ఆ జనాభాకి సంబంధించి ఒక పిహెచ్సి మాత్రం ఒక్కొక్క మండలంలో 2 పిహెచ్సిలు ఈ విధంగా పిహెచ్సిలు ఉంటాయి. ఈ విధంగా రాష్ట్ర వ్యాప్తంగా దాదాపుగా 1156 పిహెచ్సిలు ఈరోజు రాష్ట్ర వ్యాప్తంగా ఉన్నాయి. ఆ విధంగా ప్రతి మండలంలోనూ ఒక పిహెచ్సి 2 పిహెచ్సిలు ఉన్నాయి. అలా కాకుండా ప్రతి మండలంలోనూ కూడా 2 పిహెచ్సిలు ఉండాలి. 2 పిహెచ్సిలు ఉండటం వల్ల గ్రామీణ ప్రాంతాల్లో ఉన్నటువంటి ప్రజలకు, అక్కడ పిహెచ్సి అంటే మీకు డాక్టర్లుగా ఉన్నటువంటి మీకు అందరికీ కూడా తెలియంది కాదు. ఒక పిహెచ్సిలో ఖచ్చితంగా ఒక ఎంబీబీఎస్ డాక్టర్ ఉంటారు. ఆ డాక్టర్ ఉంటారు, అక్కడ ఒక స్టాఫ్ నర్స్ ఉంటారు, అక్కడ మినిమం ఎక్విప్మెంట్ ఉంటుంది, అక్కడ డెలివరీస్ కూడా జరుగుతాయి. ఈ విధంగా ఇంకా పిహెచ్సిలకి సంబంధించి ఇంకా డాక్టర్లు ఎక్కడెక్కడైతే లేరు వారందరినీ కూడా రిక్రూట్ చేయడంతో పాటు, అక్కడ పిహెచ్సిలకి సంబంధించి ఎక్కడెక్కడైతే ఒక మండలంలో 2 పిహెచ్సిలు లేవో ఆ విధంగా రేషనలైజ్ చేస్తూనే అవన్నీ కూడా, ఎందుకంటే ఒక్కొక్క మండలంలో 3 పిహెచ్సిలు కూడా ఉన్నాయి. అలా కాకుండా ప్రతి మండలానికి కూడా 2 పిహెచ్సిలకి తగ్గకుండా ఉండే విధంగా చర్యలు తీసుకుంటూ ఇంకా దాదాపుగా 176 పిహెచ్సిలకు సంబంధించి ఇంకా అవసరమైతే నూతనంగా 176 పిహెచ్సిలు ఇంకా మన రాష్ట్ర వ్యాప్తంగా ఏర్పాటు చేయడానికి ఇప్పటికే మేము జీవో కూడా ఇష్యూ చేయడం జరిగింది. కేవలం ఈ హాస్పిటల్స్ ఏర్పాటు చేయటం కాదు, ఇన్ఫ్రాస్ట్రక్చర్ ఏర్పాటు చేయటం మాత్రమే కాదు, ఎక్విప్మెంట్ ఏర్పాటు చేయటం మాత్రమే కాదు, దానికి సంబంధించి మనం ఇప్పటివరకు ఏ ప్రాంతానికి వెళ్ళినా కూడా, ఏ హాస్పిటల్కి వెళ్ళినా కూడా అక్కడ ఆ స్పెషాలిటీస్ ఉంటాయి, కానీ అక్కడ డాక్టర్లు అందుబాటులో ఉండరు. ఎందుకంటే డాక్టర్స్ రిక్రూట్మెంట్ జరిగి ఎన్నో సంవత్సరాలుగా కొత్తగా మనం హాస్పిటల్స్ కట్టుకుంటా ఉన్నాం, ఇన్ఫ్రాస్ట్రక్చర్ డెవలప్ చేసుకుంటా ఉన్నాం, ఎక్విప్మెంట్ మనం ఏర్పాటు చేసుకుంటా ఉన్నాం, కానీ సఫిషియెంట్గా అక్కడ డాక్టర్స్ అయితే మనం ఎప్పుడు కూడా మన రిక్రూట్మెంట్ అనేది ఏదో అరకొరగా జరిగింది. కానీ నాకు తెలిసి 10 సంవత్సరాలుగా దాదాపుగా ఎక్కడ కొత్తగా డాక్టర్స్ రిక్రూట్మెంట్ అయితే ఎక్కడ జరగలేదు. ఒక విప్లవాత్మకమైనటువంటి కార్యక్రమం దాదాపుగా ఒక్క సంవత్సరంలోనే ఇప్పుడు మనం నోటిఫికేషన్ ఇస్తూ ఉన్నాం. కొంతవరకు అయితే రిక్రూట్మెంట్ మనం పూర్తి చేసుకున్నాం. ఏపీపీ హాస్పిటల్లో ఇప్పుడు రిక్రూట్మెంట్ ప్రారంభం చేసుకోబోతా ఉన్నాం. ఒకేసారి దాదాపుగా 14,000 మంది వైద్య సిబ్బందిని, స్పెషలిస్టులతో పాటు, జనరల్ డాక్టర్స్తో పాటు, అదేవిధంగా పారామెడికల్ స్టాఫ్ను అందరినీ కూడా దాదాపుగా 14,000 మందిని మనం ఈరోజు రిక్రూట్మెంట్కి మనం చర్యలు తీసుకుంటా ఉన్నాం. అందులో చాలా వరకు కూడా రిక్రూట్మెంట్ ప్రాసెస్ కూడా పూర్తి కావటం మనకందరికీ కూడా తెలుసు. ఈ హాస్పిటల్కి సంబంధించి నిర్మాణాలు, దానికి సంబంధించి డాక్టర్లు, స్టాఫ్, వీటి వరకు మనం చేయటంతోనే మనం ఆలోచన అంతవరకు మాత్రమే పరిమితం కాలేదు. మన గౌరవ ముఖ్యమంత్రి జగన్మోహన్ రెడ్డి గారు ప్రతి అంశంలోనూ కూడా మీకు అందరికీ కూడా తెలుసు, ఆ దివంగత మహానేత రాజశేఖర రెడ్డి గారు ప్రవేశపెట్టినటువంటి ఆరోగ్యశ్రీ కార్యక్రమం వల్ల ఈ రాష్ట్ర వ్యాప్తంగా ఎన్ని లక్షల మంది పేద కుటుంబాలు వీధి పాలు కాకుండా ఏ విధంగా మరి వారందరూ కూడా ఈరోజు సంతోషంగా జీవిస్తూ ఉన్నారు. ఆరోగ్యశ్రీ కార్యక్రమాన్ని ఉపయోగించుకోవటం ద్వారా, దాని ద్వారా వైద్యాన్ని మరి సకాలంలో పొందటం ద్వారా, ఉచితంగా పొందటం ద్వారా ఎన్ని పేద కుటుంబాలు ఈరోజు రోడ్డును పడకుండా ఉన్నాయో మనం అందరం కూడా చూసాం. దానికి సంబంధించి కూడా ఎన్ని సమూలమైనటువంటి మార్పులు మీరందరూ ఆలోచిస్తే, అంతకుముందు మరి గౌరవ ముఖ్యమంత్రిగా జగన్మోహన్ రెడ్డి గారు పదవి బాధ్యతలు స్వీకరించక ముందు కేవలం 1,059 డిసీజెస్ మాత్రమే ఆరోగ్యశ్రీలో కవర్ అవుతూ ఉండేవి. ఈరోజు దాదాపుగా 2,500 డిసీజ్ ఇంక్లూడింగ్ క్యాన్సర్ తో సహా ఈరోజు 2,500 డిసీజెస్ ఈరోజు ఆరోగ్యశ్రీలో కవర్ అవుతూ ఎన్నో లక్షల మంది, ఎంతో మంది పేద ప్రజలు ఈరోజు వారి ప్రాణాలను కాపాడుకుంటూ, వారి కుటుంబాలు వీధుల పాలు కాకుండా, ఎందుకంటే మనం అందరం చూస్తూ ఉంటాం, మన వరకు అయితే ఎంతో కొంత ఎవరు మన కుటుంబంలో పెద్ద మరణించినా కూడా ఎంతో కొంత మన కుటుంబాలని మనం ముందుగానే మనం వారికి సేవ్ చేసుకుంటూ ఉంటాం. కానీ పేద మధ్య తరగతి కుటుంబాలకి సంబంధించి కనుక ఆ కుటుంబ పెద్ద చనిపోతే ఆ కుటుంబం అంతా కూడా వీధి పాలు కావాల్సిందే. అటువంటి పరిస్థితుల నుండి ఆ కుటుంబాలని రక్షిస్తూ కొన్ని లక్షల మంది మరి ఈ ఆరోగ్యశ్రీ కార్యక్రమాన్ని ఉపయోగించుకుంటూ మరి ఎంతమంది పేద ప్రజలు ఈరోజు సంతోషంగా, ఆరోగ్యంగా జీవిస్తూ ఉన్నారో మనమందరం కూడా చూసాం. ఈ కార్యక్రమంతో పాటు ముఖ్యమంత్రి గారి మదిలోంచి వచ్చినటువంటి మరొక మంచి కార్యక్రమం ఫ్యామిలీ డాక్టర్ కాన్సెప్ట్. ఈ ఫ్యామిలీ డాక్టర్ కాన్సెప్ట్లో మనకి ప్రతి మండలంలోనూ 2 పిహెచ్సిలను ఏర్పాటు చేయడంతో పాటు ఇప్పటివరకు పిహెచ్సిలకు సంబంధించి ఒక్కొక్క డాక్టర్ మాత్రమే ఆ పిహెచ్సిల్లో ఉంటూ ఉన్నారు. ఇప్పుడు 2వ డాక్టర్ను కూడా మరి రిక్రూట్ చేసుకుంటంతో పాటు ఆ 2వ డాక్టర్కి సంబంధించి ఏదైతే మనకి 104 వాహనాలు ప్రతి మండలంలోనూ కూడా తిరుగుతూ ఉన్నాయో, దాదాపుగా ఇప్పుడు 656 104 వెహికల్స్ గ్రామానికి వెళ్ళి పేద ప్రజలందరికీ కూడా నెలకి ఒకసారి ఆ గ్రామాన్ని విజిట్ చేయటం, ఆ గ్రామంలో ఉన్నటువంటి వారందరికీ కూడా వైద్య సేవలు అందించడం అన్నీ కూడా జరుగుతూ ఉంది. ఇప్పుడు ఈ ఫ్యామిలీ డాక్టర్ కాన్సెప్ట్ ద్వారా మరొక 432 వాహనాలు వెహికల్స్ కొనటం మాత్రమే కాకుండా మొబైల్ మెడికల్ యూనిట్స్ అవన్నీ కూడా మరొక 432 వెహికల్స్ కొనడానికి ఇప్పటికే టెండర్స్ పిలిచి ప్రతి మండలంలోనూ కూడా ఇప్పుడు నెలకి ఒక్కసారి ఆ వాహనాలు అవన్నీ కూడా ఆ ఎంఎంయూస్ అన్నీ కూడా నెలకు ఒకసారి ప్రతి మండలానికి వెళ్తాయి. అలా కాకుండా అందులో డాక్టర్ ఉండేవారు కాదు, ఉంటే ఒక స్టాఫ్ నర్సు, ఒక టెక్నీషియన్, ఒక డేటా ఎంట్రీ ఆపరేటర్ మాత్రమే ఉండేవాళ్ళు. కానీ ఇప్పుడు ఈ ఏదైతే మనం కొత్తగా మనం స్టార్ట్ చేస్తూ ఉన్నామో ఈ ప్రోగ్రాంలో ప్రతి 104 వాహనంలోనూ కూడా ఒక డాక్టర్ కూడా వెళ్తారు. ఆ డాక్టర్ ప్రతి గ్రామానికి నెలకి ఒకసారి కాదు, నెలకి 2 సార్లు కనీసం వెళ్ళేలా, నెలకి 2 సార్లు ఒక్కొక్క మండలంలో అయితే నిన్న గౌరవ ముఖ్యమంత్రి గారి దగ్గర జరిగినటువంటి ఈ ప్రెజెంటేషన్లో ఒక్కొక్క మండలానికి అయితే 3 సార్లు 4 సార్లు కూడా ఈ మొబైల్ మెడికల్ యూనిట్ వెళ్ళి 104 వాహనం వెళ్ళేలాగా కూడా మరి ప్లాన్ చేయటం జరుగుతూ ఉంది. ఈ విధంగా ఉండటం వల్ల ఏదైనా ఒక గ్రామానికి దానివల్ల అడ్వాంటేజ్ ఏంటంటే, ఒక గ్రామానికి ఒక వాహనం వెళ్ళినప్పుడు ఆ పిహెచ్సి డాక్టర్ ఒక ఫ్యామిలీ డాక్టర్గా మారుతాడు. ఎందుకంటే ఆ డాక్టరే ఫ్రీక్వెంట్గా రెగ్యులర్గా ఆ డాక్టరే వెళ్ళటం, ఆ డాక్టరే వాళ్ళకి కావాల్సినటువంటి జ్వరం వచ్చినా లేకపోతే ఇంకొక ఇబ్బంది వచ్చినా వాళ్ళకి ఆ ఫాలో అప్ చేయటం కానీ అవన్నీ కూడా ఒకే డాక్టర్ వెళ్ళటం వల్ల ఆ పేషెంట్కి కూడా ఎంతో ఉపయోగకరంగా ఉంటుంది. ఇంచుమించు ప్రతి కుటుంబానికి కూడా ఒక ఫ్యామిలీ డాక్టర్ ఉన్నటువంటి విధంగానే మనం ఏ విధంగా ఒక ఫ్యామిలీ డాక్టర్ని ఏర్పాటు చేసుకుంటామో అదే విధంగా ప్రతి పేద మధ్య తరగతి గ్రామీణ ప్రాంతాల్లో నివసించేటువంటి ప్రజలందరికీ కూడా ప్రతి కుటుంబానికి కూడా ఒక ఫ్యామిలీ డాక్టర్ ఉండాలన్న ఆలోచనతో ఈ ఫ్యామిలీ డాక్టర్ కాన్సెప్ట్ను త్వరలోనే ఆ కార్యక్రమాన్ని కూడా మనం ప్రారంభం చేయబోతా ఉన్నాం. ఈ విధంగా అనేకమైనటువంటి కార్యక్రమాలు 108 కార్యక్రమానికి సంబంధించి అంతకుముందు ఆ కార్యక్రమం ఏ విధంగా మరి వెనుకబడిపోయిందో మనం చూసాం. గత ప్రభుత్వాల నిర్లక్ష్య వైఖరి కారణంగా 108 వాహనం అంటే ఎక్కడైనా ఒకరికి ప్రమాదవశాత్తు ఎవరికైనా యాక్సిడెంట్ జరిగితే గంటకో 2 గంటలకు ఆ మనిషి దురదృష్టవశాత్తు చనిపోయిన తర్వాత కూడా 108 వాహనాలు వెళ్ళేటువంటి పరిస్థితిని మనం చూసాం. ఆ 108 వాహనాలను కూడా రాష్ట్ర వ్యాప్తంగా మరి దాదాపుగా మరి 600 నుంచి 700 వరకు కూడా మనం ఆ వాహనాలను కూడా మనం పెంచుకుని ఇప్పుడు ఎక్కడ విత్ ఇన్ 20 మినిట్స్లో కాలు వచ్చినటువంటి 20 మినిట్స్ లోపు ఆ వాహనం కూడా ఎంత దూరంలో ఉన్నా కూడా ఆ వాహనం కూడా వెళ్ళేటువంటి విధంగా మనం ఆ కార్యక్రమాన్ని తీర్చిదిద్దడం జరిగింది. ఇప్పుడు ఇవన్నీ కూడా మీ దగ్గర ఎందుకు ప్రస్తావిస్తూ ఉన్నానంటే, ఇప్పటి వరకు వైద్య ఆరోగ్య రంగానికి ఒక పరిమితమైనటువంటి పరిధి ఉంది. ఇప్పుడు ఆ పరిధిని గ్రామీణ ప్రాంతాలకు, ఏజెన్సీ ప్రాంతాలకు, మారుమూల ప్రాంతాలకు కూడా విస్తరింప చేస్తూ ఎక్కడైతే నగరాల్లోనూ పట్టణాల్లోనూ ధనవంతులు కానీ వారందరూ కూడా ఏ విధమైనటువంటి వైద్యం, వారికి ప్రాణాపాయం వచ్చినా, ఎటువంటి ఖరీదైనటువంటి జబ్బులు వచ్చినా కూడా వారు ఏ విధమైనటువంటి వైద్య సేవలు పొందుతూ తిరిగి క్షేమంగా ఇళ్లకు వెళ్ళి వారి పిల్ల పాపలతో సుఖశాంతులతో వాళ్ళు జీవిస్తూ ఉన్నారు. అదే విధమైనటువంటి పరిస్థితిని ప్రతి పేదవాడికి, పేద కుటుంబానికి అందజేయాలన్న ఒక పవిత్రమైనటువంటి లక్ష్యంతో గౌరవ ముఖ్యమంత్రి జగన్మోహన్ రెడ్డి గారు చేస్తున్నటువంటి ఆ సేవలకు మీరందరూ కూడా IMA తరపున మీరందరూ కూడా గతంలో ఇచ్చినటువంటి ఆ సహకారాన్ని భవిష్యత్తులో మరింత ఎక్కువగా అందజేయవలసినటువంటి అవసరాన్ని మీకు గుర్తు చేయటానికి, ఆ విధంగా మీకు విజ్ఞప్తి చేయడానికి ఈరోజు ఈ ప్రస్తావన చేశానన్న విషయాన్ని నేను మీకు మనవి చేస్తూ ఉన్నా. తప్పకుండా ఈరోజు IMA తరపున మీరు మా దృష్టికి తీసుకొచ్చినటువంటి ప్రతి ఇష్యూని కూడా తప్పకుండా దాన్ని సాల్వ్ చేయడానికి నా వంతు సహకారం ప్రభుత్వం తరపున ఇప్పుడే కాదు భవిష్యత్తులో మరొక విషయం ఏదన్నా వచ్చినా కూడా ఆ ప్రతి ఇష్యూను సాల్వ్ చేసేటువంటి అంశంలో నా సహకారం, ప్రభుత్వ సహకారం ఎప్పుడు ఉంటుంది. మా వల్ల కానటువంటి అంశాలు ఏదన్నా ఉంటే దాన్ని గౌరవ ముఖ్యమంత్రి గారి దృష్టికి తీసుకువెళ్ళి ఆ విధంగా ఆ సమస్య పరిష్కారం చేయడానికి కూడా మా వంతు సహకారం అందించడానికి మేము ఎప్పుడూ సిద్ధంగా ఉంటామని మరి IMA సంస్థకు తెలియచేస్తూ మీ సహకారాన్ని కూడా ఎందుకంటే ప్రభుత్వం ప్రజారోగ్య రంగానికి ఇన్ని వేల కోట్ల రూపాయలు, దాదాపుగా ఒక మెడికల్ కాలేజీలకే దాదాపుగా 14,000 కోట్ల రూపాయలు వెచ్చిస్తూ ఉన్నామంటేనే ఈ ప్రభుత్వానికి ప్రజారోగ్యం పట్ల, పేద ప్రజల ఆరోగ్యం పట్ల, ప్రజల ప్రాణాల పట్ల ఎంత అంకిత భావం ఉందో గౌరవ ముఖ్యమంత్రి గారికి ఎంత చిత్తశుద్ధి ఉందో మిమ్మల్ని అందరినీ కూడా అర్థం చేసుకోమని, కోవిడ్ పాండమిక్ సిచ్యువేషన్లో ఏ విధమైనటువంటి సేవలు త్యాగాలకు మీరు చేయటానికి ముందుకు వచ్చి రాష్ట్రంలో చేస్తున్నటువంటి కార్యక్రమాలకు సంబంధించి కోవిడ్ సమయంలో, ఎందుకంటే ప్రత్యేకంగా కోవిడ్ సందర్భాన్ని నేను ఎందుకు ప్రస్తావిస్తూ ఉన్నానంటే మీకు అందరికీ కూడా తెలియంది కాదు, కోవిడ్ మేనేజ్మెంట్ విషయంలో మన ఆంధ్రప్రదేశ్ రాష్ట్రం భారతదేశంలో ఉన్నటువంటి మిగిలినటువంటి అన్ని రాష్ట్రాలకు కూడా ఆదర్శంగా నిలిచింది అంటే అందులో మీ డాక్టర్స్ పాత్ర ఎంత ప్రముఖంగా ఉందో నేను ప్రత్యేకించి చెప్పక్కర్లేదు. ఈరోజు టెస్టులకు సంబంధించి దాదాపుగా 3 కోట్లకు పైగా మనం టెస్టులు చేసామన్నా, 5 కోట్లకు పైగా మనం వ్యాక్సినేషన్ కార్యక్రమాన్ని ఈ రాష్ట్రంలో పూర్తి చేసుకున్నామన్నా కూడా ఈరోజు థర్డ్ వేవ్ని ఎదుర్కొనటానికి కూడా మనం ఇంత సంసిద్ధంగా ఈరోజు దేశవ్యాప్తంగా ఎలా ఉన్నా కూడా థర్డ్ వేవ్ వచ్చినా రాకపోయినా వస్తే కనుక దాన్ని ఏ విధంగా సమర్థవంతంగా గతంలో ఏ విధంగా మన ముఖ్యమంత్రి గారి మార్గదర్శకత్వంలో ఏ విధంగా కోవిడ్ని ఎదుర్కొన్నామో అంతకన్నా సమర్థవంతంగా కోవిడ్ని థర్డ్ వేవ్ గనక ఒకవేళ వస్తే దాన్ని కూడా ఎదుర్కొనటానికి మనమందరం కూడా సన్నద్ధమవుతా ఉన్నాం. ప్రభుత్వం కూడా పూర్తి సన్నద్ధంగా ఉంది. దానికి సంబంధించి కూడా మీ అందరి సేవలు గతంలో ఏ విధంగా అందించారో అదే విధమైనటువంటి సహకారం ప్రభుత్వానికి కూడా అందజేయమని మీ అందరికీ కూడా మరి IMA సభ్యులందరికీ కూడా సవినయంగా మనవి చేస్తూ, మరి ఈరోజు IMA లైఫ్ టైమ్ అచీవ్మెంట్ అవార్డ్స్ కూడా తీసుకుపోతూ ఉన్నారు మన డాక్టర్స్. మరి నాకు జగన్మోహన్ రావు గారు, మరి ఆయన నాకు ఒక విధంగా మా కుటుంబానికి ఆయన ఫ్యామిలీ డాక్టర్. ఆయనకి సంబంధించి మరి నేను నా చేతుల మీదుగా ఈరోజు అవార్డు ఇవ్వటం నేను చాలా నా అదృష్టంగా భావిస్తా ఉన్నాను. అదేవిధంగా మరి మీ పెద్దలు సమరం గారు, ఆయన కూడా ఈ రాష్ట్ర వ్యాప్తంగా ఆయనకి మరి వైద్య రంగంలో ఎంత పేరు ప్రఖ్యాతులు ఉన్నాయో మనకందరికీ కూడా తెలుసు. ఆ విధంగా సమరం గారికి, అదేవిధంగా మరి అశ్విని కుమార్ గారు, ఆయన గురించి కూడా ఇందాకే నాకు మన వాళ్ళు చెప్తా ఉన్నారు. బందర్లో జనరల్ ఫిజిషియన్గా మరి ప్రాక్టీస్ చేస్తూ ఎంతో మందికి ఆయన మరి వైద్యం పరంగా ఎన్నో సేవలు అందిస్తూ ఉన్నారు. ఈ వయసులో కూడా మరి ఇక్కడ ప్రాక్టీస్ చేస్తూ మరి అశ్విని కుమార్ గారు కూడా ఇంతమంది ప్రముఖులకు ఈరోజు మరి IMA లైఫ్ టైమ్ అచీవ్మెంట్ అవార్డ్స్ ఇవ్వటం కూడా మరి ఇంతమంది పెద్దలకు, ఇంతమంది సీనియర్ డాక్టర్స్కి ఇవ్వటం కూడా నా అదృష్టంగా భావిస్తూ వారందరికీ కూడా నా హృదయపూర్వకమైనటువంటి శుభాకాంక్షలు, అభినందనలు తెలియజేస్తూ ఈరోజు మరి ఈ కార్యక్రమంలో నాతో పాటు ఈ డాష్ పైన ఉన్నటువంటి ఆల్ ఇండియా మెడికల్ అసోసియేషన్ రిప్రజెంటేటివ్స్, అదేవిధంగా ఈ కార్యక్రమానికి హాజరైనటువంటి అటెండ్ అయినటువంటి డాక్టర్స్, స్టూడెంట్స్ అందరికీ కూడా నా ధన్యవాదాలు, కృతజ్ఞతలు తెలియజేస్తూ ఈరోజు ఈ కార్యక్రమం ద్వారా ఈ కొన్ని విషయాలు మీతో పంచుకొని మా అభిప్రాయాలు మీతో షేర్ చేసే అవకాశం ఇచ్చినటువంటి IMA సభ్యులకు వారందరికీ కూడా నా హృదయపూర్వకమైనటువంటి కృతజ్ఞతలు తెలియజేస్తూ మరొక్కసారి శ్రీనివాసరాజు గారికి, నూతన ప్రెసిడెంట్కి నా హృదయపూర్వకమైనటువంటి శుభాకాంక్షలు తెలియజేస్తూ మా సహకారం ఎప్పుడూ మీకు ఉంటుందని ప్రభుత్వం తరపున, మా తరపున కూడా మా సహకారం ఎప్పుడూ మీకు ఉంటుందని తెలియజేస్తూ మరి సెలవు తీసుకుంటూ ఉన్నాం.
It is almost spellbinding message by the Honorable Health Minister, sir. I request our national leader, the vibrant speaker, the passionate for about the IMA, and our beloved president of IMA headquarters, Dr. J. Jailal, sir, to give his keynote address and also involve me in the oath.
Beloved and distinguished leaders of Indian Medical Association, the newly installed president of the Andhra Pradesh state, my good friend Dr. Srinivasa Raju, the chief guest of this day, the Honorable Deputy Chief Minister and the Minister of Health of the Andhra Pradesh state, the World Medical Association Treasurer and the past National President, Dr. Ravi Vangetkar, sir, the immediate past President of IMA Andhra Pradesh, Dr. Subramaniam Garu, my good friend and the beloved president of the AMS National Chairman, Dr. Sri Hari Rao, the distinguished leaders of Indian Medical Association of Andhra Pradesh, and my dear guests. I'm extremely happy and delighted to be with you at this moment, representing the Indian Medical Association, the largest professional body of the modern medical doctors in this country. As I stand here, that Indian Medical Association very vividly remember when we were fighting for the safety of our doctors' fraternity. It was only one chief minister we had at that time who was bold enough to come forward in support of the doctors and the healthcare professionals and declared the Health Professional and the Professionals Protection Act is none other than our own doctor, Dr. Rajashekar Reddy sir, who was then the Prime President, Chief Minister of the Andhra Pradesh state. The way in which he started the Arogya Shri is the first of its kind in the whole country, which has now resulted in developing with a lot of insurance scheme. So always after Dr. B.C. Roy, we remember with gratitude Dr. Rajashekar Reddy sir for being the wonderful chief minister of this state and helping the medical fraternity in all this way. But following him, I'm so happy the chief minister of Andhra Pradesh, Shri Jagan Mohan sir, is extremely doing good things in the country and the state, both helping the medical fraternity and the doctors of this state. An Honorable Deputy Chief Minister, we normally get a lot of complaints from the state, from our medical doctors. But I'm so happy we do not get complaints from the doctors of Andhra Pradesh because you are taking care of them very effectively and very boldly you are doing things. I was told that the innovative ideas with which you are starting the various programs in this state, we wholeheartedly thank you. And we believe the medical fraternity and the government, if it is joined together and working together, definitely the country can go forward. The health of this country depends upon the health of the professionals. If the professionals of this healthcare delivery system are not happy, not being supported, not being taken care, I'm sure that will not be resulting in the good health of this country. So it's a most important mantra for the development and the health of this nation is always to keep the health of the professionals at the better way and protect you of this way. I know for sure this Andhra Pradesh has led us a lot in the Indian Medical Association. We always used to come to Hyderabad and stay in a very palatial IMA building, which IMA Andhra Pradesh they used to enjoy. At the moment I enter into Andhra Pradesh IMA, asked for what is your new building. They said still they are waiting from the government to get the support. I'm sure Honorable Minister and the Deputy Chief Minister will be assuring as a newborn baby of this state for the 6 years old. Definitely would like to have a wonderful palatial infrastructure building for its own. I'm sure the government will support and the doctors and Srinivasa Raju sir before his term is over. Though maybe may not be as a president, but at least as an immediate past national president, I will have the privilege to come and participate in the inaugural function of that building of the Andhra Pradesh, which I am looking forward. Especially on this year of that the Indian Medical Association is marching towards the centenary year. We are now on the 93rd year of existence since 1923. As we are aiming for the centenary year in 2027, it is my dream and vision that every branch and every state shall have its own building. This building of Indian Medical Association is not for the sake of just having a house, but it is a house of infusing confidence and building the infrastructure and the non-academic medical education skills like administrative skill, lifestyle skills, and the cognitive skills to the doctors of this fraternity. But I believe that when a doctor is getting the knowledge, it will not stop short with the doctor. Definitely it will percolate to the community. Then ultimate beneficiary, always when a doctor is given a knowledge, is the community. When a doctor is given with a new skill and a new knowledge, and definitely the patient who is coming with the doctor is going to get benefited. And that ground, I'm sure as a social responsibility and the social public welfare, the government of Andhra Pradesh will definitely come forward and build a new paradigm or the new palace for the Indian Medical Association of Andhra Pradesh. I do remember with gratitude the great service done by Dr. Gangadhar Rao, the man who was serving as a national vice president of Indian Medical Association, who was leading the COVID registry of Indian Medical Association, who has calculated and meticulously dotted all those members who have suffered and deceased due to the COVID and he has prepared a list of nearly 1,900 doctors of this country who has died due to the COVID. Unfortunately, he himself has succumbed to that disease. And it is our responsibility as a family Indian Medical Association to take care of these, all those our doctors who have succumbed their life for the COVID in a pandemic. I'm sure the government of India has come forward and supported them with 50 lakhs rupees. But unfortunately, in the struggle or the bottleneck of the insurance, not even 1/10 of these doctors were able to get the benefit. In the Andhra Pradesh, I know that more than 80 doctors has died because they were very actively and proactively serving for the country and bravely taking care of the COVID patients. I appeal to Honorable Deputy Chief Minister that it is our duty to see to that these doctors are honored as a martyrs of this country. We do not ask only the financial help, but we appeal to the government to declare them as a martyrs, the soldiers and the brave people who have served this country with a great attitude. When India was facing the Kargil war, we lost only 400 people. All those people were honored as a Kargil martyrs. But unfortunately, in this country, this doctor community is not being recognized adequately for the government service which they have rendered to the society. I'm so happy to know that our Honorable Deputy Chief Minister was announcing of the family medicine concept, which is the priority area which Indian Medical Association is also working towards. We do not believe in only the super speciality, but we believe in the family medicine concept. A doctor in the village, a doctor in the society who will be taking care from the birth to death of an individual and the womb to tomb care for the individual. A comprehensive and the community oriented individual care will be given by the family medicine concept. I'm extremely delighted the government of Andhra Pradesh is thinking on that line, and the reincarnation of the family medicine concept in this country. That is a great step they are taking in the forward of the welfare of the country's healthcare. I'm so happy to note Dr. Srinivasa Raju was announcing that he is going to implement a plan of save the resuscitation work or the CPR, the resuscitation training to be offered to entire medical fraternity. I must tell Dr. Srinivasa Raju sir, before you are incorporating Dr. Chakra, I have already nominated him for the national team. So I have hijacked you from your Andhra Pradesh. Now he is heading the national, the resuscitation council. I know for sure that the way in which the interest with which that he is working on that, and definitely that he will be doing a great job. One thing Indian Medical Association believe is on a two new category of the people is the women doctors and the young doctors. And we believe and we firmly noted the women doctors like Dr. Ramani, Dr. Vani, Dr. Padmavati, all these people are doing a human service to the country. The way in which they are serving and motivating and stimulating the healthcare delivery system from the front line is remarkable. So Indian Medical Association wants to support and encourage Srinivasa Raju sir to make sure that 30% reservation is not only in the constitution, but also in the power and the letter and spirit. In every branch and every central working committee and every area, the women doctors should be encouraged and they should be supported. They should be promoted to come to the stage and occupy the chair. Because I have seen that wherever the women doctors has occupied the president or secretary's chair, something they are doing marvelously. Either they are building their house, building their branch, or making some monumental project. So I appeal to the Andhra Pradesh state also to see to that someday that one of your lady doctors should also occupy the chair of the state presidentship. Now in the state we have only Orissa, we have a state president, and then next year Haryana state president is going to be the lady. But we would like to see that many more people are coming. Equally, we have seen that people with less than 40 years, and throughout the country, we have the nearly 200 doctors, less than 40 years, occupying the president or secretary post of the branches. We had a program on November 14th calling the National Yuva Doctors Day. We honored them individually because I believe the investment which we are putting on this youth and investment we are putting on the young leaders will definitely help us the country to go forward and go with much more outreach and benefit to the Indian Medical Association, the fraternity. Two important flagship program I must just want to enlighten and help us to, help the Andhra Pradesh state to take it forward is a Safe Motherhood and Swayam project. The Safe Motherhood, we believe that no one in this country should have the sufferings due to anemia or nutritional disorders. and they should have the facility to have the healthy delivery infrastructure systems. I'm sure the government of Andhra Pradesh is extremely taking care for the woman with the pregnancy to get the safe delivery, and IMA should come forward and proactively support the hands of the government of Andhra Pradesh to establish that every man, woman in this Andhra Pradesh should have a safe delivery, safe motherhood, and they should get the nutritional support to overcome the disease. The second most important thing, the project which we have started is a Swayam project. Swayam is a self-help project in which now one of the two major incidents of the cancer which is affecting the woman are the breast cancer and the cancer of the cervix. The breast cancer can be diagnosed early if the woman is taught how to do the self-breast examination. Unfortunately, this small technique or art of self-breast examination and identifying a lump in the breast is not made known to the people. It is the responsibility of the Indian Medical Association doctors, women doctors, and the branches to see to that every woman of this country, every woman of your state is given the art of self-examination of the breast, and so that they will be able to early identify the breast cancer, that we will be able to give the complete cure. Equally, the cure of the cervical cancer. This is very high prevalent here. Next to CA breast, we are having a lot of cases of cancer cervix. And if we have an opportunity for them to do the pap smear examination and also provision for the vaccination against the cancer cervix, that is the only cancer where we can prevent is by vaccination is a cancer cervix. I am sure that IMA Andhra Pradesh will also take up this project of the safe motherhood and Swayam project so that we will be able to go forward. Finally, I will be also only requesting the Andhra Pradesh state to see to that, do not just involve in the professional development of the doctors, but also the overall well-being of the doctors. For that, we need two things. One is a cultural activity and the sports activity. And very recently, we had in the Nasik, the IMA Olympiad, 1,200 doctors across the country participated in that and had a phenomenal success of the 4 days program. I'm sure Srinivasa Raju sir will also in his tenure will conduct a state level Olympiad like event in Andhra Pradesh to encourage our doctors to keep healthy and also to encourage Dr. Padmavati and various other people are involved in the cultural program. You will be always do that. Indian Medical Association headquarters, we assure Dr. Srinivasa Raju sir, we are with you. All the projects which was enlisted as very, very reasonable. I think it is very fortunate you have brought in the Deputy Chief Minister. I think he has also assured many of your project to be shall. It is only I'm sure the Honorable Deputy Chief Minister will be able to do that within a short time, especially on that the allotment and the encouragement of the emergency care and all the other benefit. Finally, I just also request the Deputy Chief Minister, because one of the big requests he has made is the Clinical Establishment Act and the exception on the fire safety and the problems, especially the small care hospital, less than 25 beds. We need to extremely be patient and passionate towards them to give some concession to them and support them in all the possibility. Friends, I'm here happy to see a lot of medical students are here. They are the future of our country. They are the people who are going to help the Indian Medical Association and the fraternity in a larger way. All of us, if we can join together and help us each other, I'm sure that definitely we will be able to do a greater service to the country. It is not for the benefit of Indian Medical Association or the doctors alone. It is for the welfare of the community. It is welfare of the country. I appeal to the members of Indian Medical Association. You should all feel that IMA is your family. The word IMA should bring adrenaline to your body. You should feel that you possess this, you own this, it belongs to you. It is not a someone else's body, it belongs to you and invokes you. It is the participatory democracy, is the part of the IMA, and you all should be able to do that. I'm sure we let us all work together and consciously bring health to the nation, health to the community, and whatever the way you need the support, National Indian Medical Association will be with you, support you and encourage you. I must also say thanks to Dr. Subramaniam sir and the team for the excellent work. Let us give a big clap for the tremendous job run by Subramaniam sir, being a neurosurgeon. I think even in the COVID pandemic, the way in which he has served the country and served the Andhra Pradesh state is innumerable. I'm sure that he will get the best state president award in the days to come because of his excellent work he has done to the society. Thank you very much. Thanks for all this wonderful hospitality you are rendered to us.
Sir, it is a great occasion and also it is a fortunate on behalf of IMA AP State and Organizing Committee to felicitate and also awards, Lifetime Achievement Awards to the great clinicians, Dr. Yarlagadi Jagan Mohan Rao Garu and Dr. Goparazu Samram Garu and Dr. A. Ashwini Kumar Garu and Dr. N. Apparao Garu.
డాక్టర్ వై జగన్మోహన్ రావు గారు 15/1/1940 పెదమద్దాలి అనే చిన్న గ్రామం నందు ఒక కాంతి బింబం కనిపించింది. అదే మన డాక్టర్ వై జగన్మోహన్ రావు గారు. వారి హాస్పిటల్ శ్రీ బాలాజీ నర్సింగ్ హోమ్, అది వైద్యాలయం, రోగుల పాలిట దేవాలయం. అయ్యా, మీ సేవలు నిరుపమానం, మీ సహనం అసమాన్యం. మీ శ్రమకు విలువ కట్టే షరాబు లేడు, మీ త్యాగాన్ని స్మరించని రోజూ లేదు. ఆగిపోయే ఊపిరిని నిలిపే దైవం మీరు. ఎందరెందరికో ప్రాణభిక్ష పెట్టి చిరునవ్వుతో ధైర్యం నింపే మరో మహనీయుడు మీరు. అందుకే అందుకోండి ఈ జీవనకాల సాఫల్య పురస్కారం. మీకోసం మీ ఐఎంఏ డాక్టర్ సి శ్రీనివాసరాజు గారు, ప్రెసిడెంట్ ఐఎంఏ ఏపీ స్టేట్, డాక్టర్ ఎన్ సుబ్రహ్మణ్యం గారు, నందకిషోర్ గారు, సుభాష్ చంద్రబోస్ గారు, విజయభాస్కర్ రెడ్డి గారు, సుబ్బారావు గారు. డాక్టర్ గోపరాజు సమరం 37/1939 ప్రబోధ ప్రభాకరుడై ఎవరినో వెలిసిన దేవుడు. స్టెథోస్కోప్ కంఠాభరణంగా ధరించిన వాడు, సృష్టికి ప్రతిసృష్టి చేయగల వ్యక్తి, వ్యాధులపై మందులతో సమరం చేసినవాడు, చూపులతోనే రోగం మాయం చేసినవాడు, స్పర్శతోనే ప్రాణం పోసినవాడు, నిద్రాహారాలు లేని జీవితం గడిపినవాడు, మానవత్వంతో వైద్యం అందించినవాడు, రోగుల సేవకి అంకితమై వ్యాధులపై అలుపెరగని పోరాటం చేసినవాడు, సమర శంఖారావం పూరించి సమస్యలను ఛేదించినవాడు మన డాక్టర్ గోపరాజు సమరం గారు. అందుకోండి ఈ జీవనకాల సాఫల్య పురస్కారం. మీకోసం మీ ఐఎంఏ. డాక్టర్ అశ్విని కుమార్ గారు 26/11/1936 పువ్వు పుట్టగానే పరిమళించును కదా అన్న రీతిలో తన జీవితాన్ని నిస్వార్థ సేవకే వినియోగిస్తూ వైద్యం అంటే ఒక వృత్తిగా కాక మనుషుల్ని బ్రతికించే ఒక మహాశక్తిగా సేవలు అందించిన వైద్యుడు, నవ సమాజానికి నిజమైన హీరో, కష్టకాలంలో ఎందరికో ప్రాణభిక్ష పెట్టిన రాముడు, నడిచొచ్చే దేవుడు, మానవ మహనీయుడు, కష్టకాలమందు ఇష్టదైవంగా ఖ్యాతి గడించిన వ్యక్తి, తన నడవడికతో లెక్కలేనన్ని అవార్డులు రివార్డులు సాధించిన వ్యక్తి, తన పలకరింపుతోనే పులకరించి ఎందరెందరికో దైవంగా మారిన వ్యక్తి మన డాక్టర్ అశ్విని కుమార్ గారు. అందుకోండి ఈ జీవనకాల సాఫల్య పురస్కారం. మీకోసం మీ ఐఎంఏ. Sir, okay, Sir, today we had two orations. I request Honorable Health Minister Garu to hand over the medals to the orators. May I request Dr. P.V. Sudhakar Garu, Principal, Andhra Medical College, to receive a medal for Dr. Gurumurthy Memorial Oration. I request Dr. Shankar Mahadev Garu to receive his Dr. Peri Sastry Oration Medal from the Honorable Deputy Chief Minister Garu. Dr. Shankar Mahadev Garu, please. Srinivasaraju garu take over.
I may not be here till that time. Please, your attention, please. Your attention, please. అందరు కూర్చోండి అమ్మా, జస్ట్ కాసేపు కూర్చోండి, జస్ట్ కూర్చోండి అమ్మా, అందరు కూర్చోండి. Dr. Ravi Wankhedkar is a great, not only farmer, he is a reformer and also performer. He is such a nice gentleman, coming all the way from the Nagpur and also from various places he have visited in previously, in 2 days back also. He came with literally with a lot of pain. I must extend my hearty thanks to the Raviji sir for gracing this occasion and blessing me on these auspicious times. I request Ravi Wankhedkar ji to extend his blessings and also message to the medical fraternity here.
May I request the both past test presidents, Dr. Tyagaraja Reddy and Dr. Bal Maiya, to please be seated so that all others will be set. My young friends, please be seated. I know the main hero has gone, the Deputy Chief Minister, and your hero, Srinivas Raju, is installed. So today's function that way is over. But still, my humble request to kindly spare some time. My brother, and for whom the main reason I traveled nearly 2,000 kilometers to see that he is installed as the president of Andhra Pradesh, a very, very studious gentleman. I came in his contact when he was HBI chairman of Andhra Pradesh, and I was the National Secretary of Hospital Board of India. And I found that the contributions, the suggestions, the original ideas which Dr. Srinivas Garu always gave was wonderful, and I am very sure that his contributions will continue not only to the state of Andhra Pradesh, but also to the national headquarters. Very learned. Is it an indication that I should stop, my dear sound person? Thank you. A very learned, dynamic national president, my brother, and who has really led the fraternity in very difficult times, the national president, Professor Jailal sir, the very sincere and hardworking outgoing president who has done a yeoman service in COVID period of Andhra Pradesh, Dr. Subramaniam sir. The second reason why I am here is because Andhra Pradesh has two living legends, one Dr. Apparao Garu and one Dr. Samaram Garu. And I always have seek their blessings and have seek their guidance to whatever I have become. And thirdly, as mentioned by our national president, it was Dr. Y.S.R. Reddy, who was a great visionary and great friend of the medical fraternity, who started first the act against violence against doctors and Arogyashri. And now because of his vision that time in 23 states, we are having the same act as ad verbatim that enacted in Andhra Pradesh. My learned brother, the AMS chairman, Dr. Sri Hari Garu, the state secretary, Dr. Nanda Kishore, my very good and old friend, the state finance secretary, Dr. Subhash Chandra Bose, the outgoing vice presidents, my another very good friend, Dr. Fanindar, Dr. R.K. Raju, Dr. Parthasarathi Reddy from Tirupati, the new incoming presidents, another vice presidents, another very good friend, Dr. Anil Kumar, Dr. Ramani, Dr. Krishna Teja, all the vice presidents, all the past state presidents, Dr. G.S. Murthy, Dr. Tyagaraja Reddy is there. Yes, I really appreciate, sir. You have always worn this dhoti. I'm proud of this, your dress, sir, always. Hence, I will never forget you. Yeah. Dr. Bala Madhaiya, Dr. Ashok, I think he has left. Yeah. Dr. V.S. Prasad, my dear friend from Tirupati, Dr. Subramaniam, the past state secretary, Dr. Murthy, our TB coordinator, Dr. Sharma, and so many other friends. It is indeed a great pleasure to be with you on this auspicious occasion. And after very rightly put forth by our dynamic national president, Dr. Jailal sir, I would just like to say a few things. Of course, I should not forget to seek the blessings of Dr. Ashwini Kumar and Dr. Jagan Mohan also, who have been today honored with the Lifetime Achievement Award. But sir, this is just a beginning. Please keep your blessings on our brother Srinivas Raju and your guidance also. That is very important. The Telangana State President, my very old and good friend, Dr. G. Sampath Rao. IMA has now transitioned in last few years from an NGO to a trade union like activities. The golden era of medical practice is over. The media assaults us, the administration assaults us, the politicians assaults us, the government assaults us. And hence, the trade union like activities have now become a must. And hence, you must have seen the brand IMA is now taken notice of. Few years back, IMA had to give paid advertisements spending lakhs of rupees to put forth our point of view. But last few years, you must have seen that media seeks bites what our national president has to say. Media seeks bite what your state president has to say. Media seeks what Vijayawada president has to say. This is the now strength of brand Indian Medical Association. And that has been achieved only and only because of efforts of the common IMA members, our leaders who have sacrificed their time, energy, money. But no doubt this is an improvement. But we have a long way to go, friends. Today we are in a reactive phase. Government formulates fire policy and then we go to the minister or do an agitation saying that this is detrimental, kindly change it. IMA needs to achieve that stage where we are proactive. The government, whether it is a local government, whether it is a state government, or whether it is a union government, they need to consult Indian Medical Association first before formulating any health-related policies. This is widely practiced in all the entire Western world. May it be American Medical Association, may it be British Medical Association, may it be German Medical Association. Any health-related policy first is discussed with their National Medical Association and then it is promulgated. No doubt, yesterday we were not taken note of. Today we are at least taken notice of. But golden day will come when the government, before formulating any law, will first discuss with the largest stakeholder, that is our mother organization, Indian Medical Association. And that can be achieved only and only if we present a united face, my dear friends. Too often we fight for very small things amongst ourselves. On small posts, on small awards, on a position on stage, on a felicitation. While our fight should be directed towards the external threats against our medical profession. Unless and until we present a united face, we are not going to achieve it. But our young doctors, everywhere in the country, I am seeing young leadership coming up under the guidance of the senior leaders. And that brings lot of hope. It is the youth who are going to change not only this country, but the Indian Medical Association also. And definitely that day is not far away when the government of the day, any government, will have to take our viewpoint first before making any law. And that is necessary for the good health of this country, for the health of the common man, to provide affordable, accessible 24/7 quality healthcare. And that is the aim of Indian Medical Association. Indian Medical Association not only fights for its own members, but our bounden duty is towards the health of common man. And hence, I am very sure, under the leadership of Dr. Srinivas Raju, we will be able to convert our problems into community problems. Why we are fighting against the Clinical Establishment Act? It is not our problem. It is the problem of the patients. How costly the health service is going to be. If we try to implement all the norms of the fire department, the small and medium-sized hospitals will collapse. Today, as such, 3.3% population is pushed below poverty line because of medical expenses. Imagine how much multiplication will be there on the health expenses if all these laws are to be implemented. Hence, convert our problems into problems of common people. That is going to, unless and until we take the community along with us, we are not going to succeed. And I'm very sure leaders like Srinivas, Raju, his secretary, finance secretary, and once again, I also congratulate Eluru branch, the entire organizing committee. Of course, Srinivas Raju was the chairman, but the secretary Vijay Bhaskar Reddy, Satyanarayan Garu, everyone. This is a proud moment for their branch. And I can tell you, because I also come from a very small branch, small place. And every one of the branch feels that they are the state president. Our national president also comes from a small branch. And every one of us, every one of them feel very proud. And I always say, the strength of Indian Medical Association is its local branches. This is a very loaded and very true statement after my experience. The strongest is our local branch, then the state branch, and then the headquarters. Because you people give us a strength. Whatever we may decide, ultimately it is through the state local branches have to implement. So I'm very happy and thankful to the national president that he has empowered the local branches. He has taken forward the MSN, JDN, Women Doctors Wing. Why we are focusing last few years on women doctors? 50% of the doctors are women doctors now, friends. There has been a feminization of medical profession. And unless and until we involve this 50% doctor population of women doctors and young doctors, IME is not going to gain strength. You can't leave 50% of your population, medical doctors population out of the organization. And very rightly appealed that very soon we should see Samaram Garu sir. Samaram sir. Next 5 years, there should be a woman president of IMA Andhra Pradesh. Once again, I congratulate Dr. Srinivas Raju sir. And I am very sure, not only sure, but I am damn sure that he is an ideologue. He provides ideas. It is from my personal experience for last 6-7 years. He will write a beautiful mail. He will say 1, 2, 3. These are the things. This is how it should be done. Hardworking. Taking time out of his busy ENT practice, writing down, thinking over it, and then penning it down. Very few, we are leaders, we just talk. But somebody has to sit there, apply their mind, and then give inputs. Of course, as a leaders, we cherish and we empower such leaders so that they come onto the national stage also and serve the medical fraternity and the community. Thank you for the hospitality. Thank you for the patient hearing. Jai Hind, Jai IMA.